pharmacogenomics, all with single-day turnaround time from biological specimen to variants. Use as little as 1 nanogram input of DNA or RNA and get ultra-sensitive, rapid and accessible results for clinical research in infectious disease. Targeted NGS with the Ion Torrent Genexus integrated sequencer lets you rapidly analyze microbial genomes for viral and bacterial typing, epidemiological studies, and disease surveillance. Get all the benefits of the ultra-high multiplex PCR technology clinical researchers and public health agencies use to assess infectious diseases, with the ease of hands-off, set-up-and-go NGS workflows with customizable gene panels. Where did the SARS-CoV-2 virus come from? How does the virus work? And how is it potentially being transmitted? Rapidly answer the time-sensitive questions in an epidemiological investigation of SARS-CoV-2 with an automated and easy-to-use NGS solution. In this race against time, survey the complete SARS-CoV-2 genome, including all serotypes, with over 99% coverage in just a single day. The Ion Torrent Genexus integrated sequencer and Ion AmpliSeq SARS-CoV-2 research panel provide the speed, accuracy, and ease of use necessary to quickly and efficiently get you the answers you need. Multiple applications, one fully integrated NGS system. Let us show you how the Genexus system can uncover answers to advance your research and further your mission to improve lives and health around the world.
inasumbua wanaume sana. Ni mtu personal ndo akiona amepimwa anakuwa na hiyo kauoga kusema kama vile nimepimwa hivi inaonekana nguvu zangu za kiume itaenda chini. Hiyo ni uongo.
Unapotajwa ugonjwa wa kansa au saratani humu nchini, jamii huanza kujiandaa kualikwa katika michango au harambee, huku waathiriwa wakijawa na hofu ya maisha kuona kwamba visa vingi vilivyoangaziwa vimedhihirisha watu waliolemewa na janga hili. Kulingana na taasisi ya kitaifa ya saratani humu nchini, saratani ndiyo kisababishi kikuu cha vifo humu nchini, huku kukiwa na zaidi ya visa 37,000 kila mwaka. Aidha, saratani ya matiti, ile njia ya uzazi kwa kina dada, saratani ya umio au koo na saratani ya kibofu ndizo sababu kuu za vifo humu nchini. Jina langu ni Kimani Karanja. Karibu tuangazie jinsi imani potofu imechangia katika kuepuka kupimwa saratani ya kibofu miongoni mwa wanaume katika kaunti hii ya Turkana.
Turkana anaamini kwa watoto wengi ni baraka. Kwa hivyo mimi kwa upande wangu naweza kataa kwa sababu tutapoteza hiyo watoto.
Katika kaunti hii ya Turkana, wanaume hasa umri wa makamu wameathirika kutokana na kupuuzilia mbali kupimwa kwa dhana kwa upimwaji wa saratani ya kibofu huenda ukasababisha ukosefu wa nguvu za kiume na hivyo kuathiri uwezo wa kuweza kupata watoto wengi na kuleta heshima katika jamii.
Kule kwa wazungu watoto 3 na hapa Afrika ni watoto wa 10-15 hasa sisi wa Turkana. Sasa kuna uwezekano inaweza angamiza Afrika. Naona kwa upande wangu kama kuna shida inaweza angamiza nguvu za mwanaume ili azisae watoto wengi. Kwa Waturkana kisa watoto wachache wewe una heshima. Waturkana anaamini kwa watoto wengi ni baraka.
Kuwa na bibi zaidi ya mmoja ni swala ambalo hudhihirisha hadhi na heshima katika jamii ya Waturkana, na jaribio lolote la kupima saratani ya kibofu kwa muda limeonekana kama tishio kwa uendelezwaji wa jamii, kama anavyosema Jeremia Nangolong ambaye ni mmoja katika baraza la wazee katika jamii hii.
Sasa uko hii wanawake yote, sasa hiyo ni kuongeza boma yako uwe na watoto wengi na uwe sipa uwe kwako. Ni tamaduni ya zamani, hiyo ni kitu ya zamani kwa sababu hiyo kitu ya kukuja kwa sasa.
Na japo dhana hiyo imekuwepo, kunao walioridhia kupimwa na wamekuwa wakiwapasha habari wanaosusia, jambo ambalo limekuwa kukwea mlima katika kaunti wanaotueleza James Angirupei.
Mimi naitwa James Lorot. Hii maneno ambayo inasumbua wanaume sana. Ni mtu personal ndo akiona amepimwa na anakuwa na hiyo kauoga kusema kama vile nimepimwa hivi inaonekana nguvu zangu za kiume itaenda chini. Hiyo ni uongo. Ukipimwa igundulike ya kuwa kuna ugonjwa imepatikana ndani, hiyo inakusaidia nguvu yako ambayo ilikuwa imeregea kurudi.
Cha kushangaza ni kuwa hata baadhi ya kina dada haswa walioolewa wamekuwa wakiwashauri waume zao kuhususia kupimwa, jambo ambalo analihakiki Mama Ekiru.
Mimi mwanamke ya Turkana nasikia hii maneno ya kupima mwanaume. Tunasikia tu hiyo kitu huko watu ya town huko wanaongea hiyo maneno hata sisi kama wanawake hatukubali wanaume yetu pimwe hiyo kitu. Mimi kama mwanamke ya sita unajua katika jamii yetu sisi watoto ni mali sana. Kwanza ukipata watoto ile wasichana ukipeana watu wanakupea ngamia, na pia wewe punda, na pia wewe ng'ombe, mbuzi. Sasa wakisema wapime mwanaume itapoteza hiyo nguvu ya kuzaa ya kupata watoto, na ukikosa watoto kama jamii yetu ni aibu sana.
Lakini kulingana na Mashandiki Baraka ambaye ni afisa afya katika kitengo cha Cancer Unit hospitali ya Lodwar mjini, dhana hii ni potofu na japo matokeo huenda yawe mabaya. Kutambua kwa mwanaume ana ugonjwa wa saratani ya kibofu husaidia katika kuweza kutibu kwa haraka. Na Baraka anasema kwa kupoteza nguvu za kiume si moja ya athari za kupimwa, bali kupima ni mwanzo wa mwanga ikiwa mtu atapatikana athirika.
Mimi kama mhudumu pinga hiyo dhana ambayo watu wamekuwa naye tangu kitambo ya kwamba ukipimwa utakosa ile nguvu za kiume. Ukitaka kujua kwamba uko na ile saratani ya kibofu, ikiwa kwa ile early stage yake unapata ugumu wa kukojoa. Na pia kitu kingine utapata kwamba kuna ile decreased force, kupungua kwa ile pressure ya mkojo. Unapata ya kwamba unaweza kuwa ulikuwa unakojoa pale mbali zaidi, lakini unapata ile pressure inapungua, unaweza jikojolea hapa ama hata ukojoe tu karibu mahali pale. Kitu kingine ni kwamba damu inaweza patikana ndaita kwa semen, unaweza detect uone kwamba kuna damu inapatikana pale katika semen. Na pia kutakuwa na ile discomfort au utakuwa na amani, ndaita kwa Kiingereza ya pelvic area karibu na ile bladder. Wakati inaanza unapata kwamba inaweza kosa kuonyesha ile signs ama symptoms, unaweza kosa kujua kabisa, lakini ikienda zaidi utapata kwamba zile signs zinaanza kujionyesha. Kwa hivyo inakuwa vema zaidi wanaume wakijitokeza waende hospitalini wapimwe, waonyeshe kama wako na shida, na pia watapata suluhisho, watapata tiba kamili.
Hatma ya makala haya ni wito kwa wanaume na jamii ya wakazi wa Turkana kijumla kujitokeza na kupimwa saratani ya kibofu ili kutafuta suluhisho la kudumu la kuitunza jamii hii.
The cancer burden is rising globally, exerting significant strain on populations and health systems at all income levels. In Kenya, cancer is the third leading cause of death after infectious and cardiovascular diseases. The International Agency for Research in Cancer, IARC Globocan report for 2020 estimated 42,000 new cases of cancer annually with a mortality of 27,000. It is sad to note that 70 to 80% of cancer patients in Kenya are diagnosed with advanced disease when it is not amenable to cure. Cancer is a critical global health and human issue. At random, we asked Kenyans if they know what is cancer, what causes it, and how to prevent yourself from getting it.
I think hiyo mambo ya kansa, kitu naweza muelezea tu ni kitu chache kenye najua. Kama hizi kula chakula kuna mandawa, hiyo tu ndio naweza jua. Tuseme kama hizi mboga mimi nauza hapa, niende ninunue nini ziko na dawa, unajua ni kuuzia watu ama mimi nikule, hiyo ni kitu inaweza niletea mambo ya kansa.
Kulingana vile naelewa, kansa ni mahali ambapo seli za mwili zinafaa kuwa, zikikufa zinafaa kuwa replaced, zinaanza kugrow tena.
Najua kansa iko, but sijui kansa inaletwa na nini na sijui dawa yake ni gani. Juu watu wengi naona wakiaga kansa, sasa sijui inaletwa na nini. At least kama mnaweza ni explainia naweza jua hata pia mimi.
Cancer, from the basic knowledge that I have, is the growth of cells, abnormal growth of cells.
Ni vimelea ambavyo vinakuja kwa mwili ambavyo havijatarajiwa.
Okay, kitu ya kwanza, cancer is viral. Ni viral, meaning inakuwa caused na virus.
Cancer ni chembe chembe zenye zinaingianga kwa mwili, inaanza kubehave funny. Maybe uvimbe ama inaleta shida tu kwa part moja ya mwili.
Cancer mimi kulingana vile najua cancer ni ugonjwa deadly. It's a deadly disease. Though mostly huwezi jua vile inakuja. Yeah.
Mimi na understand cancer ni kama lump ama kama ka growth maybe in any part of the body, na your growth ina affect tuseme
such as cancers of the breast, the colon, the brain, the skin. Those are what we call solid tumors. We don't know what causes cancers, other than cancer of the cervix, where the human papillomavirus or HPV has been identified as a cause. Most of the other cancers, we really do not know. We just talk about the risk factors, because a person may have no risk factors but they develop cancer, or they may have multiple risk factors and then they don't develop cancer.
Breast, cervical, prostate, or esophagus, and non-Hodgkin's lymphoma are the leading types of new cancer cases in both males and females across all ages. Cervical cancer being the leading cause of cancer deaths, followed by breast cancer and then esophageal cancer. Although risk factors influence the development of cancer, most do not directly cause cancer. Some people with several risk factors never develop cancer, while others with no known risk factors do. However, knowing your risk factors may help you make more informed lifestyle and healthcare choices.
In Kenya, cancer is the third leading cause of death after infectious disease and cardiovascular diseases. As an institute that was established through an Act of Parliament, that is Cancer Prevention and Control Act 2012, we have a mandate in ensuring that we provide policy advisory to the Ministry of Health. We also provide coordination of cancer activities. We provide regulation and standardization when it comes to cancer treatment centers and other cancer services. And we also house the National Cancer Registry of Kenya. In the year 2021, we did a landscape analysis where we found that our guidelines were not fully communicating to our various partners, those who run cancer centers, and the basic population.
With that, the National Cancer Institute of Kenya reached out to Intellisoft to design and develop a digital platform that will enable healthcare providers and facilities looking to establish cancer care centers a platform to easily access the guidelines and get references relating to cancer care. And for the public, the platform will help them understand what is offered across different accredited cancer care centers.
We felt we needed to be able to improve the guidelines by, one, reorganizing the content of the guidelines so that they speak to each and every person in the different walks of life. And secondly, to digitize the guidelines so that it's made easily accessible across the country. So these were the reasons to why we felt that we needed to do this exercise, because as we moved out and interacted with persons living with cancer, the general community, entrepreneurs who are running cancer centers, it was very clear that the guidelines had the content but were not easily availed or accessible to somebody who was interested in specific content. Secondly, the guideline was quite large, and that also made it a challenge for someone to look for the content. So using this process, we were able to reorganize the content and be able to bring in the key specific areas that are required when you're looking at the basic minimum requirements of a cancer center and combining it with the various designations, either a basic, essential, or a comprehensive cancer center.
The digitization of the cancer care guidelines aims to improve the accessibility to the guidelines for the formation of cancer care centers, centralizing and coordinating activities, resources, and information relating to cancer care management and its prevention.
Our envisionment of this platform is that, one, we would want it to grow. Two, we would also want it to have a dashboard that can be able to showcase the various cancer centers in terms of those with high ratings in terms of service provision, and those with also high ratings in terms of accreditation and in terms of star rating. We also envision that this platform will be linked directly to our website, where both the dashboards can be presented as we present cancer registry data on the dashboards within the website. And we also hope that using this, we can also be able to push and propagate for quality improvement modalities in terms of treatment, in terms of survivorship, and even in terms
The new Kenyatta University Teaching, Referral and Research Hospital is the boldest, most sophisticated health facility initiative ever undertaken in Kiambu County and Kenya.
So today is truly a historic day. We are gathered here to witness another bold step
is just like many other diseases. There are many causes of cancer, I would say.
To my understanding, cancer is just like a disease, like any other disease. But sometimes people, they don't take cancer like a disease. Some take it like a witchcraft, and they related it to curses, which is not true. And they stay with it, and they don't take time to go to the hospital to be treated in the right time, and they start looking for other treatments. It's like any other disease, and when treated early, a person can be cured.
What is cancer? What causes it? And how to prevent yourself from getting it?
Cancer is basically a disease where abnormal cells start growing uncontrollably. They invade normal surrounding tissue, and they have the ability and the capacity to spread to other tissues. That's a simple definition of cancer. And cancers, we broadly classify them into two. We have what we call solid tumors and hematological tumors. Hematological tumors are tumors that arise from blood, like lymphomas, leukemias, cancer we call multiple myeloma. Then all the rest, such as cancers of the breast, the colon, the brain, the skin, those are what we call solid tumors. We don't know what causes cancers, other than cancer of the cervix, where the human papillomavirus or HPV has been identified as a cause. Most of the other cancers, we really do not know. We just talk about the risk factors, because a person may have no risk factors but they develop cancer, or they may have multiple risk factors and then they don't develop cancer.
Breast, cervical, prostate, or esophagus, and non-Hodgkin's lymphoma are the leading types of new cancer cases in both males and females across all ages. Cervical cancer being the leading cause of cancer deaths, followed by breast cancer and then esophageal cancer. Although risk factors influence the development of cancer, most do not directly cause cancer. Some people with several risk factors never develop cancer, while others with no known risk factors do. However, knowing your risk factors may help you make more informed lifestyle and healthcare choices.
In Kenya, cancer is the third leading cause of death after infectious disease and cardiovascular diseases. as an institute that was established through an Act of Parliament, that is Cancer Prevention and Control Act 2012, we have a mandate in ensuring that we provide policy advisory to the Ministry of Health. We also provide coordination of cancer activities. We provide regulation and standardization when it comes to cancer treatment centers and other cancer services. And we also house the National Cancer Registry of Kenya. In the year 2021, we did a landscape analysis where we found that our guidelines were not fully communicating to our various partners, those who run cancer centers, and the basic population.
With that, the National Cancer Institute of Kenya reached out to Intellisoft to design and develop a digital platform that will enable healthcare providers and facilities looking to establish cancer care centers a platform to easily access the guidelines and get references relating to cancer care. And for the public, the platform will help them understand what is offered across different accredited cancer care centers.
We felt we needed to be able to improve the guidelines by, one, reorganizing the content of the guidelines so that they speak to each and every person in the different walks of life. And secondly, to digitize the guidelines so that it's made easily accessible across the country. So these were the reasons to why we felt that we needed to do this exercise, because as we moved out and interacted.
All right, good morning, everyone. Good morning, everyone. Thanks. My apologies, they were a bit behind schedule, but we're going to start right now. So my name is Stephen Wanye. I'll be the chair and moderator for this session. I hope we're all in the right session. This is about technology for cancer. So just make sure you're in the right session. So we're going to be starting in a few minutes. And to this morning, we've got a couple of really interesting presentations and discussions lined up. So we'll get to hear from Smart Applications, who will make a keynote speech for this session. And then we've been graced by folks from Ministry of Health. Dr. Wesley, he's going to make his way here shortly, who's going to present to us about the Ministry of Health capacity for healthcare workers, particularly around digital health implementations and investments in Kenya in the health sector. We'll also get to hear from J&J on capacity building for frontline healthcare workers in cancer as well. And lastly, we'll hear from Dr. Ngure from Savannah Informatics around patient engagement in healthcare and how digital health is being used for that. Since we're really running behind time, I would have hoped that we would have had enough time just to introduce ourselves, but let's see how the session goes. If you have time, we'll take the mic around just to get to know who's in the room. But for now, please allow us to start. And I will, without much further ado, invite Harrison to make a keynote speech. I don't know if Harrison is around from Smart Applications. And if Harrison is not here, I think we'll just proceed to Dr. Wesley. And Dr. Wesley will introduce himself and take us through the Ministry of Health Virtual Academy. So for the presenters, please try and keep it to around 12 minutes. Thank you.
So good morning. It's very challenging when you have the first presentation. Sometimes half the people are half the chairs. So my name is Dr. Wesley Oga. I currently head the Division of Health Informatics within the Ministry of Health. And I'm going to be taking you through some of the few things we're doing as partner funding and every other thing is coming down. Technology, I think. That's why every time you want to go down. Oh, sorry. So I'm basically going to take you through something we call the MOH Virtual Academy. A good number of partners, I think, and all of you have had a chance to be trained physically. And one thing that COVID taught us very, very well is that ideally we may not need to meet physically to be able to get information, to have meetings, and every other thing. And as partner funding has come down, the Division of Health Informatics has been able to come up with a virtual academy where all people who are interested in improving their skills and what they have, they can be able to learn more. So the MOH Virtual Academy is an online learning platform where anybody, in case you're interested in learning, you first of all self-register, giving your details using a Google account credential. And this ensures that we have access. And most importantly, if you're using a phone, it works using an app known as Moodle. So you can be able to download the Moodle app and you can be able to work offline. So a number of times people will be able to ask you about what is the cost of bundles and the rest. It's important to note that our MOH Virtual Academy, once you download a course, you can be able to work with it offline. And you have 24/7, 365 access learning. The only thing I've realized about this learning is if you're used to traditional learning where the teacher needs to remind you to come to class, you will register for a course, you will start the first unit, and then you will forget. So we have one of the highest dropout rate, and so it really needs commitment and determination. I think if you've ever tried, any of us tried an online course, we've actually done a reminder by email and by SMS. Otherwise, we have one of the lowest completion rate, especially when we do not score 100 in the courses assessment in between there. So the materials are intended to build capacity for healthcare workers to support the entire cancer control continuum. From prevention, we have courses on prevention, early detection, treatment, survivorship, and an aspect of monitoring and evaluation of the system as we move ahead. All courses are free. So be sure we'll not be asking you to go to your M-Pesa to pay a course. It's a government-provided learning platform, and everything is free. So some of the courses you might be able to learn. There's digital health courses. I don't know, how many of us know something called DHIS2? I think only 2 or 3. So kindly, in case you want to know, for example, how many mothers delivered in your village, we have a system called KHIS, Kenya Health Information System. So the digital courses will be able to train you on issues about our health information system. We have something called KMFL, which will give you all the health facilities in Kenya, where they belong, their GA codes, and what services you can be able to access in that particular website. So some of the courses we have, I think, that will be done in digital courses. COVID, I think you all agree with me, came and taught us a very good thing about hotel training. So one of the few things we did is we have an online module for training on COVID. Antimicrobial resistance, a very big issue at the moment. HPT, health products and technology. In case you're interested about bubble autopsy, public emergencies, health commodities dashboard, non-communicable diseases courses, gender mainstreaming, and communicable disease. But for non-communicable disease, which is our emphasis today on cancer, a key thing to note is that we have courses. Our objective is to equip health workers with knowledge to risk factors on prevention and priority cancer. We intend to build capacity for health workers to appropriately conduct early detection. I think one of the major things you'll agree with me, for cancers, the main way of prevention or the key thing is screening. If you don't get screened early enough, then the outcomes are not usually very, very, very good. So our aim is to enable primary healthcare workers to undertake prompt referral for management of diagnosed cancers and their cases. So these are some of the cancer modules we have in the system. We have early diagnosis of cancer, overview of cancer. For cancers of head and neck, you'll be able to get all the information. What is the management? I think if those of you who have been in the hospital, who've not been in the hospital like me for quite a while, the chemotherapy, you'll be able to get which is the first line, which is the second line recommended for Kenya. Brain tumors, Kaposi sarcoma, I think those of you who've worked in the healthcare in the beginning of HIV, Kaposi used to be one of our major things we tend to see. So we'll be able to give you the management and everything to look out for Kaposi sarcoma, lung cancer, childhood cancers, gastrointestinal, adult hematological cancers, breast cancers, cervical cancer, gynecological cancers. I think most of the time we have a bias for cervical. I think cervical is the major thing you get information on, but you'll be able to feature all the other cancers that affect the gynecological and lastly, urological cancer. So in case you need information or you get a patient and you need to go learn more about a particular cancer, courses within the facility of the MOH Virtual Academy will be able to give you on that. So some of the other courses we're coming up with is case management for malaria, occupational health safety, and basically basic chemosafe. This is majorly to look at the pharmaceutical aspect of preparation of anti-cancers. Some of us who had a chance to intern in Kenyatta, I think you know how the hood and where we prepare the drugs for particular administration for cancers. So a key thing, one of the best things we talk about the courses available in MOH Academy is that at the end of the course, you'll be able to get a certificate. You know, one of the things that education has taught us in Kenya is that you want a reward. After I've done the learning, am I getting a certificate? Proof of ownership of that course. So you'll be able to get it. And the beauty about it is we've also linked with our regulatory authorities, that is Pharmacy and Poison, Kenya Medical Practitioners and Dentistry Board, Nursing Council, and then Clinical Council, so that once you do a course, you're able to be awarded some CPD. So you don't need to worry about whether the course goes in vain. If for registration of new certificate, you need a CPD, we have already done that for our part. Now, these are some of the CPD accreditation we've been able to acquire. I think you can see, and each of us, I'm sure you belong to one or two, to one of those regulatory bodies. So in case you enroll and you put your names as they appear on the other side, you'll be able to get the CPD once you complete our course. So I don't know if there's any major accreditation body we're missing, but I think the dietetics and the rest, we are working to be able to get them on board so that once you do our course with us, you can be able to gain the CPD. So some of you might be here and you might want your course to be uploaded within the MOH Virtual Academy. So we have developed our guidelines for e-content development. So in case you link to the website, we'll be able to tell you how you want your material to appear, what is the slides, how things should appear in the slides, so that whoever is going to interact as a student, they can be able to take a particular course easily. I think you're all aware about how you crowd your slides and the rest. So just a little statistics so that you can be able to see. We have 62 daily visits every day. We're about 6,700 users as we speak at the moment, 22 courses. So far, 10,500 have been able to enroll. And I've told you the challenge is what? Completing. You go. Friday comes and then you forget. By Monday, you don't remember you were in a class. 6 CPD accreditation, and lastly, we've been able to over 1,100 accreditation. I think we can say we have about a 10% completion rate. So in case you're interested and you have a phone, please, that is our link, so that you can get it at elearning.health.go.ke. And once you get in, please remember you need to register, get an account, and once you get an account, all those courses I've been able to show you, you can quickly get in and get the particular thing. In case you have any challenges, I think we have a help desk. The following resources are available. I think learner's guide and frequently asked questions. These ones you'll be able to get on the first screen. You need not necessarily register, but it'll be able to guide you through as you're able to go through our slides. I think I've gone through this. MOH Informatics, the e-content and how we develop it. Important to note, the key person who's been supporting us in development of this is USAID through Health IT, which is through the University of Nairobi. And currently the sites are hosted within the University of Nairobi servers, but we are moving in because my next presenter I've seen is my head, Dr. Stiene. He'll be able to give you about the health data or the data center we're doing for the country. This is just guideline, content management tells life cycle. This includes development, enrollment. I think this is something just to get you going. But in finishing within my 12 minutes, these are the partners who have supported us in developing MOH Virtual Academy. I really encourage each of you. I think one of the few things we've learned about the technology side is that the best people are those who will be able to unlearn and learn a few things. So if you don't want to unlearn what you had learned previously and learn afresh, the new things that have come with AI, ChatGPT, is that we keep learning. Thank you very much. I welcome questions.
Thank you, Dr. Wesley. Now, because we're running a bit late, I'd prefer to give all the presenters a chance to make their presentations. So kindly note down your questions. Let's keep them to the last part of this session. So I don't know if Dr. Stinei has made it yet. If not, if he's not here, I think I'll just proceed to the next presenter as we wait for him to come. So Dr. Stinei is the head of the directorate where Wesley is based, and he's going to talk to us about the digital health platform, which is the Ministry of Health end-to-end system that they're establishing. So I think since he's not here, I'd like to call up Anthony Gital from J&J. And then after that, we'll see if Dr. Stinei is not here. Otherwise, we'll go to Dr. Ngure from Savannah. Let's keep it to 10, 12 minutes so we can have enough time for a couple of minutes for questions and answers. And then I'll also be looking out for Harrison as well.
Thank you very much. Good morning, everyone. My name is Anthony Gital. I'm the Director for Global Community Impact at Johnson & Johnson for Sub-Saharan Africa. And my presentation is about training. However, it is about how we've been able to leverage digital solutions for us to advance the training of oncology nurses in the country. I'll give you a little bit of a background. Johnson & Johnson Global Community Impact is focused on supporting and championing frontline health workers. And we've specifically focused on nurses and community health workers. And our engagement with the frontline health workers is really through what we call our Center for Health Worker Innovation framework, which really speaks to training and education, leadership and management, rewards and recognition, connection and integration of the frontline health workers to the system, and finally the well-being and resilience of our health workers. So as we started engaging in this space of oncology, the biggest challenge we saw after we engaged with all the ministry at the National Cancer Control Program, the NCI, and all the specialists, was that there was a huge gap in the training of oncology nurses. In 2018, we only had 36 nurses in Kenya who are formally trained in oncology, and therefore there was a gap in terms of how the patients then received care once they've been diagnosed. So when we looked at it, we were like, okay, let's then train the nurses. And the ministry stated we needed about a minimum of 500 nurses trained in oncology in the country. When we then did an analysis of if we do have the money to do this, what is the bottleneck? The biggest we found was actually that we only had one college at that time accredited for the training of oncology nurses. And that meant that even if we had all the resources to train the nurses, we could only train 60 in a year, which would take us close to 10 years for us to be able to meet that deadline. So the first thing we then did was really focusing on, all right, there's supposed to be words inside there. I don't know where they've gone. So digital sometimes doesn't work. So the key thing was then to look at what is it that we need to do to be able to bridge that gap as quickly as possible, because we can't wait 10 years to get the services we need. So the first thing we did was to support the development of a national curriculum for oncology nursing. And this curriculum was basically produced by all the schools coming together. They sat together, they went through the curriculum, working with the National Cancer Control Program and NCI. And through that, we then developed a national curriculum, which then went through the normal process of accreditation. And this was accredited by the Nursing Council of Kenya. And so we did have a national curriculum. And then now, schools that were interested to be able to deliver the curriculum then took it and adapted it for their own accreditation, so that then we could have more schools that are offering oncology nursing training. But then we also realized that we are limited by the number of seats in a class that can be offered. Because at that time, in 2018, anytime we talked about oncology nursing training and suggested a digital solution or a blended approach, we met a lot of resistance. Because at that time, we were doing everything analog. We had to sit in a room, we had to train everyone physically, and that is the way it was thought to be. So as J&J Foundation, we also pushed for a blended approach. Nairobi Hospital and KNH, if I'm not wrong. And then by 2022, we now have added KU and also AMREF International University. So that means we now have 5 schools. And if you put in total the potential of training, that means we can train up to, I believe it is 210 that can be trained per year. And I think that could not have been done without leveraging the digital solution to do this. So since then, we've trained 254 oncology nurses. We have a current cohort in class. 254 are actually those who've graduated. And unlike Wesley, our completion rate is pretty good, because once somebody goes into these ones, they tend to finish. So we've been having a very good completion rate. And we hope that by the end of 2024 or 2025, we'll have met the target of training 470 oncology nurses in Kenya to add to the 36 we have, so that we meet our target of 500. The only thing I'll highlight at this point is that, of course, this has to be something we keep doing, because the nurses also leave. I remember one of our very initial lecturers in MTRH is now in the UK. And so as much as we train, we know that they're leaving, so we have to keep this going. And so as J&J Foundation, what we've really focused on is how do we ensure that the nurses who are currently trained are actually deployed to offer that service. And that's where I think Dr. Karagu and NCI can come in very strongly to support that those who are trained actually go out and provide oncology services. And then secondly, we are working with the Nursing Council. We've developed what is called the Muuguzi app, another digital solution. And this is an app that is for nursing, but it helps to be able to show your skills, what do you have, where are the gaps, and where can you apply for those opportunities, so that you can go and actually use the skills you've learned through the training. And then finally, because there's the issue of having enough resources to train, we can't keep doing the scholarship forever. So what we've also done is we've partnered with the Higher Education Loans Board. We have provided a grant of $500,000 that is being used as a low interest rate loan that nurses can be able to access for specialized training, and oncology nursing is one of them. So for me, I really feel that the digital solutions have really helped us to bridge this very big gap that we are having in terms of training of oncology nurses. Thank you very much.
Thank you very much, Anthony. I think we'll keep plowing through the program because we're really behind schedule. So I'll invite Dr. Wesley to make the presentation on the digital health platform. This is the Ministry of Health end-to-end digital health solution that the ministry is rolling out across the country. So I'll request Wesley.
You don't have it?
You should meet Dr. Wesley.
Yeah, meet Dr. Stini. You have anything for this, Stini? Stini.
Oh, CTNA.
Yeah.
Oh, that's for CTNA. Okay. This one.
Yeah. So good morning once again. I'm trying to fit into my boss's shoe, so in case I don't fit very well, please bear with me. But being that I am, Afra KE, please, when I get there, be very keen, because that's where our big thing. the national architecture of IT, how we expect things to work, and I'll be able to do the conclusion like rightly. So currently, if you look at the landscape of Kenya, this is the kind of facilities we have. We have dispensaries, healthcare, level 4, level 5, and level 6, and generally the total population in Kenya. You'll agree with me, we have a gap, because for cancer, most of the management will appear at level. We have a gap, because for cancer, most of the management will appear at level 4, level 5 and 6, although a good number of the level 4 facilities are based on it. You might want to inquire how we decide these levels. There are standards and norms, so that, for example, I believe a level 4 should have at least 300 bed capacity, an X-ray unit, and all the rest. But in case you want to know the facilities we have in Kenya, at the moment we have about 13,106 health facilities in Kenya. Level 5, I think you can see, majorly, private has 5, MOH has 14, 3, and level 6, I think you all know them. Anybody knows them? Kenyatta, Mathare, Spinal, Moi. Thank you. So, one of the few things we've been doing as healthcare is to try and digitalize the experience that we see when we get to see our patients. And one of the things we've noted is unsustainable system, objective of solution. Mostly M&E system, disease, or project. Most of the EMR, or what you've been able to see around, are able to focus on disease specific. I don't know how many of you know about TB. Anybody heard of TB? Which is a national EMR that whenever you have TB, wherever you go, you can be able to be managed. So one of the challenges we've had is we have disease-specific EMRs. I think you've also heard about Kenya EMR and the rest. Consequences that we have vendor lock-in. I think most of you are aware. There's something like Fansoft. I remember when I used to be in the facility, there's something like Fansoft. There's, I think, Elephant. Anybody who's familiar with Elephant? Yeah, I'm sure if you're from the county, they've been very aggressive going around and ensuring counties are on load, which is vendor locked in. So you do not have access to the data. The data belongs to the person and is the one who collects them. Lots of vital information system to be able to serve all Kenyans and to be able to serve the needs of data to inform policy and decision making within the country. So we have some of the things we have a comprehensive, what we envision in this comprehensive system is that captures all health data in all service delivery. This is what I mean. If today you are to go to a dispensary in your village and you're treated, and in the next 1 month, you're in Mombasa and you're in Coast General, we envision that we shall be able to have all that data in one place, so that once you come in, your history and your medical history can be able to be tracked along with you. So that I'm sure most of you are familiar. When you land in Nairobi Hospital, they open a file. If tomorrow you're in Aga Khan, yet another file. If you come to Kenyatta, another file. So that's what we are envisioning, that we have at least all individuals in household, all health facilities that capture data, not report, but most of the government and FBOs have been reporting. So one of the few things with this system is we want to ensure that whatever service you are providing as a health service, you'll be able to do report on it. This system should be able to be integrated with KEMSA, NHIF. Do you know the IPRS? I think if you've ever gone to the bank, have you ever gone, they ask for your ID, and then somewhere along the way, the cashier checks around to see indeed if it's you? That's the IPRS that is run by the Ministry of Interior. So we've been able to link it that, and the main aim we are doing that is that we do realize that as a Kenyan, as a country, we do share names. I think like somebody called Tom Omondi or Mercy Akinyi. Those are the common names I get to get. You can get Mercy Akinyi, like 5 of them. So we need to be able to define the Mercy Akinyi we are treating. Is it the real Mercy Akinyi? Is it Mercy Akinyi Otieno or Mercy Akinyi Omolo? So that's why we are looking with IPRS. Regulatory bodies, this comes on the professional part. We want to ensure that once you log into the system, you are within our regulatory bodies registry, and most importantly, your license. I think some of us have been practicing, and maybe the last time you renewed your license, God knows it's only you. So at the end of the year, once the license is not renewed, you'll not be able to access any of our health digital platform systems. You have to be up to date. We also integrate with M-Pesa, EHR, and all of that, and integrate all special services. So the advantages is that we'll have real-time collection. As you are seen by the clinician, the data goes into the server immediately. Centralized database, query for diseases, customer-client interaction. I think all of you have familiar, at least If you've gotten the COVID vaccine, I think you'll agree with me, that is where we need to go. You can be able to link in yourself, it's available to do. I don't know if it's very, very clear. But in October 2002, here, we were able to do all our requirements for the system. We've done, by April 2021, interactive development of OPD modules. The OPD modules is complete, and those of you who know Kitengela Health Center, the DHP is currently being piloted there so that you can see the interaction with the patients. We've done integration of users, I think 2020, identification of sites and infrastructure. I think those of you who are familiar with level 4, if you're from government, we've been able to do servers to all the level 4 facilities, county hospitals. Those who are familiar with NOFB, all of them have been able to be connected by fiber, so that when we roll out, the system will be end-to-end. So deployment to facilities started at 2021, and I've told you, at the moment, we are piloting it at Kitengela. So what is this that is helping us to be able to implement this? Number one, we have the Kenya Constitution. I think all of you are aware what the Constitution says. It says that every Kenyan citizen is supposed to get the highest attainable standard of health. So one of the key pillars in providing good healthcare, you'll agree with me, is information and data of that particular act. We have the Vision 2030, the Health Act. Key thing, I think I'm reminding everyone again, please familiarize yourself with the Data Act. And health workers, the health records information is able to capture you digitally and upload it, and within 24 hours, each baby born in Kenya will be able to get a birth certificate. And I'll be able to tell the president, yesterday, these are the number of babies who are born, and these are the number of babies who got a birth certificate. Then we have universal healthcare. I think that I'll be able to talk about it later. So policy documents, I think all of you should be able to familiarize. For the IT people, we have developed our Kenya Health Data Dictionary. Please get familiar with it. We are actually on the finalization stage so that within the data world, within the digital dictionary, a unique patient identification framework. Please note, this is available in the ministry website. If you need to know more about a unique identification, we've developed a unique identification to cover for issues that I've talked about, the Mercy Akinyi thing, so that you will have a 12-digit unique identifier for you that is not fraud-facing. It's only known within the system. You only need to come out to us with your ID. We'll search for you. The system will identify you. You'll get the healthcare service and be able to go across. Standard guidelines, health data governance, we're doing that, and telemedicine guidelines. Revised documents, I think we've done a revision of our Kenya Health Enterprise Architecture, the pre-blueprint and the rest. I think I want to go very fast. So the whole government approach is to develop a customized digital health platform. Please realize we are talking about a digital health platform, not an EMR. One of the building blocks for the DHP is an EMR, which I'll be able to take you through, which is known as Kenya Afya. Putting SOTA data center, I think we now have almost a cloud-specific, cloud-level data center within the Ministry of Health. So anybody collecting data on Kenyans, we are requiring that we should be able to have a copy with it. Ministry of Interior is covering our data security and the rest. Let me just move very fast to this. These are the components. We shall have the digital. DHP has the gloss over it. This is the system we've been able to develop to cover for all immunization. So that I think if you've been able to get COVID, you are familiar with this particular one, portal.health.gco, and use. Telemedicine is something we are piloting so that, for example, for purposes of X-ray visualizations, when an X-ray is done in Isiolo, we have people who are radiographers within Nairobi. They can be able to read, do the interpretation, and give back the results there. So that means for the far-flung areas, do not necessarily need to have those particular healthcare workers. National infrastructure architecture, I think this is just to guide you. I wanted to do this. This is the most important thing. If you should go home, I think this is one thing you need to be able to understand. What is our national architecture? That we shall have this as our national architecture. This is what will be residing within the facility. And I think you can see the different divisions within the health facility, the pharmacy and everything. They'll be able to communicate with each other running on a microservice. This should be able to link with all this. If you can see state actors, we have NIMS, which identifies you. We have NHIF claims. So very soon when we implement this, the issue of filing claims with NHIF will be gone. The system automatically, once you've seen Wesley, generates a claim to NHIF, and NHIF is able to pay. DHIS2, I think that is where we keep our aggregate data, the MFL, supply chain, early warning center, ICHIS, which is our community health, regulatory body, and IRIS. On the other side, we think we have all the other things that will be able. So this key to tell you, especially the I think the IT gurus will be able to understand the architecture, and we have the interoperability and integration layer. That means, for example, if you have a system already in place, we will not require you to get a new one. All we'll ask you is, can it be able to share data with us across those systems? Fiber optic, I think I talked about NOFB. I don't know if you heard about it, but I'm sure if you've walked along the road, you've seen a pillar called NOFB. And that is ensuring that we have fiber optic connectivity to all health facilities all the way down to the dispensary. So patient level data flow, let me just be able to give you this so that we'll be able to see NOFB is connecting us. We have the DHP, as you can see there. That's what is seeing the patient. And once it has done the patient, it will send the aggregates. How many patients had malaria, how many patients had typhoid, how many patients had surgery. The aggregate will be able to send to KHIS, which will be able to give the analytics. Other databases will be able to connect to it through that particular link. So these are the models we're implementing. Model 1, which is most of you are aware, is paper-based. We don't need a power, you don't need LAN, and you can maybe be able to scan and send us our data. Model 2, which most of the facilities that agree with me are mixed. There's some part of the clinical work which is done on the digital part, and there's a part that you write on paper. But our vision is model 3, and the president has been very categorical. We need to go fully digital. So everything is digitalized. We need power, we need a LAN, and this means we fully automate everything. What are the challenges we've been able to come through as we've been pushing this? I think infrastructure, last mile to facility, LAN, and bundles. Every time you tell people about digitalization, they always have to ask you, who will buy us the bundles? Setting up teams, sustainability, a key thing, budget line for continuous enhancement. The beauty about it is, in our MTF this year, we've been able to cover for it, and the government will budget for it. This, in conclusion, this is my take home for you, is that Kenya is slowly moving from the paper-based system to a computer-based system. Local to global information system. We are focusing on healthcare profession to patient and consumer. And we're using data only for patient care for research. And we technical to manage information system and numerical data to more complex data. That, I believe, will be my last slide. So remember, as I've said again, look at the Data Act. Be familiar with it. You don't want to find yourself being in the wrong hands. I don't know if you've registered as a data user, data processor. I think you're aware about that. Most of you are giving me a blank face. If you're handling patient data that includes their phone numbers, things that can uniquely identify them, you need to register with the data commissioner. Next thing, we have the DHP, which will run through a unique identifier, a shared health record, and an EMR. Otherwise, I'll beg to stop there. I hope I sufficed for my boss's presentation. Thank you.
Yeah, thank you very much, Dr. Wesley. And again, my apologies, I know you had to rush through that. So it looks like we might not have a lot of time for questions at the end of the day. So please take note of Dr. Wesley's face and get his contacts, because I think you might need to follow up with him separately. So at this time, I'll invite Dr. Ngure to share with us about patient engagement using digital health. And after that, I think we'll close out with Harrison. So we only have 15 more minutes. My apologies, we started a bit late, so we just have to do this way.
Thank you, Steve. So my name is Dr. Ngure from Savannah Informatics. So Savannah Informatics is a health tech company. So today I'll speak about some patient engagement work we've done. We've done it with the University of Nairobi and also J&J Global. And so J&J were here before talking about how they're supporting oncology. Now, yesterday when we were listening to the plenary, I think we had various speakers bring out themes of awareness, like the CS did that, and themes of navigation. We had the survivors tell us how they really struggled to understand how to navigate their care journey. What we've been doing is we've been testing out the feasibility of using stories, and we use the word stories to evoke social media, to unpack and simplify health information. And this will be a case where we are taking the same information that's validated by the experts and then making it really, really accessible and pushing it out there. Or one of the, I don't know if they are friends or foes, of every doctor is Dr. Google. But can we embrace Dr. Google by making sure that the right information is actually available and accessible? Then there's a subject of navigation, and I think navigation has been a very big theme throughout this summit. And I was very excited to hear about the work being done by KNH and also by Jaramogi on navigation, actually walking patients through. But the question we need to ask ourselves is there a place for a digital navigator that makes the journey of finding care, understanding services a lot less intimidating for the patient? And it's a challenge for those of us who are in content to ask ourselves what is the most high-value content that we can actually put out. Then there's a subject of how patients and their caregivers interact with the healthcare system. So the question becomes, is it always one way, or do we have room for health diaries? And there could be diaries observing things like medication. I took my meds, I've recorded that, and having that actually enter the record that is reviewed by the healthcare professional. And I think in side chats with the oncologists and others, there were emerging cases for this, especially around matters adherence and follow-up. Then I think we all agree that cancer is a very high burden disease in terms of the burden it places on the patients, on their families, and on their caregivers. And it might be the kind of situation where we want to really, really enable and empower support groups. So looking around the stalls, you could see that some of the organizations there are actually people who are out there to support cancer organizations, support patient groups. And as we look towards how to scale this, we should ask ourselves, is there a place for digital support groups and similar tools? And we have to do this while being very careful to acknowledge that online tools can be prone to misinformation and disinformation. So this needs to be channels that are moderated or that have healthcare professionals in there to offer the voice of reason. I'm actually very glad that I'm speaking after Dr. Wesley spoke twice, because I'd like to preface this slide by saying that even as a private sector player, we are happy to plug in completely into DHP and the government's vision. And that means that if we find ways to have a health record that is continuous, maybe some parts in the patient's hands, some parts in providers' hands, it to be a health record that is in keeping with DHP and coming off the government-mandated data sources and complying with all rules. Yeah. And one of the things we've heard from a lot of cancer doctors is the frustration they feel when the record is discontinuous. There's a piece here, a piece there, a piece there. And we should actually, as an ecosystem, I believe, work towards this kind of continuity. And again, happy to speak after Dr. Wesley, because when it comes to telehealth, yeah, I'm aware of the ongoing work on telehealth guidelines. But I think the question I want to pose to the audience and that we can discuss afterwards in over coffee is, what is the kind of telehealth approach that is well suited for cancer? And is it a complement to the interactions with doctors and nurses, or a replacement? I may have my own draft answer, but I'd like to hear what your answer to that is, including the place of simpler things like text. And I think I'll pause there because of time. But please, if you've got questions to ask, find me after this. Thank you.
Thank you very much, Dr. Ngure. Really appreciate you taking less time. So I think I'll invite Harrison. Harrison is from Smart Applications to make the final presentation for this session.
Good morning, ladies and gentlemen, members of the NCI board, NCI CEO. Yes. As a presentation comes up, in the interest of time, I would like to start off in the conversations that we have around this very important topic, that is uniting our voices and taking action in alleviating the burden of cancer that we have in this country. Smart Applications is a healthcare ICT firm who prides ourselves in the delivery of value that impacts patients' lives and is delivering change in the society. We are an indigenous Kenyan pioneer innovator. If I do ask across the room how many of you have smart cards and are using biometrics at the hospitals, we are the pioneers of that technology 18 years ago, and we are proud today that as we stand, we are in 11 different countries across Africa where we've been able to tell this Kenyan story and have impacted over 1.8 million lives in how they access healthcare across the continent. That should make us proud, because when we say that Kenya is epicenter of digitization, we are a true attestation of that. So today, as we stand in terms of the impact that we can create in alleviating the burden of cancer, we look at different perspectives. We look at how can we use and leverage technology and patient-centered technology for that, in terms of how the patient can be more aware, can be more educated, and I know that has been spoken about, how the medical practitioner and the caregiver can be empowered, and how the scheme, different actors within the scheme management environment can work together to ensure that the quality of care is improved. And that's what I'll be speaking about in the next few slides, which I shall cover very quickly. So we currently are interconnecting 4,200 different facilities across all the 47 counties in Kenya. That represents 80% of all private health facilities as per MOH statistics. And indeed, we are serving, as I said, 1.8 million whom we have provided different forms of access to healthcare through our digital platform that is proficient today. The World Health Organization estimates that the burden of cancer will actually double by the time we get to 2030. We are looking at 1.3 million cases. Yesterday we heard from Africa CDC that the number has actually gone up. We're looking at about 1.7 million cases, which then means that we need to act now. And therefore, this call to action is very, very pertinent. So as we look at how do we educate on matters to do with early prevention, early detection and treatment of cancer, then it becomes quite pivotal. And we've talked about different mechanisms. Yesterday, the Honorable CS of Health had a call to action to our media. And the question about to us as technology platform providers and all of us who are digital savvy in a country which has 93% mobile penetration is how do we get there? How do we get more information out, and how do we impact the country? So through the system that we provide, we've been able to, first of all, reduce errors, fraud, wastage, and abuse by up to 27% in the private medical insurance space. We know that that has contributed to sustainability, and there are many lessons that we have carried on to the public sector where we're interacting with a number of parastatals and government actors in relation to how that we can leverage the technology platform for enablement and reducing inefficiencies across the patient and hospital conversation and interaction. I want to talk about our latest innovation, which is basically on the app space. Kenya is known to actually be one of the leaders in terms of uptake of apps. And across the room, we would know that all of us, in one way or another, interact with the mobile apps for different aspects of communication. And we have focused technology in regards to how do we use this to strengthen the way patients receive and consume healthcare information. Our app basically has concepts around educating the end consumer. And this is an app currently that is in use by about 20,000 patients, where we keep them informed through healthcare articles, both local and international, in relation to how they can actually prevent cancer through the right things like diet, how the right things like articles, the right things in terms of wellness, and essentially how we link these patients to doctors across. Some of the notable partners that we are working with include the Aga Khan University Hospital, the Gertrude Children's Hospital, Texas Kenyatta National Hospital, just to name a few, and essentially ensuring that that care information is available to patients as and when they go. But one area that we have not really concised that we want to bring out to the audience today is the power in the data that comes from the solutions that we offer. Digitally, as we look, the statistics from the private insurance sector actually really are rallying with what was spoken about yesterday. The burden of cancer in terms of treatment and in terms of cost, which comes out in terms of the patient traffic and the average cost, is actually highly skewed towards Nairobi. 85% of private medical insurance consumption on cancer-related matters actually comes from the epicenter, which is Nairobi. And you can see a few counties that follow, like Kajiado, Kiambu, Uasin Gishu thereafter, and the changes from 2021 to 2022. That is also reflected in the traffic that is seen across that slide. One of the other things that we see is also the prevalence of different cancer types. And we can see this also augurs very well with the report that was shared by NCI in terms of the different cancers that are leading. We are seeing follow-up treatment post-hospitalization being the leader in 2021, but when it comes to 2022, breast cancer has become quite prevalent. And we also see other items like colon cancer, connectivity and soft tissue cancer as leaders within the top 5 cancers that are being sampled from the data that we have today. When it comes to cost, we are actually seeing that gastrointestinal cancers are actually leading in terms of the average cost to treat. And I know that this is only a portion of the data. Insurance penetration from a private perspective is only 2.3% in this country. But when we look at a number of the treatment cycles, the whole journey is not actually catered for in the private medical insurance regime. A lot of it is also taken care through NHIF and overseas treatments that are notably well managed through the family funding elements. So when we look at this, we see that in 2021, the lead in terms of high cost of treatment on average was bile duct cancer, but in 2022, we're looking at gallbladder cancer as being the lead. We do have a call to action in terms of how do we build capacity in our healthcare providers. We're seeing that in the top 10 list of healthcare facilities that are actually offering cancer care, largely it's the same hospitals. Largely, it's the same hospitals. We've not named them for purposes of data protection. We are compliant in terms of a Data Protection Act, fully registered as a processor and a controller, but it's largely the same. And you can see that concentration is driven to particular hospitals because we only have specialized equipment and scanning machines for diagnostics in those special hospitals. So therefore, there's a call to action on how do we build capacity to different hospitals. When we look at the disease trend across different age groups, it sends a very clear message that if we are to actually start the conversation and impact, we really need to look at specific age groups. We are seeing the trend rises definitely with age, but it is a marked increase around the age 31 to 40 upward. And it's skewed towards the female gender having a higher burden than we have currently on the male gender. And that shows that definitely there's a lot of conversation that needs to happen. Case in point that caught our curiosity that we're still investigating is the males around age 11 to 20, because it appears there's a certain elements that are making them more in terms of spike of cases around that particular age. So this can also inform interventions that are there or that are required in terms of policy and in terms of treatment availability when it comes to cancer care. When it comes to private medical insurance, we cannot do it alone. We have to work together with national health systems, and I pride what was mentioned yesterday by the Ministry of Health in transforming NHIF to be a national social health insurance fund for the purposes of ensuring that we have more reach in terms of cancer care to the Kenyan population. We note that actually in terms of medical policies that offer the full treatment of cancer care from a private medical insurance perspective, only 13.6% of them cover because of the aspects of exclusions and chronic ailments. So it means that really because of the cost of care, we are not having adequate choices and options for our consumers. We have seen an increase in a number of awareness, but not very high in terms of the levels that we'd anticipate to see, because this is only representative of 0.02% of the entire population that we have in the private medical insurance space, which is actually going towards some of these tests that are required for cancer detection, early detection, and care. So in conclusion, what are some of the ways that we see going forward? One of the ways that we see is we need to encourage use of local indigenous platforms and mobile tools, especially with the high mobile penetration that we have. We are seeing that we can communicate better to patients in relation to things that they can easily access to through their phones, and not only on app, but also SMS and USSD. Secondly is our role to ensure that there is interoperability and integratability, and that's why I was very happy to hear or see the presentation from Dr. Sitenei in terms of how we can work better with government to deliver and enhance quality care to Kenyans through that interaction. Nobody can do it alone, and we believe that through this integration we'll be able to foster the results that we want to see. We see that also as private sector actors, we can actually go an extra mile in terms of how do we touch the community through our CSR programs. And I want to talk a little bit about our corporate social responsibility program, which is called the Smart Touch of Gold, of which in the last 2 years we've been able to actually donate over 5 million shillings, even more, actually in terms of different cancer programs at the Kenyatta National Hospital Children's Wing, the Gertrude's Children's Hospital, amongst others. And this is all about how we can impact through these different initiatives. So the call to action for all of us is that there's something that you can do at your level in terms of cancer care. Let us start by educating ourselves through the platforms that we have. Let us start educating our neighbors. There's a Nyumba Kumi initiative which we can take to the digital space, and let us ensure that together we all rally to take action united towards ensuring that our society is taking action in relation to early detection, early prevention, and therefore quality care when it comes to alleviating the cancer burden in Kenya. Thank you very much. For purposes of time, I'll stop there. I can see my time is over.
All right, thank you very much, Harrison. I think we might have time for one or two very, very burning questions. I think we have about 5 minutes. Any burning questions? All right. I think it's off. Or just use this one.
Good morning, everyone. My name is Monica, representing Women for Dementia Africa, which forms a big bulk of the elderly. This week I read an article from NCD Alliance Global saying that many elderly in the cancer space, there's no data showing elderly people they are cut off from age 70. So my question is to SMART. Do you have any data on the elderly in regards to cancer that in your records that because many data systems globally cut off the age of 70, and yet from the presentations we've been having, we've seen 50% of people who get cancer over 65, and the number is growing. So that's my question.
Good morning, everyone. My name is Priska. Mine, I think, is a comment to smart applications. There's a slide you presented showing the different areas where where patients visit the hospital for. And I was concerned by the cancer care, where the liver function, kidney, and full blood count, where the figure was 8, I think, for both 2021 and 2022. And I'm asking myself, these are some of the very critical tests that cancer patients have to go through, like during treatment and even during cancer management. What would be the problem? Because I would actually expect that there are very high numbers during treatment and even during management because of surveillance. Thank you.
Good morning.
Thank you. Thank you. I think Wesley, a question to Wesley. Dr. Masasabi, I used to be at the ministry then. How far have you gone with the civil registration exercise that we started with the Ministry of Interior, especially to address your contribution towards digitization of, recording the, the births and issuance of e-certificates? So just a comment. Thank you.
Very much to the question that were asked around data for the over 70. Now, I'd just like to, and the second question that was asked around the liver function tests. So I'd just like to attempt to answer that, and also I'll call one of the experts that I know in the room to also help me with that. Now, as I mentioned, that only 13.6% of insurance covers actually are covering the full treatment regime of cancer. Secondly, beyond that, there is even a smaller percentage that actually covers the over 70. Primarily, private medical insurance covers the corporate within the employment age group. So that means that after you retire, then you have to go for a retail medical product. And in a number of this, then you may find that due to the steep cost of care of cancer, then the premiums are quite high. So the data is reflective of the limited options that are there when it comes to the over 70. And it's a challenge to all insurers in terms of how can we work together with the hospitals to reduce the cost of care so that we are able to have adequate data from that segment. That also answers the questions around some of the tests that are required for cancer treatment. So some of those tests are also quite expensive, and therefore, again, it calls for how do we reduce the costs of this, because a number of them then end up being paid for out of pocket by the patients due to certain limitations that they have within their covers. I don't know, I'd like to ask Dr. Matolo, would you help me with just giving the conversation around cancer care from a private medical insurance perspective?
So in terms of coverage, what Harrison had said is true. The cost of care is quite high, so you'll find even if there are medical insurance products, and they are there, so it's not like there is an exclusion. I know maybe above 80, I don't know of any covers above that cover anyone above 80 years, other than NHIF, of course. Yeah, but you'll still find after retirement from 60 to 80 years, there's coverage. The premiums might be high, but it is just a true reflection of what the cost of care for that particular population is. Yeah, so that's what I'll say.
Yeah, thank you very much. I think, I don't know if we need to move forward so that we don't echo. I think there's a question that was asked about data on over 70. Yeah, I need to inform you the Kenya Health Information System runs something called a tracker, which covers on events that happen in the hospital. So anytime there's an admission until there's a discharge, we collect all the patient variables anonymously, and it also includes data on age. So in case you'd want specifically on cancer patients who've been admitted to facilities that report through the inpatient system, we have that particular data. Doc has asked me a very good one about civil registration, and it's something I was working on. I think you all know about the e-citizen, right? The same people are developing a system which we're actually piloting today in Mama Lucy, Pumwani, Kayole 2, and Bagadi, to be able to ensure, as I told you, that within birth, within 24 hours, it's digitally recorded and you have a birth certificate. The challenge, I think, has been the user fee and how they'll be able to go through the user fee. I'm hoping the government will be able to take up the 50 shillings that Kenyans pay for birth. So all births and all deaths happening at health facility will be registered within 24 hours. And that is where we are. And community death is exactly the same thing. The chief is also getting, all the chiefs are getting tablets. I think you remember the tablets that were used for census. So we are redistributing them to all chiefs so that any community death, once the chief has recorded it, they're able to upload it into a system aptly. So we hope to go to 100% birth and death registration. And those of you who are familiar with the Kenya Demographic Health Survey, so far 90% of the births are happening in health facilities. So I'm sure within the next 6 months, we'll be able to ensure that 100% death and birth registration. Thank you.
All right, we have only 5 minutes, so we have a hard stop in 5 minutes. So I'll allow you to please ask your question, keep it short. And then Dr. Karagu, we need to close in 5 minutes.
Thank you. Mine is to Wesley. Yes, I just want your quick comment on I was very intrigued by the architecture, the national architecture for well, the health information. So could you make a comment on the unique identifier for all this architecture? Thank you.
Let me.
Let's ask you a question. Ask your question.
Hello.
Yeah, it's okay.
Hello. Hello, everybody. My question is to the digital information passed from the doctor to doctor. If I'm a cancer survivor of 14 years, I'm from Nyeri. You say that it will make it quicker for one doctor to know about my diagnosis from Nairobi back to Nyeri. What about the patient herself or himself? Will she or he have that information if we go digital? Another question is to Dr. Karagu. Yesterday he said about training 90,000 CHVs. Are the cancer survivor navigators or champions included in that? And one more thing is the NHIF. Everywhere I visit those expecting their insurances, they're only saying about gold, bronze, and silver, and whatever. What about the ordinary person who usually pay 500? The NHIF is not catering for us. They usually tell us to put a front of 2 years. If I can't afford the 500, surely can I afford the 12,000? And another one, I can see the doctors are here, the surgeons are here. Cancer survivors, this one take home. We need beautiful scars, not something I'll look every morning and get scared of for the rest of my life. We need beautiful scars.
All right. Unfortunately, I have to close this session, so I think I'll give Dr. Wesley and Dr. Karagu 1 minute each to respond to those questions, and then we close the session. I'm very sorry for the ones who I haven't given you a chance.
So I think I've been asked, let me just give a brief overview of how we're working with the unique identifier. I have already informed you that once you get born within 24 hours, you'll be able to get your birth registered. So I think, I don't know how many of us are familiar with something called the IPRS, the Integrated Population Registration System. So that means everybody, each of you, you have a number that probably you're not aware of that links you either to your ID, to your passport, to your KRA PIN. So what we're doing with the birth registration is that once you're born, just like in the States, you'll be able to get an IPRS number. I think you've heard them talk about the social security number. So once you're born, that is the number you'll be able to get within the system of the IPRS. Just the same way KRA has your PIN with A or B starting with, we're having a number for health. Because we realize as health, we have different requirement, maybe different from interior. For example, if I have your number, I would want your number not to be aware of the 12 digits that identifies you, because that means I can be able to search you and get your medical history. So what we'll be able to do is, using the standard government documents like your national ID, we're able to get your number from the IPRS and generate for you a unique identifier, 12 digits, to be used within health information systems. That means within the system, you'll not have your name or anything that can uniquely identify you. But your data can be able to be shared across with that particular number without being able to say critically, this is Wesley who is sick. But once you come to the facility with the ID, the system will use the ID to link to the IPRS number and link you to the unique identifier. So one of the few things that is going to be an enabler is that we already have numbers that are in existence. For those who are below 18, chances are you're in school. How many of us know NEMIS? So that NEMIS is part of what we'll be able to use as we'll be generating the unique identifier. But the most critical part of the people we are looking at are those who are born and do not have any identifier. And the only identifier you tend to have is your birth certificate. And that's why we want within 24 hours, you have your birth certificate and you have an IPRS generated number, which you can be able to use in all these systems. I think that is able to answer. The lady from Nyeri, thank you for the question. You asked about availability. Please, we are guided by our constitution that demands you have the right of information. And one of the few things that those of you who are in the techie world, our aim is not to be able to develop an EMR, but rather an EHR. An EHR means, for example, if you knew me 5 years ago, I used to be very big. I've done some intervention, I've lost some weight. We want that details of your exercise, details of how many steps you've taken to be part of your health. I think you'll agree with me, the doctor comes and tells you you need to shed about 5 pounds. We need that to be part of your medical history, saying from the last time you came here, you've shedded 20 pounds because you've been walking, or alternatively, you've been sitting and you've added another 5. So that is the vision, what we envision, an EHR, not an EMR, that encompasses not only what we provide for you as medical care, but also what you're able to add. I think those of you who are familiar with these apps, so that those apps that you use for exercise and anything else forms part of your medical data longitudinally. I hope that makes sense. I think that was the last. Thank you.
Mine may be very brief. I am not the one who committed to train 90,000 community health volunteers. So let me put out that very clearly. That was a commitment from my cabinet secretary, and I don't get paid enough to speak on her behalf, but I'll try. I think I would think the program targets community health volunteers across the country, and I believe in many settings, you'll find that as part of community units, you have survivors, engaged through community units. So for me, where I see it, that probably would be the relation between the training of CHVs and, a participation of survivors. So that's what I can say for now.
So thanks a lot, Dr. Karagu. So at this point, I'd like to close this session. Thank you very much for coming. Thanks to the presenters, to Harrison, Ngure, Anthony, and Wesley. And I hope everyone enjoyed this session. Please take note of the presenters if you want to catch up with them later. Thank you very much, and I'll hand over to the next session.
Good morning, everybody. Wasn't that a very interesting conversation? Right, I'm looking forward to I think I caught the word was interoperability of various systems. That one day, as a healthcare worker, as a survivor, as a patient, as the community, can go to a portal, click and get my support. Wouldn't that be easy for us, right? I can get all the people that I need to know, or to know all the facilities that can support me. So that was a fantastic conversation. So I hope you had a good night. You all look great today. I'm ready for day 2. Our second breakout session, just a little bit change in terms of the program, the venue. This room will be for research in cancer, how research improves cancer care. So that's what's going to be in this room. And then the other breakout room, community-focused best practices in cancer, will be in the other room, Jumbo 1. So I think I got that right. So here, for those who want to remain for research in cancer, you can remain. Those who want to proceed for community-focused best practices in cancer can go to Jumbo 1. Thereafter, at exactly 10:30 a.m., we break for tea. And as we break for tea, I think you saw as you came in, there was a whole layout on the foyer there where you can meet various practitioners who can support you. It's an open day for you. You'll meet with KDA, Keshaw, KPA, CAP, COGS, pathologists, BTAC, KCS, KENCO, the Nursing Council, oncology nurses, and they're all set out there, and you can be able to engage and interact with them. And then we reconvene for plenary at 11:30 a.m. All right? So our program follows, and then now we'll have our closing ceremony. Is that clear for everybody? All right, excellent. You can now proceed to your second breakout session.
Kenyatta University Teaching, Referral and Research Hospital is the boldest, most sophisticated health facility initiative ever undertaken in Kiambu County and Kenya.
So today is truly a historic day. We are gathered here to witness yet another bold step as we as a nation inch closer towards the national rollout of universal health coverage. And I'm therefore deeply pleased to join all of you today to commission this hospital, the Kenyatta University Teaching, Referral and Research Hospital.
A project that has created a global health center that ensures Kenya and the region has world-class facilities that cut across the entire health arena to serve generations and contribute significantly to the Kenya Big Four agenda, specifically universal healthcare for all and the global sustainable development goals.
The hospital has continued to be an amazing development in this sector, specifically because of the new ways in which it adopted in terms of policy, in terms of treatment and general healthcare improvement and reform.
Kenyatta University Teaching, Referral and Research Hospital is a 650-bed capacity hospital with state-of-the-art medical equipment.
It is one of the iconic referral hospitals within the Ministry of Health and even for this country. And we say that because it is a modern hospital, it has been built and equipped with the latest technologies that are available globally.
The hospital is located on a 100-acre piece of land that lies in the northwestern part of Kenyatta University, bordering Kahawa Barracks to the south and the Northern Bypass Road to the east. The main entrance to the hospital is on the Northern Bypass Road, near Kahawa West. It is easily accessible from main roads and public transport services. The hospital also has a helipad, a landing strip to enhance access. Following the preparatory phase of design and preparation jointly carried out by China Jiangxi Corporation and Kenyatta University, groundbreaking was undertaken in 2011 with the objective of providing a world-class healthcare in Kenya and the region. Kenyatta University Teaching, Referral and Research Hospital was the brainchild of Professor Olive Mugenda, who initiated the preparation of the proposal and leading her team from Kenyatta University in making a case for the hospital through the Minister for Finance, who is now the current president, President Uhuru Kenyatta. The government approved a government-to-government loan from China Exim Bank for construction and equipping of the hospital. The hospital was constructed and equipped at a cost of 8 billion Kenya shillings.
I'm very delighted to see a vision that we started 10 years ago being actualized and saving lives, particularly at this time of COVID-19 pandemic.
It was the founder's vision to establish a world-class healthcare facility which will reduce to the barest minimum traveling out of Kenya for medical care abroad and, at the same time, attract medical tourism from other countries in Africa. Our vision is to be a premier national referral hospital renowned for clinical excellence, medical training and research that enhances quality of lives for Kenyans and the regional citizens. Our mission is to enhance quality of lives through provision of quality, patient-centered and evidence-based healthcare, training, innovation and state-of-the-art technology. Built and benchmarked with international standards to provide world-class healthcare. It is headed by a team of dedicated, experienced and qualified doctors supported by a professional cadre of trained nurses and paramedic staff. KUTRRH houses advanced and sophisticated clinical and surgical facilities, providing comprehensive care to address all aspects of health, from prevention to diagnostic and treatment to rehabilitation. Deliberately and carefully built in the fabric of KUTRRH is quality. The KUTRRH Board of Directors is responsible for the management and administration of the hospital. The major directorates of the hospital are Clinical Services, Nursing Services, Corporate Services and Administration, Finance Strategy and Planning, Training, Research and Innovations. At KUTRRH, we believe quality is never an accident, but a premeditated effort. The hospital is among few in the region to function with full-time doctors system that assures doctors' availability around the clock, giving dedicated time and attention to patients.
We mainly deal with offering clinical services and ensuring that all patients are treated accordingly. My division is very wide and it encompasses a lot of various disciplines, majorly of which is oncology services, accident and emergency, trauma and orthopedics, where we are able to perform surgeries. We have a fully established pharmacy, which is able to provide nearly all kinds of drugs. In terms of laboratory, the whole pathology area, we have a well-equipped laboratory. We are able to do state-of-the-art tests.
The highly sophisticated medical center shall offer quality medical care within the following units: outpatients, accidents and emergency, pharmacy and diagnostic imaging, inpatient services, pathology and lab medicine, critical care, medical and surgical, special internal medicine, oncology, renal and neurology, obstetrics and gynecological services. Oncology Cancer Unit. The ultra-modern oncology unit is a beacon of hope, health and happiness.
Our flagship project is Oncology Center, where we are dealing with cases of cancer. And we are undertaking very good services in radiotherapy and also radiology treatment with great outcomes.
Good morning.
The team of
Good morning. I want to call this session to order. This is research, discussion on research. There was a flip or a switch on the room, so kindly check that you're in this correct room. This was before it was for community focused. They're in the other room. So you are for community focused practices in best practices in cancer. You go to the other room. If you are for research, how research improves cancer care, then you're in the right place, okay? So good morning once again. My name is Dr. Samuel Gadere. I'm a clinical scientist at the Kenya Medical Research Institute, and I'm also a board member at the National Cancer Institute, and I'll be your session chair. So we'll start by having the CEO of NCI, Dr. Alfred Karago, making a presentation. Dr. Karago has also doubles up as a public health specialist for over 12 years, experience in clinical care and health services management, monitoring and evaluation, training, and public health research. So as he sets up, we are talking about how research improves cancer care. And I think that's a very important thing because people have been saying there's no research, but ideally why we want to do research is we want to see how would it improve cancer care. Whether it's basic research that tells us about trends or incidences or prevalences, or whether it's clinical trials that talks about outcomes of treatment. Okay, Dr. Karago, you ready? Okay, he's still waiting to get set up. So I think that is what we want to discuss. Yesterday we had a session, a discussion about research, and we were talking about someone from the counties, several people from the counties, and we asked how much cancer research is going on in the counties. And okay, he's ready. Let me just finish that question. And they say there's not much that is going on in the counties. So as you think about it, think also about the counties. So welcome, Dr. Karago.
Thank you, Chair, and good morning all. I'm here to make a brief presentation to set the stage for the panelists who will be, reviewing how far we have come in terms of research and how it relates to our situation. We're making reference to the discussion that we started yesterday, and part of understanding the status of cancer in Kenya, we must ask ourselves, noting that research is part of the key component of the cancer control continuum, how well are we doing in terms of applying research in what we do? And already we know that generally, even from the task force report that was launched last year, there has been fairly low prioritization for research. Funding has been fairly markedly low, and the coordination of research has been poorly coordinated. So there are different things happening all over the place, and probably that's part of the panel discussion that will follow. And then the critical question is that with all this in mind, what then is the relationship between the burden as we know it, or the status as we know it, and the various research efforts that are ongoing? So I believe we were all able to appreciate what our data speaks to. We see that the 4 top cancers account for half of our cancer burden. Breast cancer, cervical cancer, cancer of the esophagus, and prostate cancer account for 50% of our burden. In terms of childhood cancers, we see leukemias taking quite a bit of a proportion of this, taking a high proportion of the cases at 15%, kidney, brain, lymphoma, and so forth. So the question I think that arises then is how well aligned, or how have we structured our research efforts in realization of this burden? I think that's just a bit more description in terms of males and females, how cancer is distributed across, across different sexes. This is also part of the report, and when we analyzed our data, we were trying to understand how much of different counties are represented in our national cancer database. And we are able to appreciate that you won't be able to say that, but the top 5 in terms of county of residence was Nairobi, Nakuru, Kiambu, Machakos, and Nyeri. So the question is, if most of the cancer cases are coming from these localities, then what are we doing in terms of understanding the drivers of this, of this burden? So to try and just paint a picture of what we know about research, I will make reference to some work that tried to scope the status of published research in cancer in the country for the period 2007-2017. And largely this was based on a literature search of the major databases, the PubMed, Medline, all these major databases that you'd find published health information. And there's also some element of, conducting a hand search of various pertinent journals and even grade literature, for the various documents that we publish around cancer. So really what we're looking at is the article of interest had to be about cancer. It must be a human study. Kenya must have been either, the study must have been in Kenya, or Kenya must have been part of a multi-study. And of course, we are looking at original research. So ultimately, after going through a very laborious process of inclusion criteria, removing duplicates, and all that, we zeroed in on we focused in, we were able to pick out about 284 published articles over that 10-year period. So when you look at the distribution in terms of cancer types, what is interesting is that cervical cancer is the most researched over that 10-year period, accounts for about, I think, almost 40%, 30 to 40% of different, of all studies done. And then followed by breast cancer, back hits, cancer of the esophagus. But then what we must then realize is some fairly high burden cancers like, prostate cancer, non-Hodgkin's lymphoma, colorectal cancer. Not much really has been done in terms of, research in this country. So probably that's where the conversation begins. In terms of where this is being done, we see that the bulk of these researches are being done in Nairobi, Kisumu, Uasin Gishu. And probably that is aligned to the location or the capacities around these, centers. Your KNHs and University of Nairobi are in Nairobi, Kisumu, probably because of Kemri, Jotia. So then the question is, then what happens to the rest of the country? So I think this is important for us to be able to appreciate what is the spread of research, cancer research, targeted cancer research in this country. And this next slide basically speaks to that. The bulk of these studies were being done in the likes of Kenyatta National Hospital, Moi Chichikan Referral Hospital, Kemri, so we're able to appreciate the distribution of where most of this research is being done. And I think the final reflection that I wanted to make is looking at what we are doing research, but what kind of research are we doing? And what you might be able to appreciate is that the bulk of our research is fairly descriptive, cross-sectional studies, a bit more in terms of retrospective, but as we move towards the right side of the slide, the second last bar actually represents clinical trials, and I'm sure Professor Mansour would be very interested in that statistic. Only, I think there were only 8 out of 284 papers. Only 8 were on clinical trials around cancer. So I think that's the other dimension that would be important in this discussion. So as I end, because I want to save on time, probably what we see is that definitely there's a mismatch between where we have focused on research and the burden as defined by our data. Definitely there are more research efforts concentrated in the major training and research institutions. And when you look at what kind of research you are doing, a lot needs to be done in terms of your interventional studies, your clinical trials. So, Chair, I'll stop there. Thank you.
Thank you, Dr. Karago. And now I would like to introduce the panel. We have our moderator, Professor Alice Mutungi, who is an associate professor of obstetrics and gynecology and a public health specialist. And also she's the head of the bioethics at NACOSTI. Okay, you'll say it. She's also at NACOSTI, okay? So kindly come forward. We also have in the room Professor Mansour, who is the chair of the Department of Hematology Oncology and consultant medical oncologist at the Aga Khan University Hospital, Nairobi. Welcome, Professor Mansour. We have Dr. Mikhail Ayiro, who currently works at the Pharmacy and Poisons Board of Kenya as a regulatory pharmacist. Karibu, Dr. Mikhail. And then we have Dr. Kimani, who is an assistant professor at the Department of Medicine, University of Utah, USA. He's also a board-certified internist, medical oncologist, and hematologist. I'm not sure whether any of the other panelists are around. Dr. Is she here?
She should be. I saw her.
Okay, Dr.
She is replacing who
This Huwaida. Okay, Dr. Angela. Oh, you're replacing Dr. Huwaida? Yeah? Okay, have a seat. Yeah? And Dr. Marion Sarego from NACOSTI. So I need to add you more chairs. So I hand over to you, moderator, then I can give you, add you the chair.
Yeah. Thank you very much. Good morning, everyone.
Thank you for coming for this session. Panelists, you are most welcome. We'll start right away because, you would see our time was eaten a bit by the other presentations which were ahead of ours. But I'll introduce myself, like I've been told about NACOSTI. I'm the chair of the National Scientific and Ethics Committee at NACOSTI, formerly National Bioethics Committee. National Bioethics Committee, I was a member still and chair, but from 2021, our mandate was expanded. We were dealing with research and ethics, but now the mandate of the committee is expanded to deal with the matters, the matters of ethics in STI, science, technology, and in innovation, because NACOSTI, that is their mandate of dealing broadly. So this committee, 1 minute only I will say about it. The committee is one which assists NACOSTI to determine the ethical standards of the protocols or proposals that are submitted, which have already been reviewed by institutional scientific and ethics review committees. The National Bioethics Committee used to review the proposals, but they became very many, so the NACOSTI accredited institutional bodies or review committees to review on behalf of NACOSTI for the permit. But NACOSTI scans through for the science bit, then ethics, very serious consideration before the permit is issued. That's what I would say. I hope I'm okay. I've done justice. Yeah, thank you. So our panelists, most welcome. You've been introduced, so I think we can go straight to business. And I will start with Prof. Mutuma. Didn't come, eh? Yeah. Yeah, some of the panelists we were expecting didn't come, but it's okay. We'll still do with the topic of research. And thank you very much, Dr. Karagu, for setting the mood. And I think when questions are being asked, Dr. Karagu, I hope you'll be able to join us when we open it to the audience. But now the panelists will first of all deal with the issues that we'll discuss. Then we'll give you time to also respond and also ask you questions. Now, I'll start with Dr. Kimani. Dr. Kimani, with your experience in implementing cancer research, including clinical trials in Malawi and the USA, what are the foundational elements that are required to enable high-quality clinical trials in resource-limited settings?
Thank you, Professor Mtungi, and my colleagues and panelists. I also want to acknowledge the NCI, especially Dr. Karagu and the organizing team for this first Cancer Summit. It's a privilege to be here. So, I think when you think about clinical trials as a broad term, it encompasses various things. We do trials to figure out new ways of treating conditions, or new methods, or new pathways of care. And generally, I think of at least 3 key fundamental blocks. So interest, investment, and infrastructure. On the interest part, I find that when you have a very motivated and interest panel of investigators, either in academic practice or in private practice or in industry, no matter where the investigators are from, it's important that we owe it to our patients to have the interest to figure out new ways of treating cancer or new methods of delivering care or new ways of being efficient in what we do, especially in our own backyard. And that also applies to other stakeholders, including regulators and government agencies, whereby if you are part of the regulatory framework in clinical trials, for example, the NACOSTI or the various IRB, having a streamlined process that bears in mind that advancing clinical trials is part of advancing clinical care for patients who need urgent and appropriate interventions. So therefore, being a facilitator in expediting that aspect of it. And then investment has been talked about a lot today and yesterday, and this looks at investment in capital, so money, funding. So having dedicated budgetary support, either from the local governments, the county governments, that addresses their context-specific clinical trials needs, at the national level that addresses investment in capital for infrastructure, which is the third key pillar. And on that point, I'll talk about infrastructure as being both diagnostic, therapeutic, and supportive care. When you invest in infrastructure for supporting clinical trial, you want to be able to ascertain reliably and consistently that you're making the right diagnosis that then guarantees the fidelity of the data that then ultimately impacts care. So just to summarize, I think those three are in my opinion, the foundational blocks. So interest, investments, and infrastructure.
Thank you very much, Dr. Kimani. I will now move on to Professor Mansour. And as a practitioner, Prof, of clinical trials in Kenya, what has been your experience in establishing a clinical trial center at the Aga Khan University Hospital and Teaching Hospital?
Thank you for the question. I'll become like a politician. I will not answer your question. I will give you an answer to my question, but then I will answer your question. I want the audience to understand what is research. If Karago was given $100,000 as a gift, and before he puts it in his pocket, he says, I'm going to give it to the public. Should we spend $100,000 giving clinical care? If we did, we could only treat 50 cancer patients. If you invested the $100,000 in asking a research question, we could treat 100,000 patients 5 years down the road. And our question is, should we invest in today, 50 patients taken care of, or for the future, where a bigger population will be taken care of? And the question also being asked is, why should we do research in Africa? Those guys in America and Europe do it already. We should just accept what they do. Research is identifying the basis of cancer. What is the gene? Why does it happen? So that's basic research. You apply that, which can block the gene causing cancer in a patient, because you have a pill from Roche, for example, that's clinical research. And then the impact of cancer on the patient and the society is population health research. So there are many ways of doing research. If we invested in that, the output down the road would be much more productive for very many more patients. So the question being asked is, how do we do it at AKU? And there are many other places here that do research. The chancellor of the Aachen University 10 years ago said, there are two things shortchanged in the developing world. One is research, the other one is education. 90% of the oncologists here in Kenya, taking care of Kenyans, are trained in North America or Britain. We need to train our own. You saw Dr. Karago provide data. Most of the data we put in here is cross-section studies. We do not generate our own data. Should we? Are we different than the rest of the world? So we have data to show that in triple-negative breast cancer, for example, the genetic makeup of TNBC in the African woman, the Kenyan woman, is different than the genetic makeup of the African-American woman in Alabama, where I come from, and the white woman in Alabama. We have different genes. So we should test the drugs that we get on our genes. And I'll give you an example. Why should we have a drug that Roche developed in the US be tested here? There's a drug called eltrombopag that is a platelet growth factor that we use for ITP. 50 milligrams is the FDA-approved dose. In a clinical trial in the New England Journal of Medicine, A median of 50,000 platelet count raises to 100,000 when you give 50 milligrams. Any JAME paper. There were 14 patients in Hong Kong. They were given 50 milligrams as well. Their platelet count went to 1 million. They got white clots of platelets. The black box warning from the FDA says, if you're of East Asian ancestry, take half a dose. It doesn't say anything about Kenya. Should the Kenyan take double dose, no dose, a quarter of a dose? Which is why the pharmacogenetics of the African patient population is different than the Caucasian or the North American, which is why we should do research here. So when I came to AKU 3 years ago, the basis for us at AKU was they will take the drugs from Roche, AstraZeneca, other pharmaceutical agencies, test them on our patients, see how they work, the toxicity, and the benefit. In turn, we would do our own research. For example, and I'll finish up very quickly, we did a study of tocilizumab in COVID. Tocilizumab costs about $3,000. You need 2 doses. You have to be in the ICU. Expensive stuff. Works very well. We said, what if you give a very low-dose radiotherapy to the lung? It can sterilize the microenvironment. The macrophages, the dendritic cells will not make IL-6. Inflammation will go away. You will not need to be intubated. We're able to show that a low-dose radiotherapy, 100th of the dose that you give to lung cancer, can really sterilize the microenvironment, no toxicity, and benefit. Low-dose radiotherapy, 1 shot, $30. Tocilizumab, $3,000. What we will do in Kenya if next week we have COVID that attacks the lung? We should do low-dose radiotherapy. And we have 3 biomarkers, for example, that says if these biomarkers are elevated, give tocilizumab. If the biomarkers are low, give LDRT. That is science. That is the kind of work that Karagu is talking about that we should do here. And that is what we do at AKU.
Thank you very much, Prof. Mansu, for answering your question first. I'm not sure you've answered mine totally, but we have time. Yeah. Now we move on to our next panelist, Dr. Kiraba. Dr. Kiraba from Roche. Roche has invested in generating evidence on the effectiveness of various oncology molecules in Kenya. What are the key lessons learned so far in the process, and what does the future hold for Roche-supported clinical trials?
Okay, thank you. Thank you, Prof, for the question and for the opportunity to speak here before you all. I want to start answering this question by giving a bit of a background on where we've come from. In 2020, Roche did a bit of a study to see where are we currently sitting when it comes to African populations in the clinical trials that we have. When we looked at it, we saw that the African population made up about 17% of the global population, but yet for our Roche studies, we only had about 63 patients. And then now we estimate that in 2050, the African population will make up about probably 2.5 billion, which will make up about more than 25% of the global population, total global population. So if we keep going at that trajectory that we are going at in 2020, what are the chances that we will have massive inequities in 2050 and we don't have African patients in clinical trials? So then what did Roche do about this? In 2021, Roche made a commitment to have advancing inclusive research as one of the key pillars that we work on. Now, what has this meant for us here locally in Africa? So I'll give an overview of sub-Saharan Africa, but also narrow down a little bit on Kenya. For sub-Saharan Africa, we only had 1 clinical trial running in 2020, and now we have at least 19 clinical trials, others that are still in startup, which may bring that number up to above 20. For Kenya specifically, we have 13 clinical trials running over, I think, more than 10 therapeutic areas, and specifically again in Kenya, we are running these trials in at least 8 sites. And what has this meant? This means that we've had at least 50 patients directly impacted by these innovative medicines and new innovations coming into Kenya so early. Again, this also is impacting the HCPs or the healthcare providers because they get access to these innovative medicines and standards of care very early on, and so they're able to carry this on throughout their professional journeys. So this has been great, and we are able to see impacts to the patients and positive things happening. And some of the lessons that we learned along the way actually came about because of some of the hurdles that we had. So one of the major hurdles was mindset. When we first started, and I think Prof, you mentioned a little bit about that, was people saying this cannot happen in Africa. How can this happen in Africa? But guess what? It happened, and it is happening. It continues to happen. I think we have about 6 oncology trials in startup still. So we have something coming up, and we'll have more and more coming up. So the mindset was one of the key things that we learned. How do you change this? How do you work on this? And it takes a lot of innovation sometimes when you need to talk to these people and to talk to everybody. And everyone here is a stakeholder, actually, starting from patients all the way to public to the private sector. So that's one. The other thing is speed and the timelines. There was a bit of delay in a lot of the approvals that we were hoping to get, and that really impacts in clinical trials. Clinical trials are competitive processes, so every center that is taking part in a clinical trial is competing to get their patients on. So if we are delayed in getting the patients on here, then we will not end up getting the African patients on the clinical trial, and we have no one else to blame except ourselves. So that's the other thing. Then the last thing I'd like to mention is on the partnerships. We could not have done this without partnering with most of the stakeholders that are represented here in this room. It took a lot of co-creation, partnering, helping each other out, and this is the only way we will be able to continue. So the question that I want to leave to the team here is, can we still continue to move, push this pin further in Africa? Yes, we absolutely can do it, but we need to do it together as partners. Thank you.
Madam Chair, if I may kindly add to what she's saying. She talked about clinical trial, and you, Madam Chair, are the chair of NACOSTI. Yeah? Time to trial activation, from the time we sign a CDA to get the protocol to the first patient, is the speed that Irene was talking about. During COVID, the TTA was 73 days. In 73 days, we could put a patient on study. In America, it's about 60 days. We were as good as the Americans. In oncology trials that my colleague talks about, it is 279 days, 9 months. So by the time I put my first patient on, PPB, IRB, NACOSTI, Ministry of Health, the Drug Development Agency will get the drug in. The study's been closed by the Americans already because it's already full. I will get that one token patient. So for us to be able to really be competitive, they have the regulatory system, the NCI, the PPB, the NACOSTIs of the world, to be able to really be up because we are competing against the rest of the world. And to do that, we need research nurses, physicians like me and others to really do this, but I think it is really a team effort, and I think I'm glad that the moderator is from NACOSTI, who can help her colleagues really speed up the train so they can reach the station so that the patients in Kenya can benefit from these drugs that my colleague talks about.
Yeah, thank you very much, Dr. Kiraba and Dr. Prof. Mansour. And now, what you've noticed is that what we've been having are discussions on clinical trials because our presentation, the introduction by Dr. Karagu showed the scoping, showed that most of the research in our country is usually descriptive. So now, and you've seen that 3 speakers who have spoken on clinical trials because now we are going to the other side to do something different and something more helpful to our situations. Now, I'll move on to the regulators, the Pharmacy and Poisons Board, and NACOSTI. And I would ask Dr. Ayido, being a regulator of healthy products and technologies, what are the bottlenecks in accelerating deployment of clinical trials in Kenya? And I will respond, Prof. Mansour, I will respond to your query later after these people have spoken when we are giving the audience a chance. Thank you.
Thank you so much. Thank you so much for the chance to speak, Professor. Now, Pharmacy and Poisons Board. I'll start with what they do. What do? We try to ensure that the patient gets products that are of quality, efficacy, and are safety to use. Now, when it comes to availability, we try to look at the timely availability. And I think Professor Mansour will look at me and stare and say what is timely when we come from 73 days to 200 and something days. Yes, there has been a bottleneck of the timelines. We started quite well. We do the approvals for the clinical trials. And I think when we noted is that for the approvals, we are a number of regulators. So by the time it finishes from this regulator, goes to the next regulator, time is moving. Professor is crying, but as we are doing a part timeline, and the other people are doing their timelines, they are capturing them. But when he adds them up, the process for the clinical trials has stopped on the other side. So what have we come up to do? There's a time we had, I think, some of our meetings, and I think we also involved some of the outsiders like the WHO, one of the stakeholders, and we noted that we can do better by trying to do parallel approvals. So the different regulators stand in at different times, or they can do it parallel so that the timelines can be decreased. That was one of the bottleneck. Another bottleneck we noted, we do have a system on clinical trials. Our system has been up since 2008. Being an era of digitization, I think it's high time we need to revise it so that when you do your applications, all part of it needs to be online. We noted when you do your application, yes, it's online, but there are some documents, you have to attach them separately. When you're doing some variation on your product or your intervention, you have to do it partly online and partly manual. That has been an issue too. So we are trying to see how best we can have it online, fully online. So currently we are updating the system. And in updating the system is not that the Kenyan system. We are liaising with the regional area, regional regulators like the WHO AVAREF, so that they can help us have an updated system. And that system will be regional. And remember, when they give that system, it's a system it can be used internationally. So you are able to do your applications wherever you are. And maybe if you're in Kenya, if you're in Uganda, it will be the same. Unfortunately, now we have those we called, in brackets, the stringent regulators, like the FDA. We cannot access them, but they can access us. So we are trying all the best to see how best we can liaise with that. Remember, for us as a regulator, we've noted we cannot stay alone. There are things which are really holding us behind. And we've realized we can collaborate with the other regulators internationally, at the ESC level, and the other people, we can liaise together. So what we are trying to do is to come up with that system. Already some of the products, we have what we call the priority products, of which anti-cancers are priority products. We have the anti-malarials and all that. So what they are doing is try to ensure that during assessment of those protocols and the data, they can have it done at regional base level. If not, as a country, we can rely on their assessment report. They share their assessment reports. But when it comes to now the data that is derived nationally, who will assess it for us? That was another bottleneck, specifically when it comes to these new molecules, the biosimilars, the biologicals, the mRNA derived. These are molecules I would say we didn't have the capacity to assess them. But what has happened is that most of the officers have had trainings on those products. And AVAREF has taken a chance to ensure that when those products are launched, they can provide a platform whereby the national regulators can have assessment with the stringent regulators, or there's a person you can rely to ask a question about that. That was another area where I think it was sort of a bottleneck. And also what to note, we noted that as a regulator, we are on our own. the sponsor, the PI, they're on the other side unless they want to be inspected or they want their data to be cleared. But what we are saying as a regulator, involve us when you're starting your trials. We have some knowledge. No competence, Professor Mansour, we are there. I know there are people who are trained specific, even further studies on biologicals. But is this training just enough? No. Hands-on is of great importance. Let's involve each other at the beginning so that you are able to move. We are able not to stop your clinical trials when you've finished all the data and you say, no, the design is not regulatory approved. So let's move together from the initial. We also noted there are these stakeholders where we have the patient. As a regulator, to be frank, I cannot say much how much we've engaged with the patient. But what we've come up is that we want to have a stakeholders meeting. When you talk of stakeholders, we'll not forget the patient, we'll not leave out the sponsor, we'll not leave out the PI. We can have different sessions at different times, but we need to know what are their views so that we are engaged together. And as I say, where we are at the moment, we need to work together. Thank you so much.
Thank you, Dr. Ido. Thank you very much for highlighting the bottlenecks. Now we'll move on to the next regulator, that is NACOST, represented here by Dr. Mary. Mary, you know that NACOST is mandated to promote and regulate science, technology, and innovation in our country. What resources and facilities are available to promote research in cancer and particularly in the counties?
Thank you, Prof. And I think most of the issues have been raised. But let us all remember that research in the real sense is supposed to be translated into services, products, and even inform policies. I really like what Professor highlighted. It's actually research that is giving solutions immediately. Just highlighting what the CEO said, he quoted 284 articles published. I can tell you that from NACOST, we have cleared 279 research on cancer, and this is just from July 2019 to December 2022. So it means much of it has not gone to journals that really make, translate into what we really want. So it tells us what kind of research is taking place in Kenya. So what we are talking about here, research, NACOST has 3 roles, actually 4. Broadly, that is advisory, where we make policies, where we identify gaps. We have the regulatory, which is what we are discussing today. We have also promotion and coordination. So under regulatory, we issue research license, and this license is supposed to, we establish or we develop procedures, standards, ethics, and guidelines. So under the ethics and guidelines is where Professor Alice Mutungi falls. She's the National Scientific Ethics Committee, where they accredit all those ethical, institutional, scientific, and ethical review committees. We have a regulatory, which is 107, a regulation that is 107, which gives a framework on how, when you want to establish an ethical review committee, an institutional ethical review committee, what you need to follow. As she said at the beginning, that is NACOST mandate, but because of the much work we have delegated to this committee so that it can oversee for us. In relation with the question you've asked, currently we have accredited 38 ethical review committees across the country. And this one, unfortunately, they fall under 20 counties out of 47. So at least the 20 counties have an institution, either university, a research institute, or a hospital that has an ethical review committee. So NACOST as a regulator and in the ecosystem of ST&I, it is majorly to give an enabling environment for research. I would give you reasons why we need a permit for research or why we need to regulate research. One, it is for national security. If you look at what happened to the COVID issue, we are not sure exactly whether it was a manipulation that was released, because the war, the world war where it is moving, it is biological war and not the conventional war. So we sit under that. NACOST is a custodian of the convention known as the Biological Weapon Convention, and we've learned a lot how these biological agents can be used as a weapon. So for national security, it's good to see what is going on in the research. Then for protection of lives, and this is where the ethical review committees come in. They look through the proposals, check all the quality, what are issues that are related to ethics. Then the other one is protection of cultural values. Some research may not be able to, may infringe into personal space. So the ethical review regulates that. Then it is protection of IP rights. It is in research we get innovations, and this is where if you are to get new products, also for economic gains. So that IP rights we pick and see whether this research is being protected or if there is ideas that needs that protection. Also protection of environment. It is not just any research, it has to be research that either preserves and also maintains our environment. And then we have to ensure the ethical conduct of the research is right. Also for national development. And lastly, assurance of research quality. So as we ensure that all those, as we give that enabling environment, you've seen it's arranged, it cuts across all the sectors. And I can mention that how the counties, I've highlighted on the 20 counties, on the 20 counties, which have ethical review committees. So it means the institutions, or there is other parts of the country where research is not really allowed, because for you to come up with an institutional ethical review committee, you have to apply, and this, it means you have enough research that is going through your institution, then you don't need to take your proposals to other institutions. Then what I wanted to mention, it's about the challenges that are around this regulatory environment. One, as you've heard from one of our regulators, actually we are several. But NACOST will not give you a research permit until we get clearance from them. So we are at the apex. So for us, it takes just a bit, at most maybe 30 days, but of late I think we've gone up to less than 2 weeks. And our system is online. Everything else, you do it online, and even you get your permit online. Then there is one thing I need to mention on ABS, access benefit sharing. The resource, the biological resource, human beings, we are biological resources. We have our tissues, either blood, whichever part of tissue, that is your biological resource. I think as we do this debate, let's remember the National Environment Management Authority is the national authority that guards the ABS. ABS is very important, and that is where our IP issues and also our benefits for these resource, biological resources that we have. Thank you.
Thank you very much, Dr. Nsarigo. I was trying to stop you, but you had very important information to give to the audience. One thing she has said about the permit at Nakosti, I have already received many complaints during this meeting that it's not 2 weeks, the period. Dr. Mansour indicated that it takes, during COVID, it took shorter, now it's long. I will answer that question when we are interacting, when we are responding again after the audience gets a bit of time. I will request you for comments and questions. That's why I wanted to save time so that we can have all these people. We'll have, how many hands are up? 1, 2, 3. You have raised yours so that you have 4. Can we ask 3 per side, the right and left? Then if we have time, we can ask again.
Okay. Thank you very much. This is Dr. Busahala from Moi University, and I want to thank you as regulators. But one thing I've noticed is there's a lot of redundancy in the process. You know, so IREC or whatever, the ethics committee has to look at it, PPB has to look at it, Nakosti has to look at it, and I would like to suggest to you one way of improving this, because as researchers, we have to do human subjects protection course every 2 years. Now, this human subjects protection course is not certified in this country. It is certified under the CITI program, the CITI program, which is not in this country. So I want to suggest that Nakosti brings together all these players, and then you put up a training program that contains everything that you require, so that every researcher can then be certified every 2 years, instead of us having to go and do the CIT program outside, you know, the country. We do it here, and people who qualify within that CIT program will then have everything that you'll require to make your work much easier and improve the turnaround time. Thank you very much.
Thank you to the panelists who are here today. I'm Dr. Diana Mojong from Machakos County. My question, I think, goes to the entire panel. Probably I'd like everyone to give us a comment. I'd like you to address the barriers to research in Kenya, especially with regard to legislation. My question would go to the KEMRI people. How do you guys navigate research in illegal products that are actually, you know, I'll give you an example like cannabis. Are you able to navigate through this without the fear of being prosecuted? The other question would be, with the panelists who are from the USA and the patients who travel there and they are treated with this cannabis and they would like to import it back into Kenya, how are you people able to navigate this situation and actually conduct research with regard to the illegal substances? Thank you.
Good morning, everyone. My name is Dr. Tyra Somondi from Masinde Muliro University. My question is to the Nakotsi. One, why did you relinquish your funding functions to NRF? Because there's a lot of bottleneck, or what I call, you approve, but the money is not reimbursed. So we remain behind with our proposals, and cancer is becoming a burden day and night. Is there something that can be done, like in 2019 to 2023 today? And none, I'm not sure if other university probably got, but none received the fund.
Okay. Thank you so much. Thank you to the panelists. So my name is Chemtai. I'm a professor of OBGYN and I do research in cervical cancer. Similar to what has been mentioned, if we can please harmonize so we can reduce the time from submitting a proposal to activation, because when I look for funding and I get funding to do a clinical trial, and then I go through KEMRI, two-step IRB, takes 3-4 months. My university takes 3-4 months. And then I submit to PPB, and then PPB, I find out that they don't like the template of the protocol. So something very small, but then it sets the researcher back 6 months. And the funding, has limits. So if we can really harmonize, and also when NACOSI is doing approval, have it be very specific. You have KEMRI, you have PPB, check, 10 days. That's how we really help patients. Because if NACOSI has a view of going back to ethics, then this wanaanza kuchambua the things that have been chambuad by KEMRI. So if we can really harmonize, because that can really help. Many of us here are trying to do research, we're looking for the money, but the delays mean the money goes back. Because if I don't activate my trial, the money goes back. So if we really see this as something we're doing to help our patients, to kila mtu akuwe na very narrow scope, very defined, so that I know from the start, if I have all these things, in 6 months, the trial can start. Thank you.
Okay. Okay. So my name is Kalistas Wilunda from African Population and Health Research Center. So we've talked about clinical research, which is important, especially in patient care. But the key to prevention of cancer is actually is understanding the risk factors of cancer. So the gold standard for generating this evidence is a cohort study. And we've seen that most of the studies we do in Kenya are cross-sectional studies which provide the weakest evidence to inform decision making and developing guidelines for cancer prevention. So mine is not really a question, but a comment. I think I'd like to challenge all of us here, especially the National Cancer Institute, that we set up a cohort study to investigate the risk factors of cancer in the Kenyan context. And actually, this study can be, if possible, it can be funded by the Exchequer, because now cancer is a national disaster, is a national crisis, so I think it's important to give it the due attention it deserves and funding. Thank you.
Thank you, Prof, and your team. Two things I would like to raise. The first one, if you are doing a multi-site studies in this country, you quickly get into trouble. For example, if you are in Aga Khan and you are doing with Kenyatta National Hospital and Moi Referral KU, the ethics committees in these different universities approve your study at different times. And it can take up to 2 years. For example, I had my study approved in Moi and AKU and Kichabe, but Kenyatta took 2 years to approve. And imagine if you have been given funding and your funders want some report, because every year they must get a report on what you are doing. So I was just hazarding how we can approach this. I was thinking that maybe if 1 or 2 of the ethical committees in the hospitals have approved of the universities, the other one must be able to comply with it, and then the study is initiated. The other elephant in the house for basic science studies, like mine was a basic science study, is very expensive. Like if you're looking at genetic profiling or looking at genes or molecular studies to translate to clinical practice, it becomes very hard because like my study was consuming 3.7 million Kenya shillings. And although the National Research Fund is available, that money that they give is not enough. So I think for you to enable serious studies, even clinical trials, we need money right from our partners and also from the government and our research institute. So those are my 2 comments. Thank you.
Thank you. Thank you very much for the questions. Very pertinent, very important questions. I wish we had more time, but we'll respond to those ones. I'm told we have like 2 or 3 minutes. I will ask the panelists to respond. Thank you for the comments. Those who made comments, we've noted them, very important. But I will answer one regarding the delay, because that was asked by one of the panelists, Prof. Mansour, and it has been highlighted again by several people, the delays in review. And those days when we were having, is it 73 days during COVID? It is because the WHO, AVAREF, the steering committee and the technical committee and recommended, and the steering committee, PPB and NACOSTI, we are members. I represent NACOSTI in that committee, and the Pharmacy and Poisons Board is also represented. So WHO came up with an idea of accelerated review of protocols and joined the protocols to be joined. We set the timelines. You take 2 weeks to do this. Then, of course, even the 73 days is because also the principal investigators, when they get comments, at times they also delay to get back. So we're trying to see, are we able to do that for the other protocols? You know, this accelerated review where there can be joint review by several bodies who are reviewing the protocol at the same time, including even NACOSTI having a copy to go through as they wait for the final comments or approvals from the Institutional Review Committee. I hope that answers it, but we have a long way to go. Multi-sectoral, when we do a multidisciplinary meeting, then we can discuss that and see how we move forward. Because in NACOST, we are already thinking about it in the National Scientific and Ethics Review Committee. So give our panelists a chance to go through the questions. And please, when you make comments, make your final comment, because we don't have time to come back to each one of us. Thank you.
So my only comment, I have all the mics open. My only comment is, as important as this is, the chai should wait. I don't think we should rush 2 minutes because there's tea waiting for us. If we all agree that the tea can wait, these questions are very critical. Let's all agree, we'll get our chai a little bit later, and let the chairman here and the moderator say, let's spend a little bit more time. Because as I understood it, the time to trial activation is a problem, okay? So we need to figure out, we heard to say we are duplicating effort. It's going to and fro, it's sequential, one after the other. We saw that it'll be parallel. We need to be able to at least have a commitment as to when that will happen. If it could happen for COVID, more people die of cancer than of COVID. So let's do the same thing for cancer. Number 2, we should talk about it, and we did not address all the questions. The only way to do research, and I have a colleague from the US, I came from there as well, you have to have trained research nurses. You have to have biostatisticians who help us. The infrastructure we talked about. How can the NCI, Dr. Carago is here, oh, he left. How can the NCI help all of us really do that better? Because as Angela will tell you from Roche, we are competing within the whole of sub-Saharan Africa, and there are other partner countries who are faster than us. So how do we get manpower? Chita talked about it yesterday. Train our individuals to think about clinical research, not fee-for-service. And how can we really parallel process the application? So we go from 279 days to about 90 days, which is the standard what we see in North America, which is where we're competing with. Should we agree on maybe spending some more time on this?
Are we in agreement? Yeah. Oh, thank you very much. Thank you. You are all very good. Dr. it's you.
Okay, thank you so much for the questions. I'll start with the question on redundancy, and where they're talking about repeating or doing what the other person is doing. What I would say, when we looked at our mandates, there's a place where they're sort of overlapping. They're very clear, but they're sort of overlapping. That's why as regulators, we are working together to see how best to handle that. Remember, we are regulators under different ministries. It's not something we wake up and you say, NACOSTI do this, PPB do this. We are under the ministries, different ministries, that we have to see how best to look at that. When it approaches the legal basis, the law, you know our parliament. So there are things we have to handle it, and as regulators, we know the challenges, but that is an area we are looking at. And remember, when you talk of collaboration, we want to rely on somebody's data. If our protocols are different, we cannot collaborate. If I don't trust NACOSTI as a regulator, we cannot rely on their data. So there are things we are working on it. The big elephant we can talk is just the timelines, but we are looking at the integrities to see how best we can come together. And remember, it's not only on just the approvals. I know protocols has been an issue. There's a time the protocol that came from another country, we were like, no, it's not in our standard. It is a small issue, but it has an impact. So what are we doing? We want to collaborate. How will you collaborate when the standards are different? When I don't trust you. If I don't trust Uganda, wherever they give on reliance, I will not approve that. And remember, apart from that, I will not talk on the political side, because when you have, there are some things like mutual recognition that are quite large, and they involve the legal process. But you are really looking at reliance, which is the easier way to do that, and to standardize our protocols. And that's why we have the World Health Organization coming in to help us standardize them. Sometimes when you have the stringent organizations, FDA, you cannot reach them. To get a data from them, you cannot. But we are trying to use how best we can do that. If we get it through WHO, then it becomes easier. So it's a matter of collaboration for the regulators. We do our best, and we try to bring out those integrities that are on the ground. And I would say WHO has been quite helpful on that data. Another thing is about the requirements. For PPB, I think the website is there. And if you feel they're not what your standard is, please let us know. Sometimes we sit comfortably and you're suffering on the other side. If you don't communicate, we won't know. So it's good to let us know what it is, the requirements that are missing, or their duplication, or whatever you feel we need to add. Remember, you know your product very well, but we'll still come in to regulate that. Something like disposal. How do you dispose of this product? You start a process and then you stop it. When it comes to barriers on research, illegal products, I'll just handle it under the regulatory side. Remember, cannabis is illegal. Act 1994, that is the one that is controlling cannabis. Under prohibited plants, I think cannabis is number 2 or 3 that is listed there. If you look at that legislation, is it controlling, or is it punitive? Read it and you'll realize we still have challenges. We used to have a DDA, which is Dangerous Drugs Control Act, but that was repealed. So we need to look. We need to work together and see how best we can do that. Already somebody will tell me, Mikal, we have cannabis in Kenya. How did it come in? How are they doing research? How did it come in? There are things we need to come together. Is it illegal? It came through illegal way it was imported, or what it is. So we need to look at that, and we need to be informed and try to work together. Thank you so much. Just to wind up, the emerging issues, what we need to come up with, remember, things have changed. Real world data is another thing that is coming up, evidence. Are we able to stand with that? So we need to move with the world and see how best we can handle that. Thank you so much.
Before I ask Stephen to talk, your PPB and NACOSTI, we all agreed, is it possible? European Union has fixed it, the Americans have fixed it. Can we have a centralized Kenyan IRB that regulates all of it? And maybe Stephen can talk about that.
Yeah, and I was gonna, I think it's we've had a very good discussion today, but it sounds like there are common themes of frustration, which is redundancy, redundancy, and redundancy, and especially on the regulatory side. I'm actually impressed that throughout the discussion today, one of the stereotypical things that are considered stereotypical barriers to clinical research in Africa has not come up, and that's funding, right? So that's good. So there are people who have funds, there are people who want to do studies, there are healthcare personnel who have the ability to do these studies, but we are running into roadblocks. What I would say is that when you think about streamlining the process, decisions are made by people. So we talk about regulators as if these are amorphous bodies, but these are actually people who sit and decide what their mandate is going to be. In this room today, we have all the regulators involved in clinical research, and it should be possible to commit to shortening the time to trial activation. That requires NACOSTI to revisit its role at the apex. Are they responsible to go through individual protocol and give investigators feedback about their protection of human subjects, or do they trust that the approval of the 38 IRBs is enough to substitute their oversight to the trials? And if the answer is no, then that's a redundant step that does not need to exist. You can get rid of the 38 IRBs and have NACOSTI do a centralized IRB approval, which allows us to set specific timelines. Basically, if you have a checklist and you've submitted the required 10 items or 12 items, NACOSTI should be able to guarantee time to response within an acceptable time frame, failure to which the investigators should have a recourse to take, because if you're going to lose thousands of dollars in funding because a regulatory body has not yet caught up with the paperwork, I think that's totally unfair to the investigators. And it goes back to my first point about interest. We have to view our role as primarily a moral imperative to advance and take care of our patients. And if you're going to bed at night and you know that you're part of this redundancy system, I think you need to commit to do better.
Okay. Am I audible? Okay. There's something I just want to point out. The 38 institutional, scientific, and ethics review committees, it is a way we delegated that duty so that people don't have to come to the national committee, because that will be overwhelming. So the moderator, actually, she's in a position to tell us, do they have a timeline, those ethical review committees? Do you give them timelines on how they should review the proposals? So before you answer, I just want to point out this. The regulators we deal with are actually specific to the sector. One, I can talk of the Poisons Board. They deal more with human and medicine. So NACOSTI, remember, is a regulator. We don't implement any of this. We only receive, once we get that clearance from Poisons Board, we don't go review. As long as that document has been uploaded, we trust they have done their work. If anything goes, we will use that as evidence that proposal has been cleared by them. The other regulator is KEPHIS for plants. So if we get that clearance permit from KEPHIS, we trust that they are in control of plants and the pests. Also, we get the pest control. We have KWS, that is wildlife. We have NEMA. We have Kenya Forest Service. So you can see it cuts across human, plants, and animals. So for us, those regulators, we only ask their clearance. NACOSTA has always tried to bring all these regulators together so that we have a one-stop. The talk, because already we have automated our services, we wanted them to plug in their clearances so that the researcher is able to see where is the proposal. Is it at NEMA? Is it at Poisons Board? Is it at KFS? And then they are able to, to unlock. Because for us, we will not give you that permit until we receive all those other documents are uploaded. And NRF and NACOSTI, it's after the review of the ST&I Act 2013, 3 institutions were established. NRF took the function of funding. Kenya, which is the Kenya National Innovation Agency, took the function of innovations, and NACOSTI remained as a regulator, as an advisory, and as a promoter and coordinator. So the funding is squarely for NRF and not NACOSTI. I hope that is clear. Thank you.
Thank you. Thank you very much, Dr. Nsarigo. Dr. Kiraba, you are allowing me to, you just say a statement.
Just one statement. I would just like to echo what Dr. said here, is that funding is not one of the major problems. You had asked the question, the barriers of clinical trials in Kenya, and definitely funding is not one of them. I think I can safely speak for the private sector and the sponsors in saying that we are willing. It is one of the pillars that we have within our developmental opportunities that we see happening in Africa. And so we are willing. It is definitely not a problem, and I agree with you there, Dr.
Yeah, thank you very much, panelists. Thank you very much, members. I know I was to say the last statement regarding the delayed approvals. I know, Dr. Kimani, you pointed at NACOSTI. Actually, the delay is not at NACOSTI. I said I got complaints regarding the ethics review committees, not necessarily NACOSTI. But even NACOSTI, we're supposed to get back to you in 2 weeks' time. There have been occasions of delay, but not the 279. That is at the Institutional Review Committee. And by the way, we trust the 38 very, very much. We only skip through because human beings are human beings. And we've gotten instances where big research, a lot of money, is approved, the protocol is approved, but it has queries, and we've reviewed it. It is our mandate, actually, when there is a query, for the committee to review. And even if it has millions of dollars available, we won't allow if it is harmful or not beneficial to our society. Because safety and quality matter. It is you and me and our people. It is not the money. And then, so I'll summarize, sorry. So I just wanted to make that clear, that the delay is not necessarily at NACOSTI. At times they can go a bit, also delay a bit, but we'll look at that. But in summary, we have seen that we really need to do more research, cancer research in our country, and that we need to do more clinical-based research so that we are not always doing what we've been doing before. And we need manpower, trained manpower, particularly nurses. Collaboration is key. So that, and we should strengthen collaboration between various bodies, especially the researchers, because researchers are very important. We can't do without them. The ethics review committees at institutional level, the Pharmacy and Poisons Board, and NACOSTI, and all the other regulators who approve research at some stage. And this is a good recommendation so that as a country, we can look and see how we go forward. Then we need, I won't say redundancy, but we need to accelerate the review process. That is in the positive aspect. We need to accelerate it, and as when we collaborate, we'll be able to do that. NACOSTI has been requested to take lead in ensuring that the review process, the collaboration is strengthened and the review process is sustained. With that, I want to thank each and every one of you for the very active participation and for the very insightful knowledge that we've gotten from each one of us. The panelists, thank you very much. Can we give them a hand, please? Okay, can we give ourselves a hand? Panelists, we also do. I will now return this to the chair of the session so that you can. Thank you so much.
Thank you, moderator. Thank you, panelists. I think we've ended the session. I think Dr. Karago is not here, but as I would like NCI to convince a meeting. This is a very critical thing. Some of us have money stuck, almost going back. So I have a very vested interest. When you're doing that collaboration, call, and I'm sure many people will turn up. Let's deliberate that for a little longer. Let us give our ideas so that as you harmonize this, funding is not an issue. Okay, 10 years ago, if you are not high in the food chain in research, you almost got nothing. Now there's a lot of money tracking down. I feel the frustration. People are getting money, it's going back. So we can, if you agree, we get a meeting, maybe one-day meeting, give us our ideas. I see Professor Mazula has a lot, and we want to speak out. So that's what I would say about this. Otherwise, thank you very much. You're welcome to tea. This room is being dismantled, so we are going back to plenary, I think. But let's give ourselves a hand, and thank you very much.
Babylon have 5 years. Oh Lord, why them a try this girl? Legalize it. Diamond will advertise it. Legalize it. Yeah. The messenger will advertise it. Some call it gambling, some call it the weed, some call it marijuana, yeah. Some of them are calling ganja. Never mind, got to legalize it. Please don't criticize it. Legalize it. Yeah. And
personal ndio akiona amepimwa anakuwa na hiyo kauoga kusema kama vile nimepimwa hivi inaonekana nguvu zangu za kiume itaenda chini. Hiyo ni uongo.
Unapotajwa ugonjwa wa kansa au saratani humu nchini, jamii huanza kujiandaa kualikwa katika michango au harambee, huku waathiriwa wakijawa na hofu ya maisha kuona kwamba visa vingi vilivyoangaziwa vimedhihirisha watu waliolemewa na janga hili. Kulingana na taasisi ya kitaifa ya saratani humu nchini, saratani ndiyo kisababishi kikuu cha vifo humu nchini, huku kukiwa na zaidi ya visa 37,000 kila mwaka. Aidha, saratani ya matiti, ile ya njia ya uzazi kwa kina dada, saratani ya umio au koo na saratani ya kibofu ndizo sababu kuu za vifo humu nchini. Jina langu ni Kimani Karanja. Karibu tuangazie jinsi imani potofu imechangia katika kuepuka kupimwa saratani ya kibofu miongoni mwa wanaume katika kaunti hii ya Turkana.
Turkana anaamini kwa watoto wengi. Watoto wengi ni baraka. Hivi mimi kwa upande wangu naweza kataa kwa sababu tutapoteza hiyo watoto.
Katika kaunti hii ya Turkana, wanaume hasa umri wa makamu wameathirika kutokana na kupuuzilia mbali kupima kwa dhana kwa upimaji wa saratani ya kibofu huenda ukasababisha ukosefu wa nguvu za kiume na hivyo kuathiri uwezo kuweza kupata watoto wengi na kuleta heshima katika jamii.
Kule kwa wazungu watoto 3 na hapa Afrika ni watoto wa 10-15 hasa sisi wa Turkana. Sasa kuna uwezekano inaweza angamiza Afrika. Naona kwa upande wangu kama kuna shida inaweza angamiza nguvu za mwanaume ili azizaa watoto wengi. Kwa Waturkana kizaa watoto wachache wewe una heshima. Waturkana wanaamini kwa watoto wengi. Watoto wengi ni baraka.
Kuwa na bibi zaidi ya mmoja ni swala ambalo hudhihirisha hadhi na heshima katika jamii ya Waturkana, na jaribio lolote la kupima saratani ya kibofu kwa muda limeonekana kama tishio kwa uendelezwaji wa jamii, kama anavyosema Jeremia Nangolong ambaye ni mmoja katika baraza la wazee katika jamii hii.
Sasa hii wanawake wote, sasa hiyo ni kuongeza boma yako iwe na watoto wengi na uwe sita uwe kwako. Ni tamaduni, ni ya zamani, hiyo ni kitu ya zamani, kwa sababu sio kitu ya kukuja kwa sasa.
Na japo dhana hiyo imekuwepo, kunao walioridhia kupima na wamekuwa wakiwapasha habari wanaosusia, jambo ambalo limekuwa kukua mlima katika kaunti wanaotueleza James Angirupei.
Mimi naitwa James Lorot. Hii maneno mbali hii inasumbua wanaume sana. Ni mtu personal ndo akiona amepimwa anakuwa na hiyo kauoga kusema kama vile.
The cancer burden is rising globally, exerting significant.
In Kenya, cancer is the third leading cause of death after infectious disease and cardiovascular diseases. As an institute that was established through an Act of Parliament, that is Cancer Prevention and Control Act 2012, we have a mandate in ensuring that we provide policy advisory to the Ministry of Health. We also provide coordination of cancer activities. We provide regulation and standardization when it comes to cancer treatment centers and other cancer services. And we also house the National Cancer Registry of Kenya. In the year 2021, we did a landscape analysis where we found that our guidelines were not fully communicating to our various partners, those who run cancer centers and the basic population.
With that, the National Cancer Institute of Kenya reached out to Intellisoft to design and develop a digital platform that will enable healthcare providers and facilities looking to establish cancer care centers, a platform to easily access the guidelines and get references relating to cancer care. And for the public, the platform will help them understand what is offered across different accredited cancer care centers.
We felt we needed to be able to improve the guidelines by, one, reorganizing the content of the guidelines so that they speak to each and every person in the different walks of life, and secondly, to digitize the guidelines so that it's made easily accessible across the country. So these were the reasons to why we felt that we needed to do this exercise, because as we moved out and interacted with persons living with cancer, the general community, entrepreneurs who are running cancer centers, it was very clear that the guidelines had the content but were not easily availed or accessible to somebody who was interested in specific content. Secondly, the guideline was quite large, and that also made it a challenge for someone to look for the content. So using this process, we were able to reorganize the content and be able to bring in the key specific areas that are required when you're looking at the basic minimum requirements of a cancer center and combining it with the various designations, either a basic, essential, or a comprehensive cancer center.
The digitization of the cancer care guidelines aims to improve the accessibility to the guidelines for the formation of cancer care centers, centralizing and coordinating activities, resources, and information relating to cancer care management and its prevention.
Our envisionment of this platform is that, one, we would want it to grow. Two, we would also want it to have a dashboard that can be able to showcase the various cancer centers in terms of those with high ratings in terms of service provision, and those with also high ratings in terms of accreditation and in terms of star rating. We also envision that this platform will be linked directly to our website, where both the dashboards can be presented as we present cancer registry data on the dashboards within the website. And we also hope that using this, we can also be able to push and propagate for quality improvement modalities in terms of treatment, in terms of survivorship, and even in terms of best practices for cancer treatment in this country.
The next generation is now. With the Ion Torrent Genexus system, you've got the power to go from specimen to report in a single day, affordably analyze even individual samples, and get insights from challenging samples, with fast automated workflows. You're on a mission to uncover answers that ultimately advance health and one day will improve life for people around the world. Whether your clinical research focuses on the growing list of genomic alterations in cancer, inherited disease, the rapidly evolving infectious disease research, or even epidemiology of the SARS-CoV-2 virus, the Genexus system empowers you to get answers to the people who need them now. Don't waste precious samples or time in your endeavor to deliver comprehensive genomic profiling results. Oncomine solutions for the Ion Torrent Genexus system feature a complete NGS workflow that enables you to go from specimen to report in a single day, in a hands-off, set-up-and-go fashion. With the lowest sample input requirement of any NGS solution and compatibility with both FFPE and liquid biopsy samples, the Oncomine Precision Assay lets you successfully sequence more precious samples, even when tissue is very limited. Simultaneously profile 40 DNA genes and 29 RNA fusion driver genes using the Ion Torrent Oncomine Myeloid Assay GX. Analyze samples for all major myeloid disorders. Now, every laboratory can deliver a comprehensive genomic profile in a single day, with a hands-off automated workflow. Experience easy, customizable gene panel design and iteration for human disease research with convenience and confidence. Ion AmpliSeq on-demand panels for inherited disease on the Genexus system deliver amplicon-based enrichment technology for targeted sequencing with exceptional coverage and outstanding uniformity. Configure your custom panel from an optimized catalog of over 5,000 wet lab tested and scientifically curated genes for research. Everything from hereditary cancers, cardiovascular disorders, to pharmacogenomics, all with single-day turnaround time from biological specimen to variants. Use as little as 1 nanogram input of DNA or RNA and get ultra-sensitive, rapid and accessible results for clinical research in infectious disease. Targeted NGS with the Ion Torrent Genexus integrated sequencer lets you rapidly analyze microbial genomes for viral and bacterial typing, epidemiological studies, and disease surveillance. Get all the benefits of the ultra-high multiplex PCR technology clinical researchers and public health agencies use to assess infectious diseases, with the ease of hands-off, set-up-and-go NGS workflows with customizable gene panels. Where did the SARS-CoV-2 virus come from? How does the virus work? And how is it potentially being transmitted? Rapidly answer the time-sensitive questions in an epidemiological investigation of SARS-CoV-2 with an automated and easy-to-use NGS solution. In this race against time, survey the complete SARS-CoV-2 genome, including all serotypes, with over 99% coverage in just a single day. The Ion Torrent Genexus integrated sequencer and Ion AmpliSeq SARS-CoV-2 research panel provide the speed, accuracy, and ease of use necessary to quickly and efficiently get you the answers you need. Multiple applications, one fully integrated NGS system. Let us show you how the Genexus system can uncover answers to advance your research and further your mission to improve lives and health around the world.
Kenyatta University Teaching, Referral and Research Hospital is the boldest, most sophisticated health facility initiative ever undertaken in Kiambu County and Kenya.
So today is truly a historic day. We are gathered here to witness yet another bold step as we as a nation inch closer towards the national rollout of universal health coverage. And I'm therefore deeply pleased to join all of you today to commission this hospital, the Kenyatta University Teaching, Referral and Research Hospital.
A project that has created a global health center that ensures Kenya and the region has world-class facilities that cut across the entire health arena to serve generations and contribute significantly to the Kenya Big Four agenda, specifically universal healthcare for all and the global sustainable development goals.
The hospital has continued to be an amazing development in this sector, specifically because of the new ways in which it adopted in terms of policy, in terms of treatment and general healthcare improvement and reform.
Kenyatta University Teaching, Referral and Research Hospital is a 650-bed capacity hospital with state-of-the-art medical equipment.
It is one of the iconic referral hospitals within the Ministry of Health and even for this country. And we say that because it is a modern hospital, it has been built and equipped with the latest technologies that are available globally.
The hospital is located on a 100-acre piece of land that lies in the northwestern part of Kenyatta University, bordering Kahawa Barracks to the south and the Northern Bypass Road to the east. The main entrance to the hospital is on the Northern Bypass Road near Kahawa West. It is easily accessible from main roads and public transport services. The hospital also has a helipad, a landing strip to enhance access. Following the preparatory phase of design and preparation jointly carried out by China Jiangxi Corporation and Kenyatta University, groundbreaking was undertaken in 2011 with the objective of providing a world-class healthcare in Kenya and the region. Kenyatta University Teaching, Referral and Research Hospital was the brainchild of Professor Olive Mugenda, who initiated the preparation of the proposal and leading her team from Kenyatta University in making a case for the hospital through the Minister for Finance, who is now the current president, President Uhuru Kenyatta. The government approved a government-to-government loan from China Exim Bank for construction and equipping of the hospital. The hospital was constructed and equipped at a cost of 8 billion Kenya shillings.
I'm very delighted to see a vision that we started 10 years ago being actualized and saving lives, particularly at this time of COVID-19 pandemic.
It was the founder's vision to establish a world-class healthcare facility which will reduce to the barest minimum traveling out of Kenya for medical care abroad and at the same time attract medical tourism from other countries in Africa. Our vision is to be a premier national referral hospital renowned for clinical excellence, medical training and research that enhances quality of lives for Kenyans and the regional citizens. Our mission is to enhance quality of lives through provision of quality, patient-centered and evidence-based healthcare, training, innovation and state-of-the-art technology. Built and benchmarked with international standards to provide world-class healthcare. It is headed by a team of dedicated, experienced and qualified doctors supported by a professional cadre of trained nurses and paramedic staff. KUTRRH houses advanced and sophisticated clinical and surgical facilities, providing comprehensive care to address all aspects of health, from prevention to diagnostic and treatment to rehabilitation. Deliberately and carefully built in the fabric of KUTRRH is quality. The KUTRRH Board of Directors is responsible for the management and administration of the hospital. The major directorates of the hospital are Clinical Services, Nursing Services, Corporate Services and Administration, Finance Strategy and Planning, Training, Research and Innovations. At KUTRRH, we believe quality is never an accident, but a premeditated effort. The hospital is among few in the region to function with full-time doctors system that assures doctors' availability around the clock, giving dedicated time and attention to patients.
We mainly deal with offering clinical services and ensuring that all patients are treated accordingly. My division is very wide and it encompasses a lot of various disciplines, majorly of which is oncology services, accident and emergency, trauma and orthopedics, where we are able to perform surgeries. We have a fully established pharmacy, which is able to provide nearly all kinds of drugs. In terms of laboratory, the whole pathology area, we have a well-equipped laboratory. We are able to do state-of-the-art tests.
The highly sophisticated medical center shall offer quality medical care within the following units: outpatients, accidents and emergency, pharmacy and diagnostic imaging, inpatient services, pathology and lab medicine, critical care, medical and surgical, special internal medicine, oncology, renal and neurology, obstetrics and gynecological services. Oncology Cancer Unit. The ultra-modern oncology unit is a beacon of hope, health and happiness.
Our flagship project is Oncology Center, where we are dealing with cases of cancer, and we are undertaking very good services in radiotherapy and also radiology treatment with great outcomes.
The team of oncology specialists work together to develop individualized treatment plan for every patient with great results.
This team consists of the oncologists, the surgeons, the palliative nurses, our nutritionists, physiotherapy, the pathologist, and our oncology nurses. And once a week we have this meeting, the multidisciplinary team meeting, where we discuss the management of all the patients who were seen in the previous week, so that we can make the treatment of every patient a focused and patient-centered treatment to target the specific needs of every patient.
We offer cancer care services across surgical, radiation, and medical oncology. Every unit is equipped to treat every type of procedure, including trauma and surgeries. The ultra-modern laboratories are equally proficient to delivering high standards of services.
If you look at the infrastructure around this hospital and you look at the keen interest that the government has, if you look at the keen interest that our Cabinet Secretary of Health has in this hospital, and if you look at the need in the market, in the region, and even in the locality for this hospital, it's very clear that if we get our act right, this is going to be a hospital that is a game changer in the region.
Kenyatta University Teaching, Referral and Research Hospital has continued to embark on projects aimed at providing quality healthcare. The ongoing projects include the construction of furnished hostels and apartments that shall provide accommodation within the hospital premises to patients and their families while undergoing prolonged treatment. An important ongoing project is the construction of the Integrated Molecular Imaging Center, IMIC.
We also today had the pleasure of laying the foundation stone for the soon-to-be Integrated Molecular Imaging Center. The hospital is beginning construction. The center will host a cyclotron machine, a PET and CT scanners. We have also laid the foundation stone for this hospital's hospitality center, which will cater for the accommodation and hospitality needs of patients and their families. The impressive equipment, infrastructure, broad services, service range and highly trained staff. Indeed, I foresee the Kenyatta University Training, Teaching, Referral and Research Hospital becoming a leader not just in this country, but in our region and also in the continent.
This iconic comprehensive cancer center shall provide medical relief to Kenyans and beyond.
This center will be the first public center in East and Central Africa, and will go along.
My name is Dr. Nicholas Kisido, a resident in general surgery and oncology general practitioner at International Cancer Institute. International Cancer Institute is a not-for-profit organization with the main aim of providing access to cancer care in sub-Saharan Africa through training, mentorship, and clinical research. International Cancer Institute is one of the designated sites by the European Society of Medical Oncology here in Africa. In Kenya, we have 42,000 cases which are diagnosed annually, and approximately 27,000 cases die each year. Kenya has a population of about 54 million people, and it has less than 100 cancer specialists who are located majorly in major towns and cities. Therefore, this leaves cancer patients from hard-to-reach areas in lack of essential ecological services. Also, during the period of COVID-19 period, the cancer care was greatly affected due to the fear of patients traveling to hospitals, messages from hospitals telling patients not to come unless when it's necessary. Some of the patients lacked transport and food due to harsh economic times provided by the COVID-19 period, and also some of the facilities were closed due to healthcare workers who were infected with COVID-19, leading to closure of these facilities. As you know, every cancer patient deserves optimal care that is achieved through timely diagnosis and treatment, and therefore quality of cancer care provided should not be determined by the patient's geographic locality. Accessibility to affordable cancer medication is also essential in achieving optimal care, and ICI utilizes integrative, innovative approaches to improve cancer through its strategic partnership. ICI was able to support the team on the ground through teleconsultations, whereby we used virtual modes such as online teleconference, and also providing phone consults to the team on the ground, whereby they were able to continue to provide oncological services. In one of the clinic sites whereby we opened an oncology clinic, the number of patients seen from March to September 2020 really increased, and this was due to the number of patients who are able to access the rural facility rather than traveling to the major towns to access these oncological services.
Guess what? Most of my patients were still stage 3 and 4. So what it tells us is that we've got a long way to go, and especially a cancer that is easy to eradicate, like cervical cancer. This is why when you talk about integration from the community level and working closely in the referral system all the way to the referral hospital, we actually need to have a seamless transition of care so that our patients really don't get so much trouble in accessing care.
There are some others who are going through treatment in other places, but since they did not have a support group that they would join, we also incorporated them. And also after realizing that they were going long distance for clinic follow-up, which would be easily done at Makueni, we also registered them in the clinic on their request, and they are part of our survivors group. Survivorship is an area which is not keenly looked at, especially in cancer. After treatment, people feel good that they have gone home, but they have to reintegrate back to the community. The only way they can reintegrate back is when you bring them together, talk to them, counsel them, find out from them what they can do best to help them maybe earn their daily living and be active community members to build our community. And this group, as I am talking now, we are very happy with them because they are just coming for follow-up. I thank International Cancer Institute in collaboration with the Makueni County government for the efforts they put together to ensure that these people were properly diagnosed, properly treated, and in the end, they are standing as a pillar and as a result of the treatment.
IC was also able to offer preceptorship courses on their e-learning portal, and this included more than 30. This included breast cancer preceptorship, lung cancer preceptorship, colorectal cancer preceptorship, among others. And then clinical preceptorship were research and biostatistics, cancer registry, data management, project management, health communication, among others. So the trainees came from various countries in Africa, ranging all the way from Egypt up to the South Africa, on the southern part of African continent.
My name is Dr. Philio Tandisuzo Chova. I'm from South Africa, in the province of the Eastern Cape. I'm working in Madziganiga Zulu Hospital as a clinical manager that side. So basically, one is here in Kenya, in a program that is called Medical Officer Oncology Program that is facilitated by the International Cancer Institute.
My name is Dr. Alex Momanyi. I'm a Part 1 resident in orthopedics, actually here in MTRH. We're the second cohort for the Oncology for General Practitioners course, and it has been a very well thought out program for us. We've had interactions from individuals from South Africa, lecturers and consultants, and specialized individuals and people who are well versed in this field, to provide us with information that will help us, especially in the management of patients, considering that in our current setup, we don't have very many individuals who have adequate knowledge of the management of oncology on its own, because most patients end up being mismanaged or ignored in the peripheral facilities, and most of them are sent out to tertiary facilities or higher tier facilities for management of oncology. This is a well thought out program, especially in...
Okay, if you've had a nice cup of tea or coffee outside there, give me a nice good morning. Good morning. How's the summit so far? It's great? So give me a thumbs up if you think it's great. And give me a thumbs down if you're like, you guys just do better. All right, I think all of us think that it's a really great summit. We've had such great exchanges, great conversations today. I hope your breakout sessions were excellent. Today is our final day together. Then tomorrow we're going to meet in the field, and we are here for our final session together. My name is Wageni, and I'm going to be your host for these sessions until we finish. Just a quick reminder, if I can get, please reduce the echo on the microphone. All right, so as everybody, the delegates who are outside having tea come in, I am reminded to please request the delegates, if we can take out our phones again. They said the photo that we did yesterday on social media was really nice, so let's do another one for today. So please take out your phones. You all look nice, and we're going to take a nice selfie together. Hey, take out your phones. All right, I'm going to take out mine. Let me see if I can get everybody. Okay, the people, okay, I can see one smile. All right, there we go. You all are looking great. So when you go to your social media, I'm told the hashtag is Cancer Summit KE. Please tweet or Facebook or, oh, you look nice. Let me take that picture. And just write one thought that you've had. There you are. This is nice. Take one thought. Please write one thought that you have picked out, your takeout from this summit. Let everybody know how important this summit was to all of us. All right? Cancer Summit KE is our hashtag for today. Cancer Summit KE is our hashtag today. We are at NCI Kenya, I believe, on Twitter, and then all the other social media platforms. So we have our final plenary session now, and then we shall go into the closing ceremony. And right now we're going to talk about partnerships for cancer. And this session will be led by our director, Madam Agnes Kaleche. She's going to take us through this session. And after that, then we head on to our final closing ceremony. Madam Director, karibu sana.
morning, good morning, good morning. Or is it afternoon? Okay. So good morning, ladies and gentlemen. On behalf of National Cancer Institute and our amazing partners, we welcome you to this exciting session on Partnership for Cancer. They say it takes a lot, a village, from patients themselves, organizations, scientists, academia, biotech and the public sector, and many others to move the needle for cancer care. And this means a lot for the survival of cancer patients. My name is Agnes Kalechenguna, and I'll be chairing this session, which will take 1 hour. There'll be 4 presentations, and each speaker will have 10 to 12 minutes for their presentation, which will give us around 15 to 20 minutes for Q&A. Today, we have very, very exciting presenters, and I would kindly request them to come on stage. Please come on stage. Our presenters today, Ms. Ada, Marlene, Mr. Mutai, and Dr. Komatso. Please come on stage. Let's give them a round of applause as they come. Thank you. I think I can say Mr. Mutai. Thank you. Thank you for being here. It's good to see you all. So we'll start so that we save time because we are running short of time. I would like to introduce our first speaker, who's the Director for Social. Please sit on the other side. Thank you for cameras. So our first speaker is the Director for Social and Political Pillar of Kenya Vision 2030 Delivery Secretariat. She has a wide range of experience ranging from development, NGO, world, and the public sector. She's an expert also on governance. Today, she will talk about final lap to Vision 2030 private sector collaboration in the social pillar. Ladies and gentlemen, please welcome Ms. Ada Mwangola, the Director of Social and Political Pillar at the Vision 2030 Delivery Secretariat, to the stage. Ada, please come to the stage. Yeah. No, they're going to play it.
Still good morning. Good morning, everyone. All protocols observed. I will go straight to my presentation. I hope it can be mounted, but otherwise I could just read through. So I'm not Mr. Kenneth Mwige, that's our Director General, but I'm here to represent the Secretariat. Okay. Okay, let me, I can use this, I point it there, okay. Let me just use this. Yeah, so I'll have a very brief presentation on our last lap and the partnerships that we require for Vision 2030 to be realized. So my outline is a brief on what Vision 2030 is, but I can see most of us in the hall are Kenyans, and we will be very familiar with this, so I'll brush over it very quickly so that we have more around the substance on health. Implementation of the Vision 2030, our mandate, the health sector, flagship projects and their performance, and what is the final lap and ideal partnerships that will be needed to help us cover this final lap. So Kenya Vision 2030, as you all know, is our national vision, launched in 2008, and it's the long-term development blueprint that we've been implementing since the year 2008. The main goal is to create a globally competitive nation, but also to realize an industrialization and middle-income country providing a high quality of life to all of us. I want to emphasize a high quality of life because that is where the substance of today's topic is around. So it is implemented around 5-year plans, medium-term plans. We have completed the first medium-term plan, that ended in 2012, and then we had the second medium-term plan that ended in 2017. And as you all recall, this is the time when we had the new constitution, implementation of the new constitution. So we had county governments for the first time, and that they also developed their county integrated plans at that level. So we had two plans at the national level and at the county level integrating into each other, and there were lots of lessons around that. So came MTP3, which is on its final lap. It ends this year in June. And in July, we will launch the fourth medium-term plan. And that will bring in also the third tier of the county integrated development plans. Now, remember, these plans are in tandem with the political cycle. So in the next medium-term plan, that is medium-term plan 4, it is integrating the Kenya Kwanza Manifesto ideals and plans. So let there be no doubt that Vision 2030 is different from the administrations that come in. And that is why the 5-year plans are synchronized, so that the incoming administration is able to implement their ideals and push the vision towards its ideal goals. So our mandate as a secretariat is to spearhead the vision through coordination, through monitoring and evaluation of the various flagship projects across the 24 sectors of the medium-term plans, and ensure that all these projects and programs that are contained in the MTPs are funded, launched, and completed on schedule, so that by the year 2030, we'll be measuring our success against the goals and ideals that we had set in 2008. So very quickly, I've talked about the overall goals, but the economic pillar, as you can see, aimed at achieving a 10% GDP growth. The social pillar aimed at achieving a just and cohesive society in a clean and secure environment. And again, this is where we need to have in mind, what does a clean and secure environment, a healthy living, entail? And the political pillar, of course, an issue-based, people-centered, result-oriented, and accountable democratic political system. And then we have the foundations, where these 3 pillars sit on. And these 3 pillars are founded on the foundational sectors. For example, infrastructure, innovation, ICT, national values, our national values, which are very integrated with our behavior as a people and as Kenyans, so that we achieve our goals, because certain behaviors will not allow certain goals to be achieved. Let us narrow in now to the health sector, which is one of the key sectors under the social pillar. And under the social pillar, we aspire to have equitable, affordable, quality health care. But the topic before us, you will realize that it's cross-cutting across all the pillars. And in a moment, we'll get to that. And within the health sector, there were several flagship projects that have been implemented over time. Currently under the MTP3, which some of them were carried forward from MTP1 and MTP2, Social Health Protection Program, Medical Tourism, Health Infrastructure Program, Community High Impact Interventions, Digital Health, Human Resource, and Quality Care for Patients. And you realize that all these projects are cross-cutting. They integrate, even though the health sector is the lead, but they integrate other sectors to come in. So what has been the performance so far within the health sector? And very briefly, according to the reports that we do have, is that we do have a large increase in registration within the NHIF program that mainly drives the social health insurance program. And yesterday we had our CS mention that is the direction that NHIF is taking. And so you will see those numbers probably reach almost the whole population in Kenya, that everybody will be under the NHIF. Linda Mama program that has really helped improve our indicators on maternal health. That has been very successful. The health insurance subsidy program that was targeting the vulnerable groups in our society also increased substantially. Not enough, definitely a long way to go, but it covered some ground. It wasn't there before, and it wasn't measured before. We've seen an increase in our key levels of hospitals, level 4, 5, and 6. Level 6 at the national level, we now have 5 hospitals. Initially, during MTP1, we only had 2, KNH and Moi Teaching in Eldoret. But now we have 5 of them. We have over 80 level 5, that's at the county level, the highest level at the county level, and over 100 level 4 hospitals across the country. We are really proud and love to showcase Kenya Medical Training College that has over 71, a total of 71 campuses countrywide, which means there's a huge focus on developing our human resource, and it can do better, especially at the specialized levels, the oncologists, the kidney specialists, and so on, because that is where you realize a lot of deficit. Now, what are the ideal partnerships that we are seeing around that ecosystem of the health sector? The county governments have a lot going on, and experiences are varied from county to county. But clearly here, we want to develop policies at that level to prop up our health indicators, improve cancer surveillance and data, and that has been talked across even in the sessions that I was in this morning. Cancer surveillance, I had a new term, cancer navigation for the patients, which was very interesting for me. It's a takeaway from one of the sessions this morning. And then the PPPs, how can private sector directly integrate with this sector? It's health interventions, it's infrastructure and health facilities, equipment for the various facilities at the county level and national level. In terms of human resource, offer scholarships for health workers, conduct research on how to cure and prevent diseases, and that again brings in the community health perspectives. We have health insurance. Our various private sector establishments out there. Can you relook into your costs? Because cost has come up very strongly in the sessions yesterday and today about affordability and how we lower this cost. And no wonder it is on top of the leadership of the ministry that let us do the social health insurance. Infrastructure developers, can we partner on investing in infrastructure, especially level 5 and level 6, put equipment? And as we equip these hospitals, let us not forget prevention measures, because again, that has come out very strongly. We need prevention measures popped up. The ideal situation in the vision is a healthy society in a clean and secure environment. So you see the integration there. It is not about many hundreds and hundreds of hospitals with the top-of-the-art facilities or top-of-the-art equipment. It's a healthy people. So let us go preventive. Local manufacturers, locally driven natural health products. I think we had that in one of the sessions yesterday, which was very interesting to me, that communities also think at their own level of curative measures, and some of them really believe in them and they've worked. So how do we integrate these perspectives, cultural perspectives and so on, which are so important to our people. My final slide is about the intersection of all these sectors into the health sector. You know, think about it. There's housing, you know, the spaces that people live in. There's environment. There's nutrition. Again, our agriculture sector, how are we influencing that to promote policies that, that produce nutrition that doesn't harm us? There's a bit about the political pillar, about rights, you know, civic education. How do we create awareness for people to understand what they're supposed to do, where they're supposed to go, where do they get information, the kind of medication they're fed with. You know, that's a rights perspective. And then the targeting of vulnerable groups, the gender perspectives. This whole dynamic about inclusivity is one of our key sectors in the vision. So the way forward is, let us look also broader than just the health curative perspectives, move into improved nutrition, the infrastructure that we interact with, our houses, our roads, our paths, our school environment, even the hospital environment itself, all these institutions, our work environment, how does it look like? Pollution control. You know, I've had some, if you're in some of these housing estate groups, you know, I'm in about 3 estate groups, and I hear a lot about pollution. You know, there's a factory that has come in the neighborhood. How do we stop this? I hope I'm talking to NEMA people in the room. You know, who knows somebody in NEMA, because this is not fair. We are breathing bad air. Public awareness, again, I've talked about that. So how can we develop partnerships that speak to the whole ecosystem, that speak to preventing us from getting not just cancer, but non-communicable diseases that are influenced externally? I will end there, and thank you very much.
Thank you so much, Ms. Ada Mangola, for that presentation on what the public sector through Vision 2030 Delivery Secretariat is doing on the social and political pillar to ensure that Kenyans have access to a safe environment, and that includes health. Now, we've heard from the public sector. Let's hear from the private sector. Our next speaker has an exciting presentation on how cancer care in Africa is being reinvented through across selected cities, including some cities in Africa, through the power of multiple stakeholder partnership. She is the project coordinator at City Cancer Challenge, supporting Kigali to improve healthcare access to quality and equitable cancer care. Today, she will talk about PPP for Cancer, City Cancer Challenge. Please welcome Marlene Mumukunde to the stage to give a presentation. Welcome, Marlene.
Thank you so much. Good morning, everyone, or good afternoon. It's now officially good afternoon. So I'll briefly take you through my presentation, if they'll put it. Yes. So on Partnership for Cancer, and just to start a bit on a context on what City Cancer Challenge does. So City Cancer Challenge was launched at the World Economic Forum back in 2017 by the Union for International Cancer Control, and it was later on established as a standalone foundation in 2019. Our mission is to support cities. We support cities around the world as they work to improve and provide equitable and quality cancer care. At the moment, City Cancer Challenge, we are across 13 cities all over the world, And in Africa, we are in 3 cities so far, but we are releasing more call for applications and planning on engaging more cities. At the moment, we are in Kigali, Nairobi, just joined last year, and Kumasi. Kumasi is in Ghana. So our framework or our model is built on the principle that cities can be enablers of change that can be scaled across the country. And we build or bring together, we have a multi-stakeholder approach that brings all the important people from the city, but also nationwide at the table to discuss on what are the needs in cancer care, but also decide on what should be the solutions towards those needs. So that's briefly on our SECAN model. It has 3 stages. The first one is LEARN, we call it LEARN. This is where a city, once it has applied to be part of the challenge, to join the movement, we do a due diligence process to understand what is the situation in the city, what are the data that is available, where can we start, and then the next thing we do is to engage all the important stakeholders in the city, and that stage ends with a wide, comprehensive needs assessment that brings all the important stakeholders together to correct extensive information on the situation of cancer care in the city, to identify gaps and propose priorities for the city. For example, in Kigali, the needs assessment brought together around 32 institutions, health institutions in the country, 136 clinicians, healthcare providers, and around 80 patients. The next stage is Empower. This is where we support the city to develop solutions, to go into a process of solution planning, project development, bringing together our partners to support the city in developing those projects that they have prioritized based on the challenges that they've identified. And the last one is Grow, where we support the city, bringing together possible funders for implementation of those projects, but also thinking about the long-term implication for what we've started. I think next was a video, but for the sake of time, I will skip it. If anyone wants it, I can share that. For example, giving an example of one city, Kumasi in Ghana. So after a city has started the process and has been enrolled in part of the challenge, we form a city executive committee that is very diverse, that brings together all the important decision makers in the city. For example, in Kumasi, the mayor is the chair of that committee, but it also brings together people from the Ministry of Health, private sectors, and really all the important stakeholders in decision makers. And what we do in terms of solution planning, projects identification is to follow the WHO building blocks and to support them to see what is the needs and to develop projects around those building blocks, things including, for example, in service delivery, like quality assurance programs, guidelines and protocols for treatment. In terms of health workforce, we support cities we train, we provide capacity development, we provide opportunities for observership across other cities where we have the initiative or even where we don't have initiatives to share and learn from those cities and much more. Giving an example again of Kumasi, we have those ongoing projects. Some of them have been completed, but as you can see, they really go across the entire spectrum of cancer care. And in terms of partnership, really talking about PPP, is we really bring together that diverse array of partners to the table to support the city. In private sector, we have several people we work with, like Roche, Sanofi. We bring together international organizations, health institutions, academia, and they are there to support the city as they go through the process of developing those different projects we've talked about, like quality assurance programs, to make sure that, yes, they follow what are the needs in the city, but they also abide on international standards. Talking briefly about where we are in Nairobi. So, as I said, Nairobi applied, and as of last year, it was enrolled as a city. That was one of the meetings that we had last year. And those are some of the part of the city executive committee that we have in Nairobi. They're actually currently having a meeting right now. And as you can see, it's composed of all the main people in the cancer space, including like the Ministry of Health, the city county, and much more civil society, academia, and private hospitals, and international government hospitals. And in terms of timeline, so in February right now, what we are focusing on is that CEC MOU signature with the Ministry of Health, with the county, because we are city-based. And after that, we'll conduct a needs assessment to provide, to really understand what are the gaps in cancer care in Nairobi. And once that needs assessment is completed, we release a situation analysis of the city that is actually available to be shared to anyone who will need such information around the needs in the country. And after that, we develop a city roadmap, which is really what are the priorities, and all that is, of course, championed and led by, I'll continue, you can hear me, though you can't see me. But so it's led by the city executive committee entirely. So after the roadmap, we start the implementation, which is the solution planning and project development, which really involves mostly clinicians, health specialists who are doing the work, some patients who understand what is needed to make a change. Yes, I think in a nutshell, that is what we are doing. We are happy that Nairobi is part of the challenge and really look forward to what is going to be accomplished in Nairobi. Thank you.
Let's thank Ms. Mumukunde for her presentation on how cities are enablers of change. Very excited that Nairobi has joined the City Cancer Challenge. Exciting news, and I'm sure the panel will have a lot of questions on that. Now, our third speaker is a data scientist and a data evangelist. He's very passionate about working with data to generate insights that drive decision-making. He heads monitoring and evaluation unit at PATH. Today, he will give a presentation on NCD, Stakeholder Navigator System, the first of its kind locally managed NCD digital information system in Kenya. Ladies and gentlemen, we have Mr. Dominic Mutai to give his presentation. Welcome, Dominic.
Thank you so much, Agnes. Okay, as the slides comes up. Yeah, so as introduced, my name is Dominic Mutai. Yeah, so about PATH. PATH is a global NGO. We are in more than 70 countries. And we've been in Kenya for the last around 32 years doing work in HIV, TB, malaria, as well as advocacy, and also right now doing some work on NCDs, and cancer being one of the leading NCDs. Yeah, so from the presentations that we've seen from yesterday, yes, we've seen, it's been mentioned a lot on the growing burden of NCDs in the country, the triple burden of disease for African countries, and right now, actually the report that was tabled yesterday showing the burden of cancer. And this conversation about partnerships, it's always talked about that NCDs are actually a multi-stakeholder, needs multi-stakeholder response, because NCDs, when you talk about the other aspect, first of all, in terms of prevention and control, there's a lot that starts from lack of physical activity, the food that we consume, and when it comes to the patients actually living with NCDs and cancer, there is the issue of treatment, there is the issue of palliative care, availing NCD commodities and drugs to these patients. Yeah. So from this, we developed a tool that could bring together all these stakeholders in the NCD space, specifically so that we can work together in this journey and as we address NCDs in the country. Yeah, so we developed a tool called the NCD Navigator, which is a one-stop shop for as much information and stakeholders who are working on NCDs in the country. Yeah, so from the presentations that we've seen here, we are privy to the issue that, first of all, this country, as well as other African countries, have this lack of high-quality data for NCDs. There's also conversations that have gone around in terms of funding that's coming in for cancer, for other NCDs. We're not lucky to have the big muscles for financial resources in the NCD space. And there's also lack of visibility into what stakeholders are doing. We have seen patient organizations here, we have seen civil societies, private organizations are doing quite a lot. We've seen Roche, we've seen a number of organizations here present what they are doing. But there is no platform where all these activities can be showcased in terms of amplifying our voices. And for this, there is a need for actually bringing all stakeholders together into one common place where we can amplify our voices, and we can also avoid duplication of efforts and resources, because we have these limited resources, yes? We identify also places where the burden is quite high for specific, we'll go to cancer, against response to that specific cancer. So by having a platform where we can showcase these little activities that all of us are doing, addressing the burden of cancer in the country, we can be able to move together and move far. Yeah. So what we did is we developed a database. It's a live database that is showing it's exactly who is doing what NCDs, and for this we'll be talking about cancer, who is doing what cancer activities where, and who are they addressing. Yeah. So it's just a platform, as I said, to really showcase all the stakeholders who are addressing cancer control and cancer care in the country, and so that we can also have this collaboration. And how do we do this? We annually bring in stakeholders across the country, so all the 47 counties. We go to the civil societies, the patient organizations, and the national level stakeholders. We know NEMA has been mentioned here, KEMSA, all these, NTSA, all those other sagas that are also within the government that are addressing NCD response in this country. Even when you talk about counties, when you talk about physical planning, there is need for space, there is need for parks, even where people can do a physical activity, people can walk, so that they have this, we are able to control our NCDs. Yeah. So additionally also, because we recognize that NCDs and all these other cancers are different type of diseases. They don't have a uniform way of reporting. We mentioned that there is lack of data for NCDs, and it was shown here, the number of facilities that have the cancer registry who are reporting the cancer data. Even from the previous presentation that was done in the morning on technology and data and innovation for cancer response, we don't have this common reporting platform specific for cancers where we're able to get like aggregated data at the end of the month or at the end of the year, where we can say, these are the number of people who are living with a specific cancer across the whole country, And these are the number who have died, or these are who are achieving control and all that. So we created this tool such that you are able to also report your data through a custom indicator based on the work that you're doing. Our work cuts across. The work that patient organizations will be doing in raising awareness is different from the work that a cancer care center will be doing in terms of treating patients. So we give you a platform where you will be able to just create a custom indicator and amplify your voice on what you are achieving in terms of the cancer response. So this NCD Navigator tool is domiciled under a portal that we, together with the Department of NCDs at the Ministry of Health, developed together, as well as a number of stakeholders led by NCD Alliance and a network of cancer organizations, developed this tool and a dashboard where now you can visually see all the stakeholders involved in cancer work in the country. So at first, you look at the entire picture of NCDs, you look at, and then you drill down specifically to what NCD you want. So you can be able to drill down at, see who is doing cancer work that's addressing maybe children in a specific county. Yeah. So that dashboard is an interactive dashboard where you're able to drill down to specific NCD condition, specific geography, specific gender or age group, and as well as even the continuum of care that's addressing. And similarly, we also try as much as to see if we are also working together in terms of the pillars, the strategic pillars of our cancer strategic plan, how also organizations are speaking towards those 4 or 5 strategic pillars in terms of the little work that they're doing, which, from the counties as well as additional stakeholders from private, civil society, NGOs, foundations, and faith-based organizations. And we've been able to map 134 organizations who've been able to update annually their data to tell us what they're doing. And so that's the distribution. All the 47 counties are actually represented. And through this, every county right now has an office of an NCD coordinator who actually coordinates NCD work in the county. Some counties had, some counties did not have. Yeah. So we've had 39 NGOs reporting their data, 13 organizations who are patient organizations reporting their data, 10 civil society, and then you have 9 arms. These are different ministries or sagas that are under the government of Kenya, like KEMRI, you can say NEMA, NHIF, and the like. Private organizations also being represented. And then each and every other organization has to actually specify what NCD their response is addressing. And you can see that most of this, the work that's being done, the activities that they do, mostly is addressing diabetes and hypertension. And then there's this work that's done maybe at the national or the county level that cuts across all NCDs, and that was 15% of all activities that's been reported. But when it comes to the cancers, you can see that we see a lot of work representing cervical cancer, that's at 13%, followed by breast cancer at 10%. There's work being done on mental health at 8%. And then the rest of all those other cancers, prostate cancer, childhood cancers, colorectal cancers. And then we saw that from these presentations yesterday on esophageal cancer and being quite aggressive, but there's little work that's actually being done to address that. Yeah. Okay, and then where are these activities being done? Specifically, this is activities for cancer, for cutting across all the cancers. And again, this is where now the gaps needs to be bridged. We saw from that report 5 counties which represented around 55 to around 60% of the cancer cases in that report. But some of them are not coming on top from what the organizations have been able to say that they're doing some cancer work. You can see a number of activities in Nairobi County. Yes, Nairobi County is the leading, followed by Nyeri. But Machakos was one of the counties highlighted. Nakuru County was one of the other counties, as well as Kiambu counties. But they don't come on top there among the counties having a number activities related to these cancers. So that shows us where some of the gaps are and where we need to bridge the gaps in terms of the geography. And then we also ask organizations not to explicitly say who is funding them, but just to get an understanding of how cancer work is being supported in this country. And from when I started my presentation, I told you that NCDs have not had that traditional funding that we see malaria, HIV, and other TB programs having. And it was interesting to see how private sector is also coming in strongly as a source of funding for cancer response in this country, what's marked in red. Due to that, the data is skewed because I see a number of 47 counties really saying that most of their work, of course, is being funded through the government of Kenya. But you can see that private sector really coming in strongly, as well as NGOs supporting cancer work in the country. Yeah, and lastly, we also want to see, in terms of the continuum of care, where are these organizations playing? What, in terms of the response for cancer, much of the effort is being targeted towards what in terms of continuum of care, and where are the gaps? We can see that we talked about there is no data, and it actually showed that no one is doing M&D, data collection, and surveillance for data. That shows the gaps, as well as training and CMEs. But most of the work you can see is on health promotion or primary prevention, followed by screening, risk assessment, diagnosis. But I also want to highlight how palliative care and reintegration and rehabilitation is really also coming out strongly, as around 9% of the work being done by patient organizations, civil societies, as well as the people who reported the data, addressing that in terms of the continuum of care. And then lastly, we also mentioned that who are we addressing specifically when it comes to age, gender, as well as the population. So most of the work for cancer response was targeting the general population. That's at 34%. So we believe this should be awareness and all that screening, risk assessment, targeting the general population. But there's also work, 17%, targeting individuals diagnosed and living with cancer. So for this, specifically, all these results is on cancer. It's no longer on NCDs. 17% targeting people living with cancers. And then there is some element of work that's targeting facility-level healthcare providers. That's equipping them, training, and all that. And then 10% of that now targeting this other population that are not yet undiagnosed with cancers. But then you should be able to look at this other group, the target group that are not being targeted. That's patient associations, regulatory bodies. There is no work. Of course, really this school-going children, 1%, but all that awareness really also needs to start somewhere. You can see maybe something like employee or workplace wellness programs. There are no, it was only mentioned maybe 1% was targeting employees and wellness programs, as well as family members living with NCDs. So that support system also needs to be addressed. But then when it comes to gender, we can see that most of this work, that's 65% is targeting both male and female, with 35% targeting the female. So there is no activity that was actually explicitly mentioned to be targeting men. So I know prostate cancer now really needs to come out strongly. Yes, as I wind up, yes, I'm winding up. Thank you. Yes, so this tool, through this tool, we've been able to have a vehicle that has been used to amplify our voices, bring together stakeholders to form technical working groups that are addressing specific NCDs specific to now cancer. And then we are able to overlay burden of disease, like what we mentioned, Kiambu, Machakos, and Nakuru, not coming out strongly there, but the burden is high. So thank you so much.
Thank you so much, Dominic, for that interesting presentation on what PATH is doing to bring all stakeholders in the NCD space, in the NCD space in one portal for collaboration and partnership. Thank you so much. Let's give him a round of applause. Now, ladies and gentlemen, before we invite our next speaker, I want you to turn around and introduce yourself to the person sitting behind you for 5 seconds. Behind you, not next to you. Thank you. You have a presentation? I want them to prepare for the presentation before you come. Great, great, great. I'm sure we'll catch up after the session. So, ladies and gentlemen, our next speaker, our final speaker, is a medical doctor, is a medical director, African cluster at AstraZeneca. She has a very exciting presentation on accelerating change together for Cancer Care Africa. Let us welcome Dr. Komotso Mashilale to give a presentation. Welcome, Dr. Komotso.
Good morning, everyone. Habari wenu. Did I get it right? Oh, I'm hailing all the way from Johannesburg because this is a very important discussion that we're having. It is my privilege and my honor to be with you because we have to really make sure that this discussion that we're having about cancer care, it never dies down. Without going into the statistics again, we well know in terms of what is happening with the statistics related to cancer care in Africa. Over 70% of cases of cancer are diagnosed late. It's still a major, major burden in terms of non-communicable diseases in Africa. And we're looking at 2.1 million new cases and 1.4 million deaths are expected annually by 2040. And this is related to all the barriers that we all know. We've been talking about this yesterday. We've been talking about, my esteemed colleagues have been also referring to them, that there's lack of disease awareness, our patient empowerment, there's limited diagnostic capabilities, and that's why all our cancers are diagnosed late, because patients come late, and also in terms of us having the infrastructure to be able to diagnose these cancers. And then there's also an absence of structured screening programs, and of course, access to treatment. And very important when we talk about access to treatment, it's not just treatment in terms of medication. We need to ensure the availability of the medication, the accessibility of the medication, the acceptability of the medication, and also in terms of the, how patients access this medication. So there has never been a more important time for us to work together in terms of a joint action towards transforming patient outcomes. So in AstraZeneca, we continue being committed in terms of accelerating change to cancer together in Africa. Our Accelerating Change Together program in Cancer Care for Africa is a global network bringing together cancer communities, governments, patient advocates, and healthcare experts with the goal for us to advance equitable improvements in cancer outcomes for all. It is important for us to achieve this goal. We need to work together with our experts and also our local community. And we will do this by listening to our local oncology community. There's no need, it's like, it won't make sense if at all we just come up with solutions. We really need to co-create all these solutions that we need in terms of how are we going to drive the local needs. We need to build a network for change, and we need to implement cancer care that is driven by local needs so that what we create strengthens the local health system, strengthens the partnerships that we have so that we have an end-to-end solutions in terms of how we are managing cancer care in Africa. So to address this, we're working on 3 pillars. And as we know, these are the 3 main pillars that we've all been talking about: capacity and capability build, diagnostic infrastructure. How are we screening? How are we building all the diagnostics that we have? And very important, not forgetting our patient. It's important for us to always focus on patient empowerment. When we look at building capabilities, we have committed to improve the quality of care provided to patients across the region, supporting more than 100 oncology centers and providing training for more than 10,000 healthcare professionals. So when we talk about capacity, we also must look at capabilities. Do we have the capabilities to be able to manage cancer? Do we have the capabilities in terms of our healthcare professionals, in terms of the diagnostic infrastructure that we need? Secondly, enhancing screening and diagnostics, aiming to cover over 1 million patients across 3 major cancer types: breast cancer, lung cancer, and prostate cancer. And of course, without mentioning again, patient empowerment. This is a very critical pillar for us to really mobilize our patients, for them to understand cancer and seek treatment early. Together, we will realize this ambition through creating programs with our local partners. This aspect of network is very crucial for looking at the real gaps that we have in Africa, and together we can ensure care for our patients in Africa with Africa. I referred to the network that we need to bring. That part of our ambition is to provide a platform for partners to build sustainable projects which are capable in terms of driving change in cancer patient outcomes. So it's no use coming alone. We have, my colleague has also talked about private-public partnerships. We have to build those partnerships that we have with government, because it's important in terms of that co-creation of how are we going to be strengthening our cancer care access in Africa. Important in terms of network for sharing expertise. It's important in terms of now how much are we investing in those local screening programs and facilitation of capability building programs. Our partners, wide range. So as we say, we have started off in Kenya. These are some of the partners that we have. We also have partners across the whole of North Africa. We're building even more partners as we start now in Kenya, moving to the other countries, Ghana, Nigeria, even French-speaking Africa in terms of Ivory Coast, and also looking at the South in terms of Southern Africa. Very critical that the solutions that we create them ourselves in terms of now understanding the burden, understanding those needs that we need to be working on. So, our Cancer Care Africa, we launched last year in Egypt at COP27. It was very critical that we launch it at COP27 because we are looking at how now do we partner with government, how do we partner with associations for sustainable healthcare. And this is just one of the many pictures that we had taken, also the media coverage that we had at that point. In Kenya, we are looking at launching in Q1 this year. And this, we are committed to build capacity building programs, diagnostic infrastructure, and patient education initiatives, as I indicated. We're missing one slide. I think there's 2 slides that are very important that are missing. Let me just go back to the one. So now, in Kenya, we are starting with working with the NCCP. We are working with government, and we have several initiatives that we have put down. So firstly, in terms of now, we are strengthening our centers of excellence because it's important to have an A to Z solution in terms of what we're doing. So we're looking at in terms of donating ultrasound-guided biopsy machines, PCA screening tests. We are also looking at uplifting diagnostic capabilities when it comes to lung cancer in terms of having an EGFR testing capabilities within Kenya. We know most of our specimens, we send them out to the right, whether it's in Egypt, whether it's South Africa or India, it's important for us to have those capabilities within country. Patient education initiatives that we've spoken about, even the preceptorship programs that I referred to, we have already started that program in terms of liaising with the University of Cairo in Cairo and also in South Africa in terms of now, how do we share expertise? How do we build those preceptorship? How do we build master classes so that we can really build the capacity and capability that we need for our HCPs? So very important, the last slide I had to show that we already have started implementing. So very important for us is to make sure that whatever we do is sustainable. So we already had partnership with the MOH in terms of the virtual academy with HealthStrat, where we are really uplifting, upgrading the e-platform that they have in terms of the HCP capabilities that we're looking at. So really for us, it's very critical for us to co-create all these initiatives that we're having to really strengthening the ecosystem when it comes to cancer care. Thank you very much.
Let's give Dr. Komotso a round of applause for her very exciting presentation. Thank you. And now, at this point, I want to open the floor for question. As you ask your question, state your name, where you're from, or which organization you represent. Also, direct the question to the specific speaker. I think we have time for around 5 questions. 5? 5. Let's start with the lady. Can you get somebody with a mic to go around? Thank you. Thank you, sir.
All right, thank you to all the panelists. The session was very interesting. So my name is Christine Guria. I'm a professor of emergency medicine at the Yale School of Medicine in the US, but I am Kenyan. So I've been doing NCD research for the past 10 years. My question is actually for the gentleman from PATH. I think that the tool, as a researcher and someone who's obviously interested in data like you are, I found it extremely interesting, and I think it's a very, very powerful tool to hopefully avoid duplication of resources. My question is, obviously as a data person, how you're sourcing some of your, I have a couple questions, but the first one's how you're sourcing input. I noticed you only have one academic project, and I know that's 100% inaccurate, right? And I see you're smiling. So how are you sourcing this, and how can you encourage more accurate information? The second question is, what next, right? So you have this fantastic tool that shows where the gaps are. Is NRF responding to this in terms of developing calls for research grants? And how are you using this output? And then the last question I have is on QI, like quality. How are you ensuring that it's kept up to date so we know a project that's listed there is not defunct or out of date? So, and I'd love to talk with you more afterwards, but those are my big questions for the group.
Thank you. Let's have the next question. Let's come to this direction. Thank you.
Good afternoon. My name is Brenda Chipapa. I'm a health advocate in Nairobi. So my question goes to Director Aga, the Vision 2030 Delivery Secretariat. We know that the future depends on what we do today. And sadly, we have, rightfully so, we have one cancer that the WHO has earmarked as preventable, 100%. If the mic is not working, is it working now? Yes, thank you. So we have one cancer that we can eliminate from the face of the earth, and that's in 100 years.
regrettably, we won't all be here 100 years from now to be able to see that happen. But we've been told by data that the cervical cancer, if we don't act today, will double by the year 2040. Meaning we will be here to be held accountable after this conference if we do not act today. Director Ada, recognizing that we've just finished the National Cervical Cancer Awareness Month last month, and recognizing that we have to maintain momentum from now through to December before we get to the next National Awareness Month, how can we harness the power of youth within the Vision 2030 Directorate to be able to help them understand the need for them to prevent now for the future, so that we're not waiting for 2030, 2040 for the numbers to double, and maybe in 100 years' time to have our women folk suffer a cancer that should have been eliminated. Thank you.
Thank you, Bernadette. Let's have 2 more questions. We're running out of time. So where do we start? Thank you.
Right. Good afternoon. My name is Kinyenjui, and I'm a esophageal cancer survivor, and with a recurrence and still on treatment. Now, unfortunately, cancer is a full-time job that nobody likes. But as we come to the close of this summit, as a person, I want to sum it up and go up the mountain, or the summit of the mountain, and tell people that they don't have to die from cancer. It is treatable when detected early. The other thing that I want to say is that I don't know whether it will come up as a question or as a comment, but then I want to be empowered so that when I go to sell hope to the people where I was born and brought up in Madare, when I sell them hope, I don't want to sell them empty hope. I want to sell them hope with substance. Substance with information. Information in regards to the HPV vaccine. Because as at now, I am skeptical of the HPV vaccine. And you would understand that as a cancer patient, I would be the best person, or I would be the best suited advocate for the HPV or whatever vaccine that is there, because people would believe me more, because I am not in business, right? So I want to know, because as at now, my 12-year-old daughter, I said no, she's not going to have it. I actually texted Mwalimu like 3 times and called her. And because as at now, I am prepared to answer the question, Dad, that's 15 years from today, when she'll be a mother. Yes, I'm prepared to answer the question, Dad, why didn't you take me, or why didn't you have me vaccinated, and why didn't you have me vaccinated, as opposed to why did you have me vaccinated? So I want to be armed with enough information so that when I go to sell hope, when I go to tell people, I can give correct information. And then the other thing is that,
let's keep it brief, please, because of time. Right. We have other people wanting to ask questions, kindly. Let's have the final question.
Okay, thank you so much. My name is Bile Kemara. I'm a cancer survivor, and I would like to formalize what Kinyenjui just mentioned over here. And my question is also to Director Ada. Kindly expound on the engagement approach to Vision 2030 that helps inform PPI health interventions, as we saw up there. The PPI needs assessment informed by the divergent views of affected communities. Thank you.
Thank you. Do we have time for one more question? Are we done? Okay.
Good afternoon. My name is Derek Bundi. I'm a student pharmacist at Kabarak University. My question is to Director Ada. So when you're talking about Vision 2030, you've highlighted that there are 4 pillars that you're focusing when it comes to cancer prevention. Now, as someone who's joining the health workforce and noting that we have not yet achieved the ratios that are set by WHO in terms of human resource, how do you incorporate that in the county integrated development plans to ensure that more health workers are recruited into the health workforce in order to ensure that we have equitable, affordable, and quality healthcare? Thank you.
Okay. Yeah. Please go ahead. My apologies. Go ahead. Final question. Final question.
Okay, my name is Dr. Jane from the State Department of Livestock. And my issue is the eradication of some of these cancers that can be eradicated. The medics, they know the process of eradicating diseases. And they know the steps that are and the procedures that are supposed to be followed. We have our partners here for the financing aspect. What is, now this is to the director from Vision 2030. What is making us not start the process of eradicating these cancers that are eradicatable from the face of the earth? We have smallpox, it was eradicated. In our field, we had eradicated rinderpest, and it only requires concerted efforts from all the partners and the private sector to eradicate this disease, so that we do not say it is eradicatable, it is eradicatable, and we are not taking steps to eradicate this disease, so that next time our children will not question us, what did we do? Thank you.
Thank you, Dr. Jane. I think we'll let our presenters answer some of your questions, and then, because we're running out of time, we'll give them 1 minute after to just give their closing remarks. And for further questions, you can ask them outside the presentation because you're just running out of time. My apologies. So we'll start with the gentleman from Perth, Mr. Dominic.
Okay, thank you. So my answers is to, okay, I didn't get your name clearly. Yes, but for the 3 questions, first, on how we are sourcing input, getting information from the stakeholders is so this is an annual activity. It's done towards the end of the year, where we've borrowed heavily from, if you know, it's called the WHO Digital Health Atlas, where they also source input similar to the Navigator. So we send an email to all existing stakeholders in the tool that it's that time to update your information in the NCD Navigator. And then we got the extra step of now bringing in those stakeholders who are already there. So we start with the counties. We bring in all the NCD coordinators from the 47 counties to also, in a physical or virtual meeting, to be able to update that information and also identify new partners that they worked with in that year. And then we do a final, we also have these umbrella bodies like NCD Alliance, which has a number of patient organizations. So we have a physical meeting for them, as well as also Kenya Network of Cancer Organizations. And then we do what is called snowballing. Lastly, because you tell me what work you're doing and who you're working with, the partners, you identify the partners. So we ask you, from the partners you have identified, we also reach out to them now so that we snowball. You identify one partner, we get that partner, and then that partner also identifies more partners, then we ask them to fill the tool. Yeah. So in terms of QI and making sure the data is accurate and up to date, okay, this is two-factor authentication, where you ask somebody to actually, first of all, be the person and associated with an organization, such that the data that you're supplying belongs to that organization. Yeah, and there's the human aspect of going through and seeing if actually what you have talked about is true. And then data use in terms of actually the why and the end. Yeah, so there is first, so we've brought in all this information, so what? So we overlay data from the Kenya Health Information System, and we see those gaps that against the burden of disease. We have this number of technical working groups, which are specific to a number of NCDs and cancers, which are formed using actually bringing in the stakeholders from that tool. We also urge people to actually just tell their success stories, their stories by posting their data, what they have been able to achieve there. And then we've seen even actually the ministry use it in terms of targeting new grants or new projects that are coming in. You have this small grant specific to childhood cancers. So we'll be able to go to the tool and identify the high burden region where with a specific what you're trying to address, such that you are able to direct you directly to where the gaps are. So those are some of the ways we are trying to ensure that at least the data is used and we are coordinating and directing to the gaps. Thank you.
Thank you, Dominic. Ms. Ada.
Can you hear me? Yeah. Thank you for the many questions. I'm surprised. But let me attempt to answer them, but please feel free to engage with us. There's, I think, 3 of us in the room, and we are happy to engage further. So let me start with Benda's question about how do we harness the power of youth to prevent a bad situation in the future. Yes, Vision 2030 is very futuristic. And what we can do within our mandate and engagement with you as non-state actors or other actors within government is to partner and create this awareness and work out a form of engagement with the youth. We have tried this more broadly around programs that are targeted at youth, youth empowerment. But I think very rightly so, this is a huge interest, the space of health and cancer specifically because of this forum. I think it's a high time that we work out an engagement framework. Let's say it's very much within the government policies that we can work this out. But of course, not to delabor or undermine the fact that resources are required. So we may hold forums, we may set up these engagements, but to sustain them, we need your partnership. We need a concrete process that is anchored under policy to sustain that engagement and bring it to fruitful. So again, yes, it's an open space, and we are very, very, very open to ideas. And I think that links to Peter's question around how do we expound on the engagement approach to inform projects. Again, that is said, I mean, the projects are identified as a sector. You need to engage with these processes that come up with the flagship projects under the MTPs, with the medium-term planning processes. And these are open forums with public participation. So this is what informs the projects that go into the framework. And we can again discuss more about how you engage in those processes, because they're usually advertised and you're called to public forums. Let me keep Derek's question last, because the aspect of engagement is also linked to the question that Jane asked from Livestock Department. What is not making us start the process of eradication? Again, that is a process. We need to declare it. How did other processes start? For example, polio eradication, and it all went off. It was not government alone. It was through partnerships with civil society, with private sector coming on board, and running a campaign that we have to eradicate this. And I totally agree. After this forum, it is ripe that we run an eradication, say, kick cancer out. And it is possible, because that is very much aligned to the aspirations of our vision. Again, I link that process with the preparation of the medium-term plans. Please engage in that process that we are coming to the final phase of finalizing the fourth medium-term plan. Let us have eradication of cancer as one of the flagship programs in the MTP4. I think we need to gather around such a project and get it off and going. Lastly, Derek, HR needs, human resource, how to ensure more health workers are recruited in the health force. The ratio is not achieved, and it's far from being achieved, Derek. I think this is a very rich space at the moment because we hear of strikes, the KPMDU calling for strikes now and then. The counties are implementing their human resource differently. No county is alike to the other. And if I recall, during the framing of the Constitution, there was meant to be a Health Service Commission, which never came to be. But I can see that there will be such a discussion again happening very soon, because we need the human resource aspect of health centralized. It's not that we don't know what we want. We know what we want, but the health workers are basically demoralized, most of them. Some counties are really bad, some counties are really good. And, it is, so they are losing a lot of people. We hear health workers going to other countries to work, even after being trained locally with Kenyan resources. So it is time to, synchronize this and have that discussion at the national level. And I'm sure that discussion will bear some fruit. So let's be hopeful. And we are happy to engage after this. I'm with my colleague Julia. Julia, just stand up so that people can see you and you can engage with her as well in further engagements with the Secretariat. Thank you.
Thank you, Ada. Our speakers are still here. Please feel free to engage them after the sessions. Now, at this point, I want to give our presenters 1 minute closing remark as we come to the end of the session, starting with Ms. Mamukunde. My apologies for that.
Can you hear me? Can you hear me? Thank you. So in closing, first, in 1 minute, on an individual level, I think my takeaway is each one of us to ask ourselves, what is one thing we're going to do after this great summit? Did we get screened? Have our daughters are vaccinated? What can we do where we are with our families, with our relatives, to eradicate what can be eradicated and teach more people about how to fight united this cancer? And second, from City Cancer Challenge, ours is to support cities. We are here, we are ready to support the city of Nairobi, and coming up is going to be a wide needs assessment, as I explained. I believe most people here are doctors, involved in cancer care, directors of hospitals. So we'll be reaching out to some of you. How ready are you going to be available to work together and to really understand what are the gaps and work together towards the solutions that are needed. Thank you.
Mine is very simple. I think after this forum, we have learned that we are all affected by cancer. I have a personal experience, my mother, my father. We still are seeing them within the community. What are we going to do after so much information that has been disseminated to us through this forum? And let's make it actionable. Let us engage. Let us make our national vision real, that we achieve a healthy society in a very secure environment. Let us look at it all round and not just from the health perspective. Thank you.
My message is we're not longer acting now. We need to accelerate that change. We need to accelerate that change. And more importantly, how are we holding each other accountable? So in terms of now holding us accountable, the partners that come through, holding government, civil associations, we need to speak to each other because we have to accelerate the change and we have to accelerate it now.
Thank you. Yeah. My message is, yes, the train has left the bus, so let's all get into the train. Let's build partnerships and synergize. My message is also to the survivors and to the patient organizations. Tell your story. Your story can change somebody's life. Let's tell those stories. Let's tell those personal stories. And let's amplify our voices. Thank you.
Thank you. Thank you so much, our speakers. On behalf of NCIK Kenya, I want to thank you for your outstanding presentation. Let's all give them a big round of applause. The panel will take a group photo after this, but that's with the speakers. Until next time, back to the hosts. I think we've come to the end of our presentation. Wageni? Okay. So I hope to see you at the next sponsors presentation. Thank you.
Media team, are we ready with Dr. Andres' video from WHO? Please play it. Delegates, yesterday we had promised that we're going to play you Dr. Andres' video, so we're going to play the video and then we get to the closing ceremony.
Important occasion to celebrate the life and the legacy of everyone who's been affected. Excellencies, colleagues, and friends, thank you for inviting me to join you on this important occasion to celebrate the life and the legacy of everyone who's been affected by cancer. Please accept my sincere apologies for not being able to join you in person and also for the technical difficulties that we have encountered. This week marks the Executive Board where governments from around the world are meeting in Geneva to discuss health and political priorities, and cancer is featuring quite prominently. In the next minutes, I will share with you perspectives on the evolving landscape of cancer control globally. As we already know, cancer is an emerging public health concern. we can anticipate the burden that it will exert in the upcoming decades ahead. If, for example, we compare South Korea and Kenya, two countries with a similar population, we can see that the disease burden in South Korea will be stable over the next 2 decades. Conversely, Kenya will see a significant and rapid escalation, placing immense strain on health systems and its economy. And this will be complicated by an epidemiological transition away from cancers associated with infections and towards cancers associated with physical inactivity, obesity, and dietary choices. So we must intensify our attention on these relevant risk factors in Kenya, recognizing the growth of these risk factors in the country and in other low and middle income countries, while maintaining a focus on commitments like the elimination of cervical cancer, a global ambition, and in fact, a global call to action to protect a generation of women and girls. But even in the best of circumstances, Kenya and other low and middle income countries must prepare for a doubling of the cancer burden. This increasing cancer burden and existing weak health systems and cancer control are threatening the ability of all governments to reach SDG Target 3.4 to reduce premature mortality from all non-communicable diseases. In fact, only 14 countries are currently on track. The status quo is simply not working, and that is particularly true in low and middle income countries. So at WHO, we took a step back to better understand how have some governments been able to achieve progress to bend the curve from cancer deaths. We looked at different types of policies, activities, and investments. What we found is this: the most strategic investments were those focused on universal health coverage and strengthening the availability and capacities of public cancer centers. Here are 2 other important findings. First, as you can see here, many countries were able to reduce breast cancer deaths in the 1980s and the 1990s. This is important. It's important to remember that the basics work. While we need to talk about the horizon, evolving landscapes, let us remember what has worked in the past and let us stay true to those examples of success. Second, investments must go to scale. The activities that you see listed here are beyond small ad hoc investments in activities or equipment. It is simply not enough. So if we look at this log frame, we can better understand why purchasing a mammogram in the absence of a broader policy environment will not, in fact, achieve its intended output. Yet, unfortunately, we see exactly that. Many governments that are investing in equipment or medicines without taking a broader look at the value chain. And without doing that, we will not achieve the progress in these specific activities and see the value of the investments reach their intended scale. This is the same for access to medicines and early detection programs. If we don't wisely, the medicines will not be available, the machines will not be used, and best practices will not be implemented. To succeed, fundamentally, we must focus on comprehensive plans founded on value for money, and critically, we must invest in people, in health professionals, in community health workers, in ministries of health, and critically, in our communities. But we know it is possible. If we invest $3 to $5 per capita, we can save more than 7 million lives by 2030, with a return on that investment of over 7. It's important to understand the starting point. Fundamentally, we must invest in the workforce, and that investment must start now. For high-income countries, in order to maintain access to care, the workforce growth rate needs to be at about 2%, and this has been matched by historic norms. In lower middle-income countries, unfortunately, the story is different. The growth rate needs to be 7%. The current growth rate is 1%. These statistics are unavoidable, and the reality is stark. But this is the horizon. What types of innovations can we introduce that will strengthen training, moving beyond the traditional ad hoc approach of postgraduate training courses? How do we embed innovation, new technologies, and new training programs into all skills and all opportunities across the education and the postgraduate service of our health professionals? Rapid innovation in cancer, and that innovation has been critical to achieve progress. But all products have not been of equal value. Some have been transformative, others are not. Critically, Rather than rely only on research from high-income countries, governments must build research capacities and data systems that are fit for purpose. We've heard that many times already in this meeting. This includes building clinical trial capacities and, most importantly, ensuring that innovation must be participatory, that communities are feeding into the needs and the outputs of research. Because if we ignore the needs of communities, then ultimately we won't address the underlying harm that cancer has, and it is indeed a generational harm. For too long, we've avoided or ignored and not placed at the center of our work the patient voice. We know that 60% or more that are diagnosed with cancer will experience anxiety or depression. We know that they will often suffer financial distress, more than 70%. And with those being diagnosed with cancer, dying at 2/3 the rate, as we heard from Dr. Karagu, this leaves families in poverty. In Kenya, where 50% or more of women diagnosed with cancer are 50 years or younger, this leads to children who are left without their mothers, 2.1 maternal orphans per woman who dies from cancer. They're subjected to lower employment, higher school dropouts, and this harm continues on communities and economies with major GDP losses on the order of 1%. We can and we must act now. We must break this cycle of generational impoverishment. Cancer control simply saves lives, it saves money, and it gives communities hope. So in closing, let us pause and congratulate what you've been able to achieve, the Kenyan people and the Kenyan government. You are responding to the growing cancer burden and adopting these threats and opportunities ahead and responding to them in the most inspiring and encouraging way. By launching your strategy, you've introduced a value-based framework founded on universal healthcare and health as a human right. By investing in cancer centers and decentralizing services, you're making access possible for the most vulnerable populations outside of major cities. By building research capacity, you have brought the government, the private sector together in a meaningful way to set standards for innovation. And finally, across the board, you've invited key stakeholders to be part of the dialogue: governments, civil society, the private sector, and focus that on the voice of the survivor. Together, we can in fact change health priorities. There are challenges ahead for all countries. The road is not easy, but together we are beginning to break the generational harm that is linked between cancer and poverty. We at WHO, we, the international community, celebrate you. We stand ready to work with you and to support you, to achieve the ambition, and to open a new chapter.
Maybe we can clap for Dr. Andre, even though he's not here with us, and I'm not sure he's joining us today. He was, I think you remember yesterday we were trying to get a feed, but we had a bit of a challenge, and Dr. Andre comes to us from WHO in Geneva and giving us the future of cancer. Ladies and gentlemen, esteemed delegates, we're now ready for our closing ceremony. Apologies for the little time glitch there, but this will not take long. And I will now welcome our session chair, director at NCI Kenya, Mildred Mugambi, to lead us through this session of the closing ceremony. Mildred?
Good afternoon, ladies and gentlemen. Good afternoon, ladies and gentlemen. Please turn to your neighbor and tell them we did it. We did it. This was uniting our voices and taking action. My name is Mildred Mugambi. I serve on the NCI Kenya board, and I'm glad to see all of you. It's been Gitai Givenji, our chair. Please come on stage. Please give him a round of applause. I'll also call on stage the chair of KENCO, Dr. Elo Mapelo. Kindly come on stage. Please give him a round of applause. And also, our other key partner is county governments. And we will have that representation by Dr. Ganda on behalf of COG. Dr. Ganda. Is he in the room? Okay. Dr. Ganda? Right. Okay, fine. We will. He's outside. Okay. Perhaps someone can allow him to come in. In the meantime, we are all going to participate in this activity. So the communique that we are about to read is just a commitment of what we have all engaged in here for the last 1.5 days. And therefore, we are all involved. So if the IT team could project the link, kindly project the link. Right, media team? Okay. So get ready with your phone, go to your browser page, whichever platform you use to browse, Google, Chrome, Opera. Get ready to key in the link. Right, so we're using the link you can see there. We'll give you a few minutes. So if you get it, give me a thumbs up. Thumbs up. I'm looking for thumbs up. If you're stranded, do like this. Thumbs down. Thumbs up for good, thumbs down for I'm stuck. As we wait for Dr. Ganda. Okay, fine. Thank you. How are we doing with the link, with the code? Are we managing? Thumbs up? Great. We have the A students somewhere. I see more. Okay. All right. Great. So you're all able to see what I'll be reading, right? Great. So we'll give a few minutes, just 1 minute for everyone to be on board. Have you managed? Has it told you yes or no? Yeah. So you could either abstain or you say yes. But I believe because you're still here, you agree to that which you've been discussing. Great. Fantastic. So without further ado, allow me to go through the communique as it reads. Communique issued at the end of the National Cancer Summit 2023, organized by the National Cancer Institute of Kenya, NCIK, in collaboration with partners, held at the Safari Park Hotel, 2nd to 3rd February 2023, under the theme, Uniting Our Voices and Taking Action. Preamble. We delegates, including the National Cancer Institute of Kenya, NCI Kenya, national and county government representatives, religious leaders, community leaders, medical practitioners and healthcare workers, development partners, civil society organizations, private sector partners, cancer survivors and individuals, having convened at the inaugural National Cancer Summit from 2nd to 3rd of February 2023 at Safari Park Hotel, Nairobi, Kenya. We note with great concern that the cancer burden in Kenya is rising, and further, that cancer is the third leading cause of death in Kenya, with an estimated 42,000 new cases of cancer annually and mortality of 27,000. We further note that the 5 most common types of cancer in Kenya are those of the breast, cervix, esophagus, prostate, and colon rectum. Sadly, 70 to 80% of cancer patients in Kenya are diagnosed with advanced disease, which is not amenable to cure. Having considered and discussed crucial issues regarding cancer in Kenya, as espoused in the National Cancer Task Force report, and the proceedings in this summit regarding the status of the burden, financing, young people's perception, and risk factors, technology and innovation solutions for cancer, research, community-focused best practices and partnerships, opportunities and prospects. We recognize the missed opportunities for early detection and therefore timely treatment of cancer due to health system and individual perceptive factors. We appreciate the existing opportunity to eliminate the highly preventable and treatable cervical cancer. We acknowledge the fundamental role played by healthcare workers of all cadres in cancer prevention and management, and the need to strengthen their capacities to prevent, detect, manage, treat, and provide care. We recognize the crucial role that is played by the cancer survivors in creating awareness at the community level and the need for a holistic package of care that includes mental wellness for all. We appreciate the potential of community and religious leaders in supporting the cancer response in Kenya, lending their voices to the multi-sectoral initiatives against cancer. We underscore the importance of data in making informed decisions, that we can utilize data from the health surveillance system to inform, model, and direct interventions against the different types of cancer. We reaffirm the need to stop the acceleration of cancer in the country and to focus on improving quality of service and equity in access to health benefits among all Kenyans, and more so, the most vulnerable in our communities. We appreciate that we can achieve this through collaboration, partnership among national and county governments, development partners, private sector, CSOs, and communities. Therefore, endorsement. Together we endorse the unity of voice and action to 1. Strengthen multi-sectoral action in the policies, strategies, and action plans on cancer prevention at county and national level. 2, maintain the convening of all cancer stakeholders in the periodic National Cancer Summit. 3rd, build the capacity of healthcare workers, especially at primary healthcare facilities, to strengthen early detection of cancer, and community health workers on how to package messages for the community members about cancer risk factors and disease prevention. 4, strengthen, expand, and sustain cancer screening programs to reduce missed opportunities for early detection. 5, promote policies that prioritize disease prevention to support wider dissemination of appropriate information on cancer involving all organizations aligned to the Kenya Health Policy of 2014 to 2030. 6, establish cancer-related advisory services at national and county levels to enable effective navigation of communities, including patients in the care continuum. 7, enhance research on cancer across the country to inform the design of targeted solutions. Lastly, number 8, remodel health financing in Kenya to make it sustainable and equitable, and support the commitment made by the national government on the planned restructuring of the National Health Insurance Fund, NHIF, to a National Social Health Insurance Fund, NSHIF, as expressed by the Cabinet Secretary for Health, Ms. Susan Nakumincha, yesterday. And therefore, ladies and gentlemen, that is the end of the communique. I will call on stage our chair of the National Cancer Institute of Kenya Board, Dr. Githinji Gitai, to come on stage and officially close this gathering. But before then, we will allow a week of comments and feedback on this communique. It will be uploaded on the webpage where you are all able to register, which is the National Cancer Summit webpage. If you go to the main National Cancer Institute of Kenya website, you find a link that directs you to the summit webpage, and within the summit webpage, we will have a place where you can find it, go through it. If you have a concern, within a week, we'll be able to capture that concern and get back to us. Thank you very much. Chair, please. A round of applause for our chair as he takes the floor. Thank you, Chair.
Wow, good afternoon, everybody. Good afternoon. Please give yourselves a big clap for a fantastic, fantastic 2 days. And I'm so glad to see all of you here after a grueling 2 days. And we still have an almost full hall. Before I say anything, because this whole summit and the existence of the National Cancer Institute is about people. It's not about policies, strategies. All those are enablers of quality of life for people, which is why we were very categorical that the people needed to be represented at this summit and to be at the forefront of this summit. So I would like to invite my friend, my brother, Elo Mapelu, who is the chair of KENCO, to come and speak on behalf of civil society so that we can record that contribution and make sure that first and foremost is about people. Mapelu, thank you and welcome.
Thank you very much, Dr. First of all, congratulations. This, you'll all agree with me, was a very well organized and very well done summit. It's hard to believe it's the first one, but it is. If you are to mark it, you'll give it 99%. I can't wait to see the next one. Actually, when we were having tea out there, people were asking if this could have been done in 3 days, as opposed to 1.5 days, so that we can have more time to interact, network, and to get to know each other. Because this is the only opportunity we have to bring everybody in the cancer space, playing different roles in the cancer space together. And it has been a resounding success. Congratulations again to you and to your team. You did a very good thing. And the theme, uniting our voices and taking action, is indeed very apt for this first meeting that we come together to bring our minds together and to draw a work plan that is going to take us to achieving our various objectives, which culminate to winning this battle against cancer. And as I mentioned yesterday, this country is endowed with a lot of resources. We have a lot of literature in cancer, what we need to do, what other people have done, and what are the areas that you can pick up. We even have centers of excellence that we've borrowed a lot from. Probably the missing link is to actually put all this together and to have a winning formula. And Mr. Chairman, you have started us on this path to designing that winning formula. And I'm sure coming together like we've done today, and in the last, today and yesterday, is just the first steps towards arriving at that. And I'm sure going forward, and as you read that communique, make your comments and have a document that you can work with for the next 1 year until the next such forum, we'll be able to come together and make some very strong and resounding wins in this war on cancer. So thank you so much. And also to everyone who came, congratulations for making time and having the energy to hold on until today and making this forum a very successful one. So thank you very much, Mr. Chairman.
Thank you. Mapelo, we truly appreciate the role that KENCO has played in getting this planned, including participation of civil society. I would like to also say that we have a member of KENCO in the Board of Trustees of the National Cancer Institute, who is Catherine, who is here. Please stand up, Catherine, representing civil society. And I would like to do a very quick history, and then I will introduce the management team and the board to all of you as we come to an end of this. As you heard yesterday with the Cabinet Secretary and myself, the Cancer Control and Prevention Act of 2012 is what did what Mapelo was saying, that cancer is not a technical issue. It has social dimensions, has political dimensions, and therefore involves everybody. It's actually a whole of society issue. We know that on the prevention side, we're talking about the food we eat. We're talking about how cities are planned. We're talking about lifestyle. We're talking about urbanization and what urbanization does to the risk factors of cancer. We are talking about the national environmental management. We are talking about climate change. We are talking about pollution. We are talking about all these things. And therefore, we cannot assume that it is a Ministry of Health issue on its own. It's a whole of society issue. And because of that, we cannot assume that the Ministry of Health, represented here by the Ministry of Health, but more specifically by the National Cancer Institute, can resolve the issues of prevention, care, management, and quality of life in the area of cancer. So in its wisdom, the government established the National Cancer Institute, first and foremost, to be the advisory body for the Cabinet Secretary of Health on matters cancer, not on oncology, which they are better advisors for that, not on palliation, they are better advisors for that, not on medical products and science and technology, because they are better advisors for that, but to be a convener of these voices. That's the purpose of the National Cancer Institute. So the National Cancer Institute does not replicate the National Cancer and Control Program in the Ministry of Health. The National Cancer Institute does not replace the National Cancer and Control Program at the Ministry of Health. The National Cancer Institute brings together all stakeholders so that we can actually advise the Cabinet Secretary, which then advises the National Cancer and Control Program and the counties and all of us in terms of how we move forward. Last year, we had a new board that was appointed to lead the National Cancer Institute. I would like to ask the board to stand. They're here. As you have seen, the board has been very, very involved in this. Please, I'll ask the board members to stand up. Please face the audience so that we may introduce you. The board members, Mildred was here before. She represents NACOSTI, which is the research arm of the government. We have Agnes representing the media. So she sits in the Media Owners Association. We have Dr. Mildred standing next. She represents the Ministry of Health. So she's the representative of the PS of Health in the board, Mildred Nyakundi. Angela Nyakundi, sorry. Mildred were already introduced. We have Catherine, who represents Kenko, civil society. We have Samuel, who represents research, so he sits at KEMRI. We have a few other members. We have Kendrick, who represents Treasury in the board, who is not here with us. We have Francisca, who represents academia from KUTTRH. Have I forgotten anyone? Kendrick, yeah, from Treasury, I've mentioned. Yes, we have Marianne Musangi, who was chairing a session in the morning, represents philanthropy. And who else did I forget? And Patrick, where is Mr. Madhar? He represents the people living with cancer. He's actually representing the people who have had the experiences, the lived experiences. Mr. Madhagu also in the board. So as you can see, the board is put together to represent the cross-sector. And you can also say that Marianne is representing private sector. Marianne is also the CEO of Hako Industries. So she's representing the private sector, which is on that other side of the society. So that's the team. I would like to ask the team of the Secretariat to stand, because the short history of this summit is that this was not a government mandate. This was a decision of the board and management. When we met as a new constituted board, we did receive the National Task Force report, which the Minister of Health spoke about yesterday, the Cabinet Secretary, which was a creation of the Ministry of Health saying, there is so much going on in cancer, but we don't have a coordinated framework. We need to understand what's going on. And the then Cabinet Secretary appointed many people who formed the National Task Force, the National Cancer Task Force. Those people, again, were from across sectors. And when they delivered the National Cancer Task Force report to the Cabinet Secretary, that was then Mutahi Kagwe, after reviewing that, he then officially forwarded that report to the National Cancer Institute to implement, to review the recommendations and guide implementation. That was last year. We then held a meeting, reviewed the report. We were convinced it was solid and robust enough, but then we wanted to have this consultation so that the elements and recommendations that came from that report were also socialized within all the stakeholders who may not have been involved. Many of you may have been involved in the public consultations that happened in development of the task force report. So we then said we must get people together. And we decided to call this a summit, because a summit is really the peak. So whereas the report was given to us, we felt we needed a peak consultation. And that's why we say we need a National Cancer Summit to consult on the elements, and I know in the different groups that recommendations of the report have been held. And this is the result that has led us to this communique. But when we decided to do so, we knew the task was big. It was really big. We didn't know where the money would come from. Many of you who don't work with government might need to know that government has money to build for you the SGR. The government has money to buy for you a PET scan. The government has money to buy you a cyber knife. The government has money to build for you an expressway. But the government has no money to convene meetings. The government has no money for mandazi. The government has no money for lunch. What my friend David D. in one conversation said, the government has no money for small things. And that's the reality. How many of us here work with government? Lift up your hand. You can have money for all your strategies, but if you're to hold one morning consultation, even booking the hotel where that will happen is an impossibility, isn't it? Because that money is not in the vote. So we knew that as a government institution, it's going to be very difficult. So the board and management got together and we approached our partners. We approached our partners and we said, we want you to hold our hand. We want you to bring money. So if any of the partners who sponsor this conference is here, please stand up. Please stand up. If you work, you don't have to be the one we spoke to. If you work with any of the organizations, J&J, Roche, AstraZeneca, KUTRH, NH, or everybody who actually put money, even those who paid for a booth because you enabled this conference to happen, please stand up. Please stand up. These are the people who enabled us to have money for Mandazi. Thank you. Please sit down. We truly appreciate you. Because without you giving that money, it would have been very difficult for us to host this. Of course, the National Cancer Institute, the board, also did approve a vote to supplement your money so that we could host this conference. It wasn't easy to do this. It cost us significant money from our partners and a little money from the taxpayers to ensure that we host this. So I want the management to stand, led by Dr. Karago. Dr. Karago, please stand up. And everybody who is working with the National Cancer Institute. Please give them a big hand. Dr. Karago, other than yourself and Lois Nyanjawa I see here, and Hannah Kagiri, where is Hannah? Hannah might be, where is Hannah? Yes, there is Hannah. We have Dr. Martin Mwangi as well. Do we have somebody else from the, yeah? Kasarani. We have some of them at Kasarani. But let me tell you as they stand, this team is not permanent team for the National Cancer Institute. The National Cancer Institute is in the process of being created. We have an act of parliament. It is last year when the board came, we went to the state corporation and said we need to categorize, because you can imagine since 2012, the institute has never been categorized to be given the rights to hire. I'm being very open because these are public institutions. So we pushed. We are now working with the Public Service Commission to be allowed to hire staff. So this team are all secondees from Ministry of Health. Can you imagine? Please clap for them. Because they actually don't earn money from the National Cancer Institute. They still operate on their salary from the Ministry of Health as secondees from the Ministry of Health. I see Mr. Sabi smiling because he used to be there when they were being seconded. He was the DG. So he knows how difficult this is. So this team, you see here, very lean team, then reached out to stakeholders and said, please come and help us to organize this. Dr. Karago, do we have any of the people who are in your organizing task force who are here represented? If you are in the organizing team that made this summit happen, assisting this very lean team of Karago, Hannah, Lois, Martin, and the others who are not here on the other side, please stand up. Any of you who was in the task force, please give them a big hand. Thank you so much. You may take a seat. Thank you so much, because this summit was organized through blood, tears, and sweat. And when I say tears, it is true. There were tears, Dr. Karago, isn't it? There were tears, yeah? So we drew support from our partners who funded this project. We drew support from stakeholders who came to help us. We drew support from people who had nothing to do with the National Cancer Institute, but people who believed that this was a just cause. Because of that, we got people together, and now we've held a 2-day summit. This explains, Mr. Mapelu, why it was a 2-day summit. Because we didn't have adequate money. We were not even sure we'd be able to pay for the services. But there were believers and believers along the way who actually supported this. And for each one of you who came to a meeting that you had never heard of before, you never heard of the National Cancer Summit before, but you woke up, you spent your money, many of you had to pay participation fee, and come here without actually believing whether it was actually going to happen. I have met people who said, you mean it was going to be this big? So, I want each one of you to clap for yourselves for believing in something you did not know. I'll whisper to you that even the cabinet secretary, when we were discussing about her coming, she was not sure that there would be an adequate meeting that fitted the stature of the cabinet secretary. But because of you, when she came here, she was pleasantly surprised. And you saw that the energy, many of you are here in the opening ceremony, you saw the energy of the cabinet secretary. The cabinet secretary flew in from a meeting in Dar es Salaam, landed at the airport, came through the expressway, straight here, because of faith. Because of faith. and you didn't let us down because you are here. Can you imagine? I have been to a meeting where the president was invited, and then before the president came, the security came and looked around, and there were many empty seats. And they said the president cannot come to this meeting. Do you know what we had to do? We said, okay, give us 1 hour. We sent buses to universities, said, please, please get us students and fill them up in these buses, okay? We were sending money for fuel by M-Pesa. Here, just get a bus. And within no time, we had gotten the meeting. There was no empty seat. You know, when we were all students, when you had there was free food somewhere, you showed up, isn't it? We filled the hall with students, and the president came and found the meeting full. That was the president's government. This meeting, we didn't have to do that, because by the time the cabinet secretary was coming, the governors were coming, there was no sitting space. So I, as chair of the board, and the board and management, we owe each one of you our gratitude for believing in our cause, believing in our dream, and making it a reality. So thank you very, very much. As I come towards the end, because I know people are hungry, I want to say again that cancer and non-communicable diseases are orphaned diseases. They are orphaned diseases. I've worked in the area of global health for a very long time, and now it's very clear in my mind that what drives funding for diseases is not the disease burden. Because if it was indeed the disease burden, cancer would be heavily funded. What drives funding is something we call global health security. What is global health security? Global health security is a simple terminology that says, I want to make sure your disease doesn't infect me. I'll say that again. Global health security is a simple terminology for saying, I want to make sure the disease you have doesn't infect me and my people. Therefore, the higher the risk of your disease infecting me and my people, the more money I'll spend on it. So if you have cancer, it's a personal disease to you. This is the unfortunate reality. You're on your own. If you have diabetes or hypertension, it's personal to you. But if you get Ebola today, you're a global priority. It's the reality. I'm telling you this from my global health experience. I've interacted with WHO, I've been to Geneva, I've been to UN General Assembly, I've dealt with donors, Global Fund, and all of them. This is what underlies funding. That is why over $5.2 billion that come to Africa for health, a lot of that money goes to what? HIV, TB, and malaria. But the other place it goes is childhood vaccination. Measles, polio, and all the other diseases that we vaccinate our children for. And in one meeting I said this and I was told, oh, but we are funding maternal health. Do you know why maternal health is heavily funded? It's because mothers have to take children for vaccination. It is a reality that you can't finance childhood vaccination without supporting maternal health. This is the background for NCDs being orphaned because they're individual diseases. But we have partners in this area who are people in industry. This is why you find that a lot of our cancer work, hypertension, diabetes, is funded by industry. Because industry, luckily, has an interest in uncommunicable diseases. They have an interest for access for their medicines, isn't it? Because if you see it and you do research and development, but then you're not able to find patients, you're not able to create awareness, reach more people so that actually your research and development can work and save lives, then why are you doing research and development? So you will find that our biggest friends in non-communicable diseases, and you must accept this and we must embrace them, is the pharmaceutical industry. Okay? And we must not see them as profiteers. We must see them as the only partners we have in fighting non-communicable diseases together with government for now. And if you look at the top funders of this summit, it's our friends in the pharmaceutical industry. We must embrace them. So please clap for those friends, because they are the only ones who actually have found an interest in funding this area. In global health development, what we call organized development aid, only 2% of that money goes to non-communicable diseases. 2%. Yet cancer is rising. In the next 20 years, cancer, diabetes, hypertension will be the biggest killers. But we are not going, and I want to tell you now, you're not going to receive $1 billion from anybody to turn back the tide on cancer. You won't. But COVID will get trillions of dollars because it affects global health security. This is the reality. Why am I saying this? That this summit is about coming together. This summit is about realizing that the burden of cancer is on us. The people who are going to resolve the issue on cancer is the people in this room, and the people in this room by heart. Because there are people who should have been here, but they are not here because they are far, so we are not excluding them, and the others who joined us online. It is us who are going to solve the burden of cancer. It is us who are going to work together through our resources, our community resources, to solve the burden of cancer. It is us who are going to activate our groups in the villages, in the communities. It is the chief who was here in one of the panels in the morning who are going to resolve the issue of cancer. It is us who have to go out there and tell people, please stop feeding your children sugar, because you are going to result in childhood obesity, and out of childhood obesity will be cardiovascular diseases, and you'll be a higher risk of cancer. It is us who have to go back and tell the people, please go back to the traditional foods. It is us who have to tell people, please stop smoking. It is us who have to tell people, reduce the consumption of alcohol. It is us who have to activate for the government to increase allocation to cancer from 2%, 0.5% actually, of our total health budget. Only 0.5% of our total health budget goes to cancer. 0.5. So you can calculate, out of the total, we spend about, now if I add it together, maybe we are about $250 billion a year, when you add county money and national government money. Out of that $250 billion, calculate how much is allocated to cancer care and treatment. I'm glad NHIF is coming through to help. And we must encourage the changes the CS talked about here to reform NHIF to take care of all of us. So the burden I'm placing on you at this closing ceremony is, as you leave here, be the warrior. Be the warrior. To activate for better policies, to activate for multi-sectoral action, bring out agriculture, environment, veterinary, everyone, to activate for better community, national government, county government allocation of resources, to look at patient navigation and say, who is it that's going to help us, to bring in community health workers, because I can assure you, nobody from outside is actually going to put in money for cancer control. And the ambassador of the US was here, and they are supporting us technically, but they are not going to bring money for drugs, I can assure you. They'll do technical assistance, and we are really glad for their technical assistance through the US National Cancer Institute. But money for drugs will have to come from domestic resources. That is a guarantee, and I'll tell you that again and again. So, as we look at this communique, I want to urge each one of you to go give it a keen eye. We know, of course, when you're drafting documents like this, everyone wants their area to be mentioned, so we will not achieve consensus, but we'll achieve alignment. We'll achieve alignment. So I want to thank you most sincerely. Please make sure you participate by going to that code and giving your thumbs up, endorse the process. Then go look at the document, and if you have a major contribution, make the contribution. We hope that in another 2 weeks, Dr. Karago, are we giving Mildred a week, 2 weeks? 1 week. In 1 week, have a look, give your comments. The technical team will look at it. Of course, we are going to work with KENCO as well. We'll work with the Council of Governors, the Ministry of Health, and we finally then can release a communique. But generally, the areas that have been announced here, have been talked about, are the key areas that we'll be talking about and we need to focus on. Let us re-engineer. Let us target to flip the success rate for cancer. Now we know the chance that somebody diagnosed with cancer will die is 70%. That's what we have. I want us to work together to change that. And 70% becomes our survival rate. Can we work to achieve 70% survival? How many of you are committed to drive towards getting to 70% survival? Lift up your hand. That is our declaration at this closing ceremony. I thank you all. God bless you. For God and my country, I thank you. Thank you. So I'll now hand back over to our excellent moderator, facilitator for these 2 days. Please give her a big hand. Thank you so much. Thank you so much for having led us through these 2 days. Thank you.
Thank you very much, Mr. Chairman. We should have taken a picture as we are shaking hands. No, I'm just kidding. It was a joke. No, it's fine.
The media left.
Oh, what am I? Yeah, all right. But thank you, Chair. I think Chair deserves a better hand clap, doesn't he? Chairman, yesterday we learnt a new Dholuo word, and allow me to take that as my take home. And we were told Marwa. And we're told Marwa means this is ours, isn't it? And so that 70% conversion is ours. So that's our big takeout for today. And then I received a request. If kindly Chair and CEO and the board could take a picture with the survivors. Do we have any survivors in the room here with us? Oh, my lovely mother. Okay, please come on stage. I've been asked if we can take a picture with you and the board and the CEO. This is the inaugural Cancer Summit. You know, we must make the memory out of it. So if you're a cancer survivor, please come on stage. We'll take a nice picture with the board. Usitoe mask. Sawa mam, usitoe mask. All right, the table is being moved out. Who's the main cameraman? Here. You? Okay. We'll all share. We'll all share.
Some of them, especially the leaders, can sit on the chairs.
Yeah. Can we have the 3 chairs in front, and 1 chair will be for the chairman, the other chair will be for... Oh, you want them to sit down? Yeah, I think because of the camera, we want you to sit. We'll put 3 seats here, 1 for you, 1 for the CEO, and 1 for Lucy. And then we can all arrange ourselves behind. Is that okay? Yes. Because of this stage? All right. So if you know you're tall, Karuse. Yes, the chairs are coming. I think our photographer has a different opinion. Oh. So ladies and gentlemen, I think our 70% is changing, isn't it? All these ladies and gentlemen, okay, have beat cancer, yes. Okay. Cameraman, if they sit down here, will they be seen?
They should not sit
all
wide.
Oh. Can we get a chair for the chairman, please? Because we need you to sit.
Let him sit.
Yes, Chairman. It's a strong message you're sending when you sit. Thank you, Chair. All right. Do we need that rostrum there? Is it blocking you? Does it need to go? Oh, yes, please. So some people cannot be seen. Please make sure you can. No, we need one big. It can work. It can work. So I need some people to move down and stand behind Dr. Karago, please, because we cannot see you. No, you stand. You're fine. You're fine. Can we form a second line behind Dr. Karago? Please move down. Madam Patience, please move down. A little bit, yes. This way, this way. Yes, that way. Next to Mildred, exactly. All right. The lady at the back with spectacles, yes. Switch with the lady in front of you because you're shorter than her. Right? And you too as well, ma'am. You too, yes. Switch, switch. We want you to breathe, eh? So just switch. Okay, I need to see every face. So there's a beautiful mom. Oh, mom, we can't see you, ma'am. Oh, come. Come round, ma'am. All right, that's fine. Come. No, we cannot see you. And we need to see your beautiful smile. Yes. All right, so this is such a beautiful picture. Camera guys, can you see everybody? All right, so make sure you're looking center, eh? You know those pictures where when you see all eyes were facing different directions? This one, I need you to all look at him, and he's telling me to get out. Okay, I've gotten out. All right, so please look at him and listen to my count. Give him your biggest smile so that, you know, when you see this picture, you're also happy with yourself. Okay, so in 3, 2, we'll all say taking action. All right, 1, taking. Nice. Camera guys, did we get that one? Excellent. Thank you very much. You may take your seats. My papers have disappeared. All right, I had a set of papers, I had written some things, some announcements, and I think they've disappeared. All right. So the last announcement that I want to bring to us, actually 2. One is about your lunch. There's no lunch today. I'm just kidding. All right, of course there is lunch. We have to have our last meal together today. And allow me to recognize Dr. Jogona. Dr. Jogona, did I get it? Dr. Jogona representing the PS Livestock. All right, thank you, Mom. She has been with us since yesterday, so thank you for joining us. So regarding your lunch, the vouchers are available. The way you picked them yesterday is the way you will pick them today, all right? So that's regarding lunch. Tomorrow, we meet, what's the date tomorrow? Exactly. What happens on 4th? It's the? Okay, I know we are hungry, but we can shout a little. Okay, what's the celebration tomorrow? World Cancer Day. Excellent. And so we are all going to congregate at the Kasarani Police Station at 8 a.m. So yesterday we gave you a very beautiful bag. Yeah? Inside there was a nice t-shirt, right? There's a nice cap. So those ones, before you think of taking them to the village. Yeah? Tomorrow, that's what we are wearing. So those nice white shirts, t-shirts that you got, your nice cape that you got. So come with it tomorrow and let's congregate at Kasarani Police Station at 8 a.m. All right? Then come with nice walking shoes because we are going to walk from there and then walk all the way to Kasarani Primary School. I'm told it's only 1 kilometer away, so it's not too far. And then right there we're going to unveil the cancer ambassadors, right? And also there'll be a lot of free screening as well and a lot of celebrations, and we need you to be part of our celebrations. If you guys are not there, then we don't have a celebration, all right? So tomorrow you can even come with your children, I think. Yeah? Yeah, Panelists, come with everybody. Everybody you have your weekend with, come with them. You're very well catered for, and we're going to see you tomorrow and commemorate the World Cancer Day tomorrow. So thank you all for being such great delegates. You're hungry, I'm hungry, we all need to go, right? But make sure you network, you get a contact of someone, and I think Chair told us that next year we're going to be here as well, right? Yes, right, Chair? Chair promised. So deep, those nice sponsors, it's okay. Now add us to your budget. You know you had not added us. Now we are a budget item. All right, so thank you, everybody. Do have a good afternoon, and enjoy your lunch.
The cancer burden is rising globally, exerting significant strain on populations and health systems at all income levels. In Kenya, cancer is the third leading cause of death after infectious and cardiovascular diseases. The International Agency for Research in Cancer, IARC Globocan report for 2020 estimated 42,000 new cases of cancer annually with a mortality of 27,000. It is sad to note that 70 to 80% of cancer patients in Kenya are diagnosed with advanced disease when it is not amenable to cure. Cancer is a critical global health and human issue. At random, we asked Kenyans if they know what is cancer, what causes it, and how to prevent yourself from getting it.
I think hiyo mambo ya cancer, kitu naweza muelezea tu ni kitu chache kenye najua. Kama hizi kula chakula kuna mandawa, hiyo tu ndio naweza jua. Tuseme kama hizi mboga mimi nauza hapa, niende nininunue nini ziko na dawa, unajua ni kuuzia watu ama mimi nikule, hiyo ni kitu inaweza niletea mambo ya kansa.
Kulingana vile naelewa, kansa ni mahali ambapo seli za mwili zinafaa kuwa zikikufa, zinafaa kuwa replaced, zinaanza kugrow tena.
Najua kansa iko, but sijui kansa inaletwa na nini, na sijui dawa yake ni gani. Juu watu wengi naona wakiaga kansa, sasa sijui inaletwa na nini. At least kama mnaweza ni explainia naweza jua hata pia mimi.
Cancer, from the basic knowledge that I have, is the growth of cells, abnormal growth of cells.
Ni vimelea ambavyo vinakuja kwa mwili ambavyo havijatarajiwa.
Okay, kitu ya kwanza, cancer is viral. Ni viral, meaning inakuwa caused na virus.
Cancer ni chembe zenye zinaingianga kwa mwili, inaanza kubehave funny. Maybe uvimbe ama inaleta shida tu kwa part moja ya mwili.
Cancer mimi kulingana vile najua cancer ni ugonjwa deadly. It's a deadly disease. Though mostly huwezi jua vile inakuja. Yeah.
Mimi na understand cancer ni kama lump ama kama ka growth maybe in any part of the body, na hiyo growth ina affect tuseme health yako.
Cancer ni kulingana na mimi ninaelewa cancer ni kama kidonda ina develop somewhere. Sema ziko tofauti, areas tofauti. Yeah.
Cancer. Mimi naelewa cancer. There are different types of cancer. Kuna colonial cancer mimi najua. Kuna mbungero alikufa na hiyo colonial pneumococc. Kuna cervical cancer, kuna lung cancer. But kile na cause sijajua.
Cancer is basically ugonjwa yenye inasababishwa na ukosefu wa mazoezi mwilini.
My understanding of cancer, it is a disease, just like many other diseases. There are many causes of cancer, I would say.
To my understanding, cancer is just like a disease, like any other disease. But sometimes people, they don't take cancer like a disease. Some take it like a witchcraft. and they related it to curses, which is not true. And they stay with it, and they don't take time to go to the hospital to be treated in the right time, and they start looking for other treatments, and they end up dying because they don't want to understand that cancer is like any other disease, and when treated early, a person can be cured.
What is cancer? What causes it? And how to prevent yourself from getting it?
Cancer is basically a disease where abnormal cells start growing uncontrollably. They invade normal surrounding tissue, and they have the ability and the capacity to spread to other tissues. That's a simple definition of cancer. And cancers, we broadly classify them into two. We have what we call solid tumors and hematological tumors. Hematological tumors are tumors that arise from blood, like lymphomas, leukemias, cancer we call multiple myeloma. Then all the rest, such as cancers of the breast, the colon, the brain, the skin, those are what we call solid tumors. We don't know what causes cancers, other than cancer of the cervix, where the human papillomavirus or HPV has been identified as a cause. Most of the other cancers, we really do not know. We just talk about the risk factors, because a person may have no risk factors but they develop cancer, or they may have multiple risk factors and then they don't develop cancer.
Breast, cervical, prostate, or esophagus, and non-Hodgkin's lymphoma are the leading types of new cancer cases in both males and females across all ages. Cervical cancer being the leading cause of cancer deaths, followed by breast cancer and then esophageal cancer. Although risk factors influence the development of cancer, most do not directly cause cancer. Some people with several risk factors never develop cancer, while others with no known risk factors do. However, knowing your risk factors may help you make more informed lifestyle and healthcare choices.
The new Kenyatta University Teaching, Referral and Research Hospital is the boldest, most sophisticated health facility initiative ever undertaken in Kiambu County and Kenya.
So today is truly a historic day. We are gathered here to witness yet another bold step as we as a nation inch closer towards the national rollout of universal health coverage. And I'm therefore deeply pleased to join all of you today to commission this hospital, the Kenyatta University Teaching, Referral and Research Hospital.
A project that has created a global health center that ensures Kenya and the region has world-class facilities that cut across the entire health arena to serve generations and contribute significantly to the Kenya Big Four agenda, specifically universal healthcare for all and the global sustainable development goals.
The hospital has continued to be an amazing development in this sector, specifically because of the new ways in which it adopted in terms of policy, in terms of treatment and general healthcare improvement and reform.
Kenyatta University Teaching, Referral and Research Hospital is a 650-bed capacity hospital with state-of-the-art medical equipment.
It is one of the iconic referral hospitals within the Ministry of Health and even for this country. And we say that because it is a modern hospital, it has been built and equipped with the latest technologies that are available globally.
The hospital is located on a 100-acre piece of land that lies in the northwestern part of Kenyatta University, bordering Kahawa Barracks to the south and the Northern Bypass Road to the east. The main entrance to the hospital is on the Northern Bypass Road near Kahawa West. It is easily accessible from main roads and public transport services. The hospital also has a helipad, a landing strip to enhance access. Following the preparatory phase of design and preparation jointly carried out by China Jiangxi Corporation and Kenyatta University, groundbreaking was undertaken in 2011 with the objective of providing a world-class healthcare in Kenya and the region. Kenyatta University Teaching, Referral and Research Hospital was the brainchild of Professor Olive Mugenda, who initiated the preparation of the proposal and leading her team from Kenyatta University in making a case for the hospital through the Minister for Finance, who is now the current president, President Uhuru Kenyatta. The government approved a government-to-government loan from China Exim Bank for construction and equipping of the hospital. The hospital was constructed and equipped at a cost of 8 billion Kenya shillings.
I'm very delighted to see a vision that we started 10 years ago being actualized and saving lives, particularly at this time of COVID-19 pandemic.
It was the founder's vision to establish a world-class healthcare facility which will reduce to the barest minimum traveling out of Kenya for medical care abroad and at the same time attract medical tourism from other countries in Africa. Our vision is to be a premier national referral hospital renowned for clinical excellence, medical training and research that enhances quality of lives for Kenyans and the regional citizens. Our mission is to enhance quality of lives through provision of quality, patient-centered and evidence-based healthcare, training, innovation and state-of-the-art technology. Built and benchmarked with international standards to provide world-class healthcare. It is headed by a team of dedicated, experienced and qualified doctors supported by a professional cadre of trained nurses and paramedic staff. KUTRRH houses advanced and sophisticated clinical and surgical facilities, providing comprehensive care to address all aspects of health, from prevention to diagnostic and treatment to rehabilitation. Deliberately and carefully built in the fabric of KUTRRH is quality. The KUTRRH Board of Directors is responsible for the management and administration of the hospital. The major directorates of the hospital are Clinical Services, Nursing Services, Corporate Services and Administration, Finance Strategy and Planning, Training, Research and Innovations. At KUTRRH, we believe quality is never an accident, but a premeditated effort. The hospital is among few in the region to function with full-time doctors system that assures doctors' availability around the clock, giving dedicated time and attention to patients.
We mainly deal with offering clinical services and ensuring that all patients are treated accordingly. My division is very wide and it encompasses a lot of various disciplines, majorly of which is oncology services, accident and emergency, trauma and orthopedics, where we are able to perform surgeries. We have a fully established pharmacy, which is able to provide nearly all kinds of drugs. In terms of laboratory, the whole pathology area, we have a well-equipped laboratory. We are able to do state-of-the-art tests.
The highly sophisticated medical center shall offer quality medical care within the following units: outpatients, accidents and emergency, pharmacy and diagnostic imaging, inpatient services, pathology and lab medicine, critical care, medical and surgical, special internal medicine, oncology, renal and neurology, obstetrics and gynecological services. Oncology Cancer Unit. The ultra-modern oncology unit is a beacon of hope, health and happiness.
Our flagship project is Oncology Center, where we are dealing with cases of cancer. And we are undertaking very good services in radiotherapy and also radiology treatment with great outcomes.
The team of oncology specialists work together to develop individualized treatment plan for every patient with great results.
This team consists of the oncologists, the surgeons, the palliative nurses, our nutritionists, physiotherapy, the pathologist, and our oncology nurses. And once a week we have this meeting, the multidisciplinary team meeting, where we discuss the management of all the patients who were seen in the previous week, so that we can make the treatment of every patient a focused and patient-centered treatment to target the specific needs of every patient.
We offer cancer care services across surgical, radiation, and medical oncology. Every unit is equipped to treat every type of procedure, including trauma and surgeries. The ultra-modern laboratories are equally proficient to delivering high standards of services.
If you look at the infrastructure around this hospital and you look at the keen interest that the government has, if you look at the keen interest that our Cabinet Secretary of Health has in this hospital, and if you look at the need in the market, in the region, and even in the locality for this hospital, it's very clear that if we get our act right, this is going to be a hospital that is a game changer in the region.
Kenyatta University Teaching, Referral and Research Hospital has continued to embark on projects aimed at providing quality healthcare. The ongoing projects include the construction of furnished hostels and apartments that shall provide accommodation within the hospital premises to patients and their families while undergoing prolonged treatment. An important ongoing project is the construction of the Integrated Molecular Imaging Center, IMIC.
We also today had the pleasure of laying the foundation stone for the soon-to-be Integrated Molecular Imaging Center. The hospital is beginning construction. The center will host a cyclotron machine, a PET and CT scanners. We have also laid the foundation stone for this hospital's hospitality center, which will cater for the accommodation and hospitality needs of patients and their families. the impressive equipment, infrastructure, broad services, service range, and highly trained staff,